The first and the foremost topic that we'll be studying today is about ear, the anatomy, the embryology, and the development of ear. As we all know, ear is a very intricate structure and hence is its development. Entire ear coming from external, middle and inner ear develops from ectoderm, mesoderm as well as endoderm. Now coming to pinna, coming to the first part, the anterior helix and tragus, these develop from the first pharyngeal arch. Now coming to the rest of the pinna, they develop from the second arch. Now this first arch and second arch develop through the hillocks of His. So what are these hillocks of His? These are nothing but the mesodermal thickenings which give rise to the first and second arch. Now coming to the external auditory canal. So a lot of students have a very common confusion, that is, what is external auditory canal and what is external auditory meatus. So is it same or is it different? So I'm going to clear this confusion once and for all. So external auditory canal is nothing but a canal or a tubular thing that is going to lead you to the tympanic membrane. So this part is nothing but the external auditory canal. But from pinna, you have an opening that will lead into external auditory canal, which is nothing but the external auditory meatus. So the development of the external auditory canal, it happens from the first pharyngeal cleft. Whereas the development of the external auditory meatus, which is nothing but part of the pinna, happens from the first pharyngeal arch. Got it? Now coming to the middle ear cleft. So middle ear cleft is a structure which is formed from various components like that of middle ear cavity. Then there is a additus which is going to lead into the mastoid antrum. So these three structures along with eustachian tube forms nothing but middle ear cleft. And the development of middle ear cleft happens from the first pharyngeal pouch. So this first pharyngeal pouch is also called as tubotympanic recess. Now coming to the ossicles. The first ossicle malleus and the second ossicle incus develops again from the first arch. The first pharyngeal arch gave rise to malleus and incus. Now coming to stapes, we have two parts in stapes. That is, we have a stapes suprastructure and we also have the footplate. So the stapes suprastructure develops from the second arch, whereas the footplate of the stapes develops from the otic capsule. Now coming to the stapes again. So if you look into this image, you can see that both the horns and the neck as well as the base, all these, both the crura, the neck and the base, all these comprises the stapes suprastructure. And as I said, this is going to develop from the second pharyngeal arch. Whereas the footplate of the stapes, this footplate is going to rest on the oval window and the oval window is going to lead to the scala vestibuli. So this develops from the bony labyrinth. Which part of bony labyrinth? From the otic capsule. Got it? Now coming to the structure of pinna, we need to always remember that if you have a structure, you always have an opposite structure. For example, if you have helix, you have antihelix. If you have tragus, you have antitragus. Now coming to the structure of pinna proper, as you can see, the first structure is nothing but tragus. This structure here is nothing but tragus. Above tragus, you have the helix. So this part where I'm showing with the arrow upwards is nothing but the anterior helix. And then you also have the rest of the helix, which can also be called as the posterior helix. Now, under the helix parallelly, you also have an antihelix. The structure that I'm marking now is nothing but the antihelix. Okay. Now, we also have a bigger depression, which is shown by blue color arrow. This is nothing but concha. Above this, you also have one more depression, which is called as Simba concha. Now, Simba concha is a cartilaginous landmark for mastoid antrum. Okay. Now, apart from this, you can also see the external auditory canal here. And then you have the lobule. So, what is lobule? It is the lowermost part of the ear, which is devoid of cartilage. You do not have any cartilage here. It is fatty and this is nothing but lobule. Now, in the initial part, I told there is something called as tragus, right? There is also antitragus. So, which is the antitragus? This is nothing but the antitragus. Now, apart from all these, there is also one more important structure that you have to know of, which is nothing but the incisura terminalis. So, what is incisura terminalis? This is nothing but the area located between the tragus and between the helix. This area is nothing but the incisura terminalis. There is a particular type of incision which is very important, and that is when incisura comes into picture. We will be looking into it in the further discussion. Now coming to the next part. We are going to look into the various congenital anomalies of the ear. The pinna, there are a lot of congenital anomalies, and when a patient walks into you, by looking at the shape of the pinna, you can name this congenital anomalies. There are different types. We have anosia, we have microtia, we have lop ear, bat ear. We are going to look into all of these in detail. Okay. There is also some other anomaly which is called as preauricular sinus. So what is preauricular sinus? As you all know, what is sinus? Sinus is nothing but a small opening. Okay. So preauricular sinus, it develops because of the fusion defect between the auricular tubercles. Why is there a fusion defect? There is no proper fusion between the first and the second pharyngeal arch structures which are formed by the hillock of His, because of which there is going to be a small opening, and when this opening gets infected, there is going to be discharge. There is on and off discharge which is troublesome for the patient. That's why they come to meet you. And how do you treat it? Complete excision of the sinus tract is going to be done. And where is the most common site? It is nothing but at the root of the helix. Okay. Now coming to microtia. As the name suggests, micro. What is micro? Small. That is nothing but malformed or underdeveloped ear. When there is underdevelopment of the ear, it is called as microtia. Now coming to anosia. The word A, whenever there is a word A in the beginning of any word, it means no. So in anosia means there is no ear. There is failure in the development of the ear. That is called as anosia. Now, if a patient comes to you with microtia, small ear, or anosia, no ear, what is the treatment that you're going to give to that patient? You can do something called as pinna reconstruction. So what is pinna reconstruction? You're trying to artificially build a ear to this patient. So this procedure is called as pinnaplasty. You're going to build pinna, so it is pinnaplasty. Now, as you all know, ear is called as, the study of ear is otology. Oto, no? So pinnaplasty is also called as otoplasty. Now to construct ear, you need a graft, no? So from where are you going to take a graft? You know that the external part, the pinna, is cartilage. So you are going to take cartilage from body. So where are you getting this cartilage from? You're going to get it from the rib cartilage. So what is the age that you have to wait for before you do a pinnaplasty? The minimum age is 6 years. So why do you have to wait till 6 years? Because the costal cartilage completely developed by this age. Therefore, you are going to start the procedure at 6 years of age. Now coming to Baha. What is Baha? Baha is nothing but bone anchored hearing aid. So when do you use Baha? Whenever there is a external ear deformity. That is when you are going to suggest the patient for Baha. So whenever you have to give the patient some hearing aid, the ear has to be patent, the canal has to be patent so that you can put the hearing aid. But if the patient doesn't have ear only, when the patient has underdeveloped ear, microtia, or no ear like anosia, where are you going to place the device? You can't, right? That is why you're going to give a device which will be anchored to the bone. Bone anchored hearing device. And even in patients who cannot afford surgery, like cochlear implant is a very expensive surgery, even in those people, you can suggest Baha, bone anchored hearing aid. Now coming to the different congenital anomalies of the pinna, as I told you, the first picture that you can see here is nothing but anosia. So what is anosia? Anosia means it is absent ear. The patient does not have ear. You can see in this image, no, there is no ear. Now coming to the second one, it is bat ear. What do you mean by bat ear? Bat ear means the upper part of the ear is more protruded, or it is more prominent. If you look at the image here, you can see that the upper third of the pinna is protruded out. So I know most of you would have watched this movie of Amir Khan, right? PK movie. So what is very peculiar in that character? You can see that Amir Khan's ear is very protruded. No, it is nothing but bat ear. The upper outer 1/3 is protruded and prominent. Coming to the third one, we have this ear called as lop ear. What is the meaning of lop ear? Here also we are dealing with something which affects the upper part of the pinna. Here the upper part of the pinna protrudes and falls. Like if you have seen goats, no? How are the ears of the goat? It is up and falling. So this is nothing but lop ear. Then we have microtia. As I told you, it is nothing but underdeveloped ear. Then we have cup ear. What do you understand by cup ear? It is nothing but contracted ear. It is called as cup ear, like the shape of a cup. Then we have something called as cryptotia. If you see in this image here, cryptotia means again the upper third of the ear is buried or hidden under the side of the head. So you are going to see only the lower part of the ear which is prominent, whereas the upper part is hidden. This is called as cryptotia. Now coming to one more topic. We'll look at certain external auditory canal abnormalities, and the first one that we want to see now is a meatal atresia. So what do you understand by the term atresia? There is going to be constriction or narrowing of the meatus. So the definition goes like this. There is going to be atresia or underdevelopment, narrowing of the external auditory canal or the external auditory meatus. Now, how do you manage this? There is going to be narrowing. So, you are going to do something so that the entire canal becomes more patulous, becomes more patent. So, you are going to surgically correct it, and it is called as meatoplasty. Now, when does this hold significance? So, imagine you're sitting in your OPD and a patient comes to you and the patient says that, "Doctor, I go to multiple ENT specialists just to get my ear canal cleaned, but once in a month or once in 2 months, it gets blocked so often, I can't hear, there is excess pain." When you examine, you find that in the external auditory canal, there is not enough space. It is very narrow. That is why a lot of bags get jammed. So, to give him a complete permanent solution, you are going to do a meatoplasty where you are going to widen the external auditory canal. This is number one. What is number two? You do a radical mastoidectomy or a modified radical mastoidectomy where you remove the posterior wall. And after you remove the posterior wall, it is going to be a wide mastoid cavity. When you have a wide cavity, the entire things have to drain from a wide canal, right? If you keep a narrow canal, all the waste that is secreted there, waste that is collected there can't drain outside. So for it to drain, you are going to do meatoplasty so that the canal is wide and the disease-free ear is given to the patient. Now coming to second condition, we have caloral fistula. So what is caloral fistula? It is an opening that is seen which has two openings, one in the external auditory canal and one in the neck region. Okay, so there has to be persistence of some structure because of which this fistula forms. So what is that structure which persists? It's nothing but the ventral part of the pharyngeal cleft. Normally what happens in the pharyngeal cleft, the ventral part is going to disappear as the development of the person takes place. But if the ventral part of this cleft persists, it is going to form a caloral fistula. Now tell me fast, pharyngeal cleft. The first pharyngeal cleft gives rise to which structure in the ear? It is external auditory canal. So there are two openings. The external opening is located in the neck. Where exactly in the neck? Between the mandible and the muscle. Which muscle? Sternocleidomastoid muscle. Now coming to the internal opening. This internal opening is there in the floor of the external auditory canal. Got it? Now let's draw a man's face to understand this properly. Okay. So this is a man and this is his ear. Okay. Now we are going to mark the two openings. One, as I told you, the internal opening seen in the floor of the external auditory canal. So this structure that I am marking with orange is the first opening, which is nothing but the internal opening. Then we have the muscle. Which is the muscle? It is nothing but the sternocleidomastoid muscle. Now, between the sternocleidomastoid and mandible, you have one more opening, which is nothing but the external opening. Got it? Now, what is the clinical significance? You know that this is the same area where the facial nerve branches out to give last terminal 5 branches called as pes anserinus. So, whenever there is a surgery in this area, the surgeon has to be extremely careful, because when the patient comes to you with fistula when it is infected, his main complaint will be, doctor, I have lot of ear discharge. The discharge is coming from an opening near my ear. Now, you operate and finally if the patient ends up in facial palsy, it is because the facial nerve is there. No, he's going to ask you, doctor, I just had ear discharge. Now my face shape is gone. So the doctor has to be extremely careful about the facial nerve, because the facial nerve branches are in vicinity of the structure. Now, how do you manage if there is any infection? You have to do complete excision of this tract. That is when you give them discharge-free ear. Okay. Now, coming to the next structure, we'll be looking into the development of the tympanic membrane. Remember, tympanic membrane is one structure which develops from all the 3 germ layers. What are the 3 germ layers? Ectoderm, mesoderm and endoderm. So, the tympanic membrane has 3 components, okay. So, what are the 3 components? We have the outer layer. Outer layer is nothing but the epithelial layer which develops from the ectoderm. Then we also have the middle layer. Middle layer is nothing but the fibrous layer. It is most toughest or the strongest layer among the 3 layers of the tympanic membrane. It develops from the mesoderm. Remember, when there is any perforation, if secondary healing of tympanic membrane takes place, only the outer epithelial and inner mucosal layer is going to heal. But the fibrous layer is not going to heal. That is why the secondary tympanic membrane that is formed is going to be a very weak tympanic membrane. The inner layer, which is mucosal, is formed by the endoderm. Now, coming to the mastoid and the temporal bone anatomy. As you all know, mastoid has 2 parts, that is nothing but the superficial component and a deep component. Now, we'll look at from where do these components develop. Coming to the temporal bone, it is a bone which is there in this part. The temple area is called as temporal bone and it has 2 parts. That is, it has the squamous part, which is called as squamous temporal bone, and it also has a petrous part. Petrous part is nothing but the deep part of the temporal bone. So, this squamosal part of the temporal bone is going to give rise to the superficial part of the mastoid. And then, the petrous part is going to give rise to the deep part of the mastoid. How do you remember it? S for S, squamosal gives rise to superficial part of the mastoid bone. Now, what you have to remember here is that in between the fusion of these 2 parts, there is a corner septum that is there. So, usually what happens when the surgeon tries to drill the mastoid, in order to clear all the disease, he has to reach a structure called as mastoid antrum, which is nothing but the most prominent and consistent mastoid air cell. Remember, this mastoid antrum is always 1.5 centimeter deeper from the surface. So, while drilling, if the surgeon at 0.5 centimeter, 0.6 centimeter gets a obstruction, it is not the wall that he has reached or not the antrum that he has reached. It is nothing but the corner septum, and the mastoid antrum is always beneath it. If he stops surgery there, it results in improper clearance of disease. Got it? Now, coming to the inner ear development. So, inner ear development happens from the otic capsule. Now, tell me, initially when we looked into development of ear, there was also one more structure, one more ossicle which developed from otic capsule. Which one is that? That is nothing but foot plate of stapes. Now, coming to the inner ear, first let's draw an image to understand it. So, we have the 3 semicircular canals, 1, 2 and 3. That is nothing but the posterior semicircular canal. We have the superior semicircular canal and we also have the horizontal semicircular canal. Now, all these canals open into one more structure which is called as utricle. Next, there is one more structure which is called as saccule. Finally, it leads to one more structure which is called as cochlea. Now, between the utricle and saccule, we also have a duct which is called as utriculosaccular duct, which further gives rise to the endolymphatic sac. So, this is roughly the structure of the inner ear. Now, the superior part of the structure and the inferior part of the structure have different origins. So, what are the different origins? let us draw a line bifurcating these two structures. Okay, so everything above this line is going to be derived from the pars superior, and everything below this is going to be derived from pars inferior. So, now tell me, what are the structures that are derived from pars superior? These are nothing but the semicircular canals. Which are the semicircular canals? Posterior semicircular canal, superior semicircular canal, and the horizontal semicircular canal. Then we have the utriculo-saccular duct. Then we have the endolymphatic sac. So, 4 structures comes from the pars superior. Now, from the pars inferior, we have only 2 structures. What are the structures? They are nothing but the saccule and the cochlea. Okay. Now, apart from this, you should also know about certain developmental anomalies in the inner ear. So, what are these developmental anomalies? Number 1 is called as Michael's aplasia. Michael Jackson is dead. Michael's aplasia, entire inner ear is not found. This is called as Michael's aplasia. Number 2, Alexander's aplasia. What happens in Alexander's aplasia? If this is the structure of the cochlea, we know that this is the apex of the cochlea and this is the base of the cochlea, and these are the various turns of the cochlea. Remember, in Alexander's, this A for A, Alexander for apex, apex is going to be spared. So, we have the structure, whereas the base is going to be absent. Base, as you all know, base, there is high frequency sounds that are heard from this structure. So, because base is not there, high frequency hearing is affected. Coming to the third one, Mondini's. When there is Mondini's aplasia, there is going to be only 1.5 turns in the cochlea. And the final one called as Sheep's aplasia, where as the name suggests, it's Sheep's, no? It is SCHIEBS. So, SNC, the saccule and the cochlea is going to be absent. As the name suggests, you have SNC in the first word, so saccule and cochlea is going to be absent. So, these 4 are the main abnormalities that you have to know in the development of the inner ear. Now, coming to the anatomy of the external auditory canal, we need to know that external auditory canal comprises of a bony part and a cartilaginous part. Okay. Now, let's all go back to our school days and revise 8 1s tables. Okay. So, the cartilaginous part, which is nothing but the outer 1/3, comprising mostly the region leading to the pinna, is around 8 mm. Okay. And coming to the bony part, which is nothing but the inner 2/3 of the external auditory canal, is around 16 mm. Okay. So, as I told you, 8 tables. 8 1s are 8, that is nothing but the outer 1/3 cartilaginous part. 8 2s are 16, nothing but the inner 2/3 bony part. And total length, 8 plus 16 is nothing but 24, which is nothing but 8 into 3, right? It is nothing but the entire length of the external auditory canal. Now, what is the direction of the cartilaginous part or the outer part? It is upwards, backwards and medially. Now, what is the direction of the bony part? It is downwards, forwards and medially. Now, coming to the skin. Remember, the skin of the outer as well as inner part is going to be different. The cartilaginous part has thick skin, whereas the bony part has thin skin. Now, coming to the epithelium. Both outer and inner is formed by stratified squamous epithelium. Now, there are going to be certain skin appendages which are found only in the cartilaginous part. So, what are these skin appendages? These are nothing but the sweat glands. We also have the sebaceous glands and we also have the wax forming glands are nothing but the ceruminous glands. Whereas in the bony part, all these glands are going to be absent. Now, there are certain deficiencies that you need to know of. There is number 1 deficiency in the outer part. Okay. So, if this is the external auditory canal and which leads to the ear, this outer part, nothing but the cartilaginous part, is around 1/3, which is 8 mm. Then we have the inner part, which is nothing but 2/3 bony, which is 16 mm. There is a deficiency in the outer part. Okay, there are small holes, deficiencies, which are called as fissure of Santorini. So, why is this important? This is an area from which infection could spread to the parotid gland. So, the ear infection spreads to the parotid gland or vice versa through the fissure of Santorini in the cartilaginous part. Also, there are some fissures or foramens of Huschke in the bony part. So these fissures or foramen of Huschke are going to close by 4 years, and this is where the infection can spread to the skull base. Now, there is a special note that you have to know. The outer cartilaginous part is more mobile and flexible because it is comprising of cartilage, right? Whereas the inner part, which is fixed to bone, is relatively immobile part of the external auditory canal. Now, there is something called as the cartilaginous landmark for the mastoid antrum. What is it? It is nothing but the Simba concha. This is something that we discussed initially, right? There is also a bony landmark. So, what is the bony landmark? Which is nothing but the McEwan's triangle. This McEwan's triangle is also called as suprameatal triangle, and when you drill through this triangle, this bony area, you are going to reach the mastoid antrum when you drill about 1.5 centimeter beneath this triangle. Then you have something called as Lempert's incision. What is Lempert's incision? It is also called as Lempert's end oral incision. Where do you give this incision? You give this incision in the incisura terminalis. So, what is incisura terminalis? If you consider this as your pinna and this as the lobule and this as the tragus, so this arrow is tragus, this arrow is the anterior helix. The area between these both, which I am marking right now, is nothing but the area of the incisura terminalis. If you give an incision here in order to approach the mastoid, then the incision is called as endoral incision of Lempert. Got it? Now, whenever the vagal nerve branch to the ear, which is the vagal nerve branch to the ear? Arnold's nerve. This is going to supply some portion of the external auditory canal. So, whenever as a doctor, when you try to remove wax, you're going to syringe, you're going to put water and flush in all the wax, right? So, when you do this, certain people have a cough reflex, or these people can also have syncope. Syncope is nothing but they faint whenever you put water into their ear. Why that does this happen? Because of the stimulation of the vagal branch, which is nothing but Arnold. Okay. Now, coming to the direction of syringing, what is the direction of the syringing in the external ear? It is nothing but posterior superior direction. Now, let's look into the nerve supply of the external ear. So, there is a very age-old mnemonic that will help you in remembering the nerve supply. There are mainly 5 nerves that supply the pinna or the external ear. So, what are these nerves? The mnemonic goes like this. The mnemonic is nothing but GOA, but with 2 extra A's. So, it is GOAAA. Okay. So, the first word, that is nothing but G, it stands for the greater auricular nerve. So, as the word suggests, great, right? So, it is going to supply the greater part of pinna or maximum of pinna. So, you can see the lateral surface of the pinna in this image. This entire structure, which is shown in purple, is supplied by the greater auricular nerve. It is having root value of C2 and C3. Now, coming to the second word of a mnemonic GOA, which is nothing but O, which is nothing but the occipital or the lesser occipital nerve. Okay. So, where does the lesser occipital nerve supply? As the name suggests, lesser. No? So, lesser part of pinna, that is in the medial side, only the upper aspect is supplied by the lesser occipital nerve and the root value is C2. Now, coming to the third nerve, which is the third nerve. The third nerve is nothing but the auriculotemporal nerve. This auriculotemporal nerve is having root value of V3 and it is derived from the trigeminal nerve. Okay, so the auriculotemporal nerve, this also supplies the backside of the pinna in the lower aspect. So, this is the area. The star mark is the area which is supplied by the auriculotemporal nerve. So, we have 2 more A's. No? So, what are these 2 more A's? One is nothing but the Arnold's branch. So, what is Arnold's branch? This is nothing but the branch from the 10th nerve or the vagus nerve. We also have one more A. It is nothing but the A for auricular branch of the facial nerve. So, this is also going to supply the pinna. So, what are the 5 branches? We have the greater auricular, lesser occipital, auriculotemporal. We also have the Arnold's and the auricular branch of the facial nerve. Do not forget it. This is very, very important. Now, the auriculotemporal nerve, we should also know one extra thing here. It is going to supply the anterior aspect of the external auditory canal and also the roof of the external auditory canal. Whereas, the 7th nerve, that is nothing but the facial nerve and the Arnold's, that is the 10th nerve, is going to supply the floor as well as the posterior part of the external auditory canal. Now, there is one more thing that you have to be very, very careful, cautious about. That is nothing but a sign which is called as Hitzelberger sign. So, this Hitzelberger sign has come in your exams multiple number of times. So, what is this Hitzelberger sign? It is nothing but a named sign which is seen in CP angle tumor. Can you name any CP angle tumor for me? It is nothing but acoustic neuroma. So, whenever there is acoustic neuroma, here the facial nerve is involved. So, when the facial nerve is involved, there is going to be hypoesthesia of the part of the external auditory canal that is supplied by the facial nerve. So, which is that part? Posterior superior part of the external auditory canal. There is going to be hypoesthesia, and this is nothing but Hitzelberger sign. Got it? Now, coming to the next part, we are going to see the anatomy of the tympanic membrane. So, this is one of the initial topics that any UG student studies. So, when we talk about tympanic membrane, what is the color of the tympanic membrane? It is nothing but pearly grey. And the tympanic membrane, as you all know, is a translucent structure. That is, if you see through the tympanic membrane, you're not going to see exactly all the parts of the middle ear as it is. No, there is a shadow. So, it is called as translucent. Now, this tympanic membrane is not at perpendicular to the horizontal. It is at an angle. So, what is the angle? It is 50 degree with the horizontal. Now, what is the effective vibratory area? That is 55 millimeter square. So, what do you understand by effective vibratory area? See, the total area of the tympanic membrane is nothing but 90 mm square. But this entire 90 mm square is not going to vibrate whenever the sound wave hits it. Only the 55 mm square of the tympanic membrane which vibrates constitutes the effective vibratory area of the tympanic membrane. Now, when you see carefully through tympanic membrane, you are going to see certain structures. So, what are the structures that you can see? These are nothing but the bone. Incus is going to be seen. You can also see the incudostapedial joint through the tympanic membrane. You can also see the round window niche. Also, you can see the eustachian tube opening. So, these four are the important structures that can be seen through the tympanic membrane. Now, take your pens and draw this image with me. So, this is a tympanic membrane. So, when we talk about tympanic membrane, you know that there is pars flaccida superiorly and there is pars tensa inferiorly. And these two are the anterior and the posterior malleolar folds, and then you have the malleus. Okay. So, now if you draw a line passing through the both, and if you also draw a line perpendicular to this through the handle of the malleus, you get 4 quadrants. So, which are the 4 quadrants? This is left and this is right. Okay. So, the right side is the anterior, left is the posterior. So, you have the antero-superior quadrant, antero-inferior quadrant, posterior-superior quadrant and the posterior-inferior quadrant. Now, if you draw a horizontal line like this angle between the tympanic membrane and horizontal is nothing but 55 degrees. Got it? Now, let's see the various structures that you can see in each quadrant. The number one structure, that is in the posterior superior, you can see the incus and you can also see the incudostapedial joint. Got it? Now, the second structure, in the posterior inferior quadrant, you can see the round window niche, and in the antero-inferior quadrant, you can see 2 important structures. What are the 2 important structures? You can see the cone of light. Okay, so this is a cone of light, and you can also see an area, a circular area, which is nothing but eustachian tube opening. I agree that you cannot see this structure always, but if there is a large perforation, you can definitely look for eustachian tube opening. Okay, and in anterior superior, there is nothing that is very prominent that can be seen. Now, if you see tympanic membrane, you have to get to know whether it is right side or left side. No. So, how do you get to know whether it is right side or left side? It is by looking into 2 structures. That is a lateral process of malleus and the cone of light. So, where is the lateral process of malleus? So, in this black ink, I am showing a process here. So, this process that I am marking here is nothing but the lateral process of malleus. So, in this tympanic membrane, it is pointing towards the right side. So, this is the right tympanic membrane. Okay. So, this is the lateral process which is helping us identify the side of the TM, and also the cone of light. This is also going to help us identify the side. So this cone of light here is also turning to the right side, right? So this also points that the tympanic membrane is of right side. Also, there is one more trick. The upper end of the tympanic membrane, it is tilted towards right. So this is right TM. Now, if we consider one more tympanic membrane, this tympanic membrane that I am drawing here is nothing but the left tympanic membrane. Okay. So in this left tympanic membrane, as you can see, this is a cone of light in the anterior inferior quadrant pointing towards left side. There is the lateral process of malleus here, which is pointing to the left side. Also, the upper part is tilted towards the left side. So this tympanic membrane is a tympanic membrane of the left side. Got it? Okay. Now you answer this question for me. Most commonly, in which of the quadrant can we see cone of light? It is seen in the anterior-inferior quadrant. Okay. And there is one more significance of anterior-inferior quadrant. What is it? Whenever there is serous otitis media, you have to give relief to the person. No, you have to, for the child, you have to remove that pressure from the ear. You have to decrease pain. So you are going to do something called as grommet incision. So where do you do this grommet insertion? Grommet insertion is done in the anterior-inferior quadrant because you are going to replace the functioning of the eustachian tube. Now we saw the nerve supply of the external auditory canal. Now we'll be looking into the nerve supply of the tympanic membrane. Remember, when we talk of tympanic membrane, the lateral aspect has different nerve supply and the medial aspect has different nerve supply. The lateral aspect is supplied by two nerves who start with the same letter, the letter A. So the mnemonic for the lateral aspect is nothing but A square. So what are the nerves that come in A square? It is nothing but the Arnold's nerve. What is Arnold's nerve? It is nothing but the ear branch given by the 10th cranial nerve, that is the vagus nerve. And also we have one more nerve which is nothing but auriculotemporal nerve. So these two nerves supply the lateral aspect of the tympanic membrane. Now coming to the medial aspect of the tympanic membrane, it is supplied by the same nerve that supplies the entire middle ear, which is nothing but the glossopharyngeal nerve. So the branch of glossopharyngeal nerve which supplies the middle ear is nothing but, what is the nerve? It is the Jacobson's nerve. Okay. So this is derived from the cranial nerve 9. Now, there is going to be referred otalgia or ear pain that is seen in various conditions that affects the jaw, that affects teeth, that affects mouth, throat and so many structures. Okay. Now, a patient comes to you, complains of ear pain. You look into the ear is completely fine. So, what are you going to think next? Are you going to think that the patient is completely alright? No. You're going to rule out referred otalgia. So, in case there is a pathology in the face, referred otalgia can go to ear. So, which is a nerve that is responsible? Which is a nerve that goes to ear, which also supplies face? It is nothing but the trigeminal nerve branch, which is nothing but which nerve? It is the auriculotemporal nerve. Now, from larynx, if there is a nerve that goes to ear and causes referred otalgia, which is that nerve? It is nothing but the Arnold's nerve, which is nothing but the nerve from the vagus or the 10th. Tonsillitis, which is a nerve that goes to ear, it is the glossopharyngeal nerve, by its branch, the Jacobson's branch. Now, there's a question for you. So, a man comes to you, okay? So, this is the man that comes to you and then he complains that he has pain in a particular area, which is the area that he focuses. He is going to show this area, okay? He tells you that, doctor, I have severe pain in this area and recently I underwent a meatoplasty, that is a surgery of the external ear, after which I developed pain in this area. So, what are you going to suspect? A lot of students think that this area is nothing but the area of the face and they are going to mark auriculotemporal nerve as the answer here. But is it right? No, it is absolutely wrong. This area is called as a shaving area and this shaving area is supplied by the greater auricular nerve. So, how do you remember it? Great men shave their face, shaving area, greater auricular nerve. G for G. Okay. Now, coming to the next thing that I want to tell, if a person comes to you with an issue of the spine, cervical spondylitis, and he also has ear pain, which is a nerve that is affected here, again, it is the same nerve, greater auricular nerve. Got it? Okay. Now, a person comes to you and this person has TM arthralgia. That is nothing but the temporomandibular joint arthralgia. Now, which is the nerve that you will be suspecting? Now we are going to suspect the nerve that supplies the face, which is nothing but the auriculotemporal nerve. Got it? This is how the examiner can ask you questions. They are not directly going to tell or ask you which nerve supplies the ear or the tympanic membrane. They are going to say that this patient has certain symptoms which could be the nerve that causes otalgia. Okay, so you need to know which nerve supplies which part of the face. Now coming to the perforation of the tympanic membrane. Okay, so whenever there is perforation of tympanic membrane, so what are the causes because of which there could be sudden perforation? Either a blast or a loud exposure to noise, or there could be a person might get slapped very tightly. These are all certain causes when there develops a perforation in the tympanic membrane. So in casualty, I had seen a patient who was a case of assault. He came to the casualty with sudden decrease in hearing post a slap by his friend. He also had features of bloody discharge from the external auditory canal. There was hearing loss. Then when we examined, we saw that there was a big perforation in the tympanic membrane. There was bloody discharge. The tympanic membrane was blood stained. Okay. And what is the type of hearing loss this patient comes to you with? It is nothing but conductive hearing loss that the patient comes to you with. There is going to be blood discharge that is seen in the external auditory canal. Also, there is going to be lot of pain. This patient comes to you holding his ear, crying out of pain. So when you see these three classic features plus a history of assault or a history of loud noise exposure, and the number one thing that has to be there in your mind is nothing but traumatic perforation of tympanic membrane. So how do you manage this? If it is a small perforation involving only one quadrant, it is going to heal spontaneously. But if it is a very large perforation, it doesn't heal, you will have to give him a surgical intervention. So what is the name of the surgery? It is nothing but myringoplasty, where you are going to repair the tympanic membrane and you are going to place a graft so that the tympanic membrane grows over it. Okay. There is one more thing that you have to know here. As I told you earlier, whenever there is any damage to tympanic membrane and if it heals spontaneously, only the outer and the inner layer, that is the outer epithelial and inner mucosal layer, is going to heal. The central fibrous layer, which is a strong layer, is not going to heal. Therefore, the patient will have a weak tympanic membrane post-trauma. So, which is the layer that is going to heal? That is the outer epithelial layer and the inner mucosal layer. Which is a layer that is not going to heal? It is nothing but the fibrous layer. Got it? Okay. Now, there is a term called as tympanosclerosis that you have to know of. If you see the image here, there is this whitish patch which is seen over the tympanic membrane, no? Almost a circumferential patch. This is nothing but the patch of tympanosclerosis. So what is tympanosclerosis? Whenever there is any chronic inflammation of the middle ear, let's see a serous otitis media or a chronic suppurative otitis media, which is a long-standing case because of repeated inflammation, there develops something called as calcification and scarring of the tympanic membrane or all the structures in the middle ear. What are the structures in the middle ear that can undergo tympanosclerosis? These are nothing but the ossicles, the malleus, incus, stapes and the tympanic membrane. All these can undergo calcification, scarring, and because of which their mobility is affected, they are going to become more stiff and they result in conductive hearing loss. Okay. And this tympanosclerosis can occur secondary to trauma, secondary to chronic infections and inflammations. Now we have seen the different conditions of external auditory canal, the anatomical abnormalities, the development, embryology, everything. So what next? We are going to see certain diseases of the external auditory canal. Okay. So in the pinna and the external auditory canal, there are various conditions which look almost similar. There is going to be red pinna, there is going to be inflammation, there is going to be swelling. So sometimes it might become difficult as a UG or as an intern to differentiate between these. So I am going to give you classic features with the help of images so that it is very easy for you to identify which condition the patient presents to you with. So the number one disease that we're looking here is, if you see this image here, you can see that there is swelling in the pinna and the surface is going to look like cauliflower. How is the surface of cauliflower? Very rough, very thick, very undulating, no? So this ear, this pinna is resembling it. Therefore, it is called as cauliflower ear. So initially what happens, the patient comes to you with hematoma. So you're an intern posted in ENT in casualty, okay? One of your friend who has newly joined boxing classes is being hit by his opponent and he comes to you, okay? He is holding his ear, he's coming to you with lot of pain. When you ask him to remove his ear and examine the ear, you can see that there is lot of swelling in the ear. But he refuses any treatment, goes back, okay? And he also says you that you're just an intern, what are you going to treat me? I'll get fine. But after 2 days, he comes to you again. But now it is not just the swelling that he comes to you with. The swelling, the hematoma, what was initially there, has got organized. So when this hematoma gets organized, it is going to form a deformity which is called as cauliflower ear. So this cauliflower ear, whenever it develops, it is a relatively permanent condition which is going to permanently change the appearance of the pinna. Okay, so what are the key features? There is history of trauma. There is going to be swelling in the lateral pinna. If you do not drain it right in time, it will organize and it will lead to formation of a cauliflower ear. So what is the management? That is nothing but incision and drainage, or you can do an aspiration of the hematoma collection which is there in the pinna. Okay, and after you aspirate it, are you going to leave it open? No. If you leave it open, there is going to be collection that develops again. So what are you going to do? You're going to do a tight dressing which is called as contour dressing. Would you understand by contour dressing? As I told you initially, our ear is a very intricate structure having lots of ups and downs. You have depressions like Simba concha, you have ups like helix, antihelix, no? So you are going to place gauze inside the ear in such a format that all these crevices or spaces are tightly covered with pressure so that there develops no collection. Okay. If by chance the patient does not come to you on time, he comes to you with organized hematoma. That is nothing but cauliflower ear. The other names are the boxer's ear or wrestler's ear because these are common, very often seen in boxers or wrestlers, or a pugilistic ear, that is a deformed ear. What do? You can't do anything because I told you it's a permanent condition. You refer to them to plastic surgeons. These plastic surgeons are going to try to give them their actual shape and actual, the appearance of the pinna is going to be restored. Okay. Now coming to the second condition. If you look at this picture here, what can you see here? The upper portion of the entire pinna is looking red and inflamed. Whereas lobule, the lower part, what did I tell you initially? Lobule is a part where there is no cartilage, only fat. So this part is spared, whereas the rest of the entire pinna is inflamed. It is red, it is hot. So what is this condition which affects only the cartilage of the pinna? It is nothing but perichondritis of the pinna. Okay. So what are the key features? Red, hot, painful pinna. And which is the most common organism that causes this? Nothing but Pseudomonas. Okay. So this condition does not resolve on its own and you always have to give a course of antibiotic. So what is the antibiotic that you're going to give to this patient? It is nothing but ciprofloxacin, because ciprofloxacin has specifically anti-pseudomonal action. Got it? And one thing that you have to remember here is the lobule is spared and only the cartilaginous part is affected. Coming to the third condition. What do you see in this image here? You are seeing two round, rubbery, firm structures in the pinna. This is nothing but an appearance of a keloid. So how does a keloid develop? Certain people are by genetics predisposed to keloid formation. It happens post-trauma or post-ear piercing. Okay, so the patient would have got the ear pierced and after a month or two, they come to you with a large rubbery swelling in the pinna. It is going to be very firm on touch, rubbery on touch, and they are going to have a very circumscribed kind of swelling which is seen in the pinna. And it doesn't happen only in the pinna, on the chest it could happen, on the sternum it could happen, in various locations these could be seen post any trauma or injury. How do you manage it? The first line management is always by giving intralesional steroids. Either you can give them or you can send them to dermats who give them intralesional steroids. And sometimes intralesional steroids won't give them any benefit. It keeps on recurring. So now the patient comes to you for a permanent cure. That time, what do? You do excision of the keloid. But remember, there is no 100% guarantee that the keloid will never occur. Even after excising, it could occur. So you always advise the patient for after excision, you advise them to get radiotherapy post-excision or steroid therapy post-excision so that it prevents the recurrence after you excise the keloid. Coming to the next condition, here you can see the arrow pointing to one structure. So what is the structure that is pointed by arrow? This is nothing but Darwin's tubercle. So what is Darwin's tubercle? This is nothing but an atavistic feature. What do you understand by atavistic feature? Atavistic feature means there is a structure in your body, but it does not have any significance. So one such structure is a Darwin's tubercle. You can see here in the upper third of the pinna and the lower third of the pinna, there is a elevation that is seen on the lateral aspect. This is nothing but the Darwin's tubercle. Can you name of any other structure which has atavistic significance? It is nothing but appendix. You have that organ, but not much importance because of the organ. Okay, so what do they signify? They signify our common inheritance from the apes. Because if you see some gorillas, apes and all, they have these features, so that it says that we have inherited from them and the size has decreased over the generations. Now coming to the next condition. What can you see in this image? You can see a small opening in the root of the helix of the ear. So what is this opening? This opening is nothing but a preauricular sinus. So what is a preauricular sinus? It is a fusion defect of the auricular tubercles or the hillock of His. When these don't fuse together, there remains a small opening. When infected, it can lead to discharge, and some patient comes to you because it gets infected again and again. They need a permanent solution. That time, what are you going to do? You are going to surgically remove this sinus and close the tract so that it does not recur. And what is the most common site? As I told you, root of helix is the most common site. This I'm showing you in the arrow. No, this is the anterior helix. So just in front of it, in the root, you have the preauricular sinus. Okay. Now coming to the next condition. This is a condition in the external auditory canal where you see an appearance like this. So the patient comes to you with very severe ear pain. He's holding his hand, he can't sleep, he can't chew. With movement of the jaw, his pain is increasing. Okay, he has lot of pressure symptoms also. Here, his hearing is decreased. He has ear block sensation. And when you put your otoscope, you can see something which shows the onion peel appearance or an onion skin appearance. How is the onion skin appearance? It is going to look lamellated, right? In pathology, you would have seen a lot of conditions which has onion skin appearance. So, in the otoscope, when you look, there are going to be multiple layers in the EAC which is going to look like peels or the skin of the onion. When you have this appearance and patient comes with these features that I told you, the one thing that you have to come to your mind is nothing but keratosis obturans. So what is keratosis obturans? This is nothing but you have white mass along with wax in the deep part of the EAC. Now tell me, which is the deep part of EAC? Is it cartilaginous part or bony part? It is the bony part of EAC. Along with you seeing white mass, there can also be ulceration and granulation. Why is there ulceration? This mass is going to continuously put pressure on the EAC wall. And when there is a lot of pressure, there develops ulceration in the skin and the skin tries to heal. There is formation of granulation tissue also. And because of the pressure, it is going to widen the external auditory canal. And sometimes, as you all know, the facial nerve is in very close vicinity in the structure. And when the canal is widened to such an extent where it could reach the facial nerve, the patient can also have facial nerve palsy. Okay. Now, how are you going to treat this condition? As I told you, it's a very painful condition. Just by syringing, you can't treat this patient. You have to take the patient to OT and under general anesthesia, you are going to use some instruments in order to remove this collection in the ear. Also, remember, whenever somebody comes to you with this condition of keratosis obturans, it is going to point to you that the hair cells are not functioning well. That is, the hair cells are not effectively pushing out the wax and the debris outside, because of which it is constantly getting collected. So, you have to always think that these patients might have any ciliary dysmotility syndromes. For example, the patient can also have associated chronic sinusitis or associated bronchiectasis, where the function of cilia becomes very important. If they don't function well, all the secretions collect up and they can have sinusitis, bronchiectasis, keratosis obturans, to name a very few. Okay. Now coming to the next condition of the external auditory canal, can you look at the image here? What is it showing? We can see that the deep part of the external auditory canal is filled with wax. This is nothing but a picture of impacted wax in the external auditory canal. So what are the clinical features? The patient comes with you with a feeling of blocked ear, and when the earwax is so much, it can even lead to pain. What are the examination findings? Whenever you put a otoscope, you can see that the external auditory canal is filled with wax. So what is the treatment? You have to do syringing. Oral syringing is a treatment of choice, and you are going to use water whenever you do oral syringing. So what is the temperature of the water that you use? The water should be in body temperature. Why can't you use water at higher temperature or lower temperature? It is because whenever you use too cold water or too hot water, it is going to directly stimulate the labryinth and it will lead to an attack of vertigo. So the patient has just come to you to get his ear cleaned. He doesn't want to go with vertigo, right? So you're always going to put in water at body temperature. And what is the direction of syringing? It is always in the posterior-superior direction. So can you always do syringing, or is there any contraindication for syringing? Remember, you should never do syringing if there is a tympanic membrane perforation. Why is it? Because when you put water, it can go to the middle ear and it can only flare up an infection. And if there is a battery in the external auditory canal, even then remember, syringing is contraindicated. Why so? Because whenever you inject water into the canal, it is going to increase the release of the corrosive electrolytes that are there in the battery. These corrosive electrolytes are going to cause extensive tissue destruction. There is going to be liquefactive necrosis that happens, and whenever there is liquefactive necrosis, the surrounding tissue is damaged, the tympanic membrane perforates, the hearing loss becomes relatively permanent, and also there is going to be damage to the surrounding nerves. Which nerve comes in the vicinity here? It is the 7th nerve. So the patient can even go to facial paralysis. Coming to the next condition. What can you see here? In the image, the arrow that I am pointing here shows a localized collection of pus. This localized collection of pus in the external auditory canal, especially in the cartilaginous region, is nothing but a furuncle. So what is the cause of furuncle? Is it bacterial or fungal or viral? Remember, it goes in the order always bacterial. For example, staphylococci, that is the most common bacteria which causes furuncle, and then you have fungus, and the last organism that can cause furuncle is virus. So what are the clinical features? It is an extremely painful condition. Patients comes to you with a lot of pain, and when the pus breaks out, there could be purulent discharge, and if the furuncle is too big, it can block the external auditory canal, and the patient can also complain of ear blockage. On examination, what are you going to see? You are going to see in the cartilaginous part of the external auditory canal a localized collection of pus. Why is it seen only in cartilaginous part? Because as we discussed earlier, all the sweat, sebaceous and ceruminous glands are limited only to the cartilaginous part. So the next question, can you see a furuncle in bony part? No, because it doesn't have any of these appendages. Got it? Okay, so what is the treatment? Treatment is usually against staphylococcus. So what is it? You give the patient with a course of amoxiclav. You treat it with antibiotics. Got it? Now coming to the next condition of the external auditory canal, we are going to look at this image here. In this image, you can see that the external auditory canal is grossly edematous. Entire canal is looking red. It is swollen. There is a lot of excoriations in the EAC skin. All these points to the diagnosis of diffuse otitis externa. It is diffuse because the entire canal is involved. So which is the organism most commonly causing diffuse otitis externa? It is nothing but Pseudomonas. So this condition also has some other names. So in your exam, they are not necessarily going to tell you it is a case of diffuse otitis externa. They can just tell it is a swimmer's ear, or they can say that it is a tropical ear. So why does this condition have such names? So usually what happens, you remember that the EAC skin and the EAC pH is normally acidic. But what happens is that one reason is that anybody, whenever they try to wash their external ear with soap, it is going to alter this acidic environment into that of an alkaline environment. Plus, if the patient is living in a condition where there is a lot of humidity, even then the pH becomes alkaline. And the patient is using earbuds, the patient is trying to manipulate his ear canal, that is when lot of abrasions and micro injuries happen in the external auditory canal. Now this person whose pH has become alkaline, has abrasions and micro injuries, goes swimming. What happens? Lot of water is going to enter the canal, flare up the infection, and he is going to land up with diffuse otitis externa. Got it? So whenever this patient has diffuse otitis externa, he comes to you with ear pain. There is going to be lot of purulent discharge coming out of the external auditory canal. He can have ear blockage. He comes with itching sensation, and here he also gives history of abrasion. How abrasion? He might tell you that he has a history of manipulation using earbuds, and then he went swimming. So this is going to be a classic history of a patient presenting to you with this condition. So on examination, you can see the external auditory canal diffusely swollen up. There is going to be edema, there is going to be redness, also there is going to be excoriations in the skin. Why excoriations? Because this patient has a lot of itching sensation. They try to itch the EAC and the skin comes out causing excoriations. Also, there is a lot of granulation also seen. So two things that will point to the diagnosis mainly are the edema of the entire canal and granulations. So what is the treatment? As you all know, the antibiotic that is most effective against Pseudomonas is nothing but, what is the antibiotic? It is ciprofloxacin. So you are going to give the patient a course of ciprofloxacin. So coming to the next condition. So look at the ear here. What can you see? So if you look at the ear closely, you can see that there is discharge coming out of the external auditory canal. The entire pinna is grossly congested and edematous, and there is a lot of granulations in the external auditory canal. So this is a picture of malignant otitis externa. So malignant otitis externa also has some other names. What are the other names of malignant otitis externa? It is also called as skull base osteomyelitis. Why is it called as skull base osteomyelitis? Because it is so advanced that it can even spread to the skull. The bone gets involved. That's why it is called as skull bone osteomyelitis. In this condition, you can see necrosis of the tissue around the external auditory canal. So what is the cause of this? Here, usually what happens, the infection spreads through the fissure of Santorini. Now tell me, fissure of Santorini, is it present in the bony canal or in the cartilaginous canal? Right, it is present in the cartilaginous canal. So what is the fissure that is seen in the bony canal? It is nothing but fissure of Huschke. When does it close? 4 years. Right. So in whom is malignant otitis externa seen? Does it occur in everybody? No. It need not occur in everybody. It is seen in those people who have diabetes mellitus, or it is seen in those people who are immunocompromised. That is, their immunity is not able to fight the infection. That is when we get malignant otitis externa. Normally, patient has otitis externa, but when you give them treatment, it is going to resolve. But in these people whose immunity is less, there develops malignant otitis externa. And what is the most common organism causing it? It is again Pseudomonas. What are the clinical features? The clinical features are, the patient comes to you with excruciating pain, there is going to be discharge, and there is going to be granulations from the external auditory canal. On examination, what do you see? Necrosis, granulation in the external auditory canal. And what is the examination that you do? You get a technetium-99 bone scan. It shows increased uptake in the area that is affected by the malignant otitis externa. What are the cranial nerves that can be involved? What are the cranial nerve palsy that occur? That is nothing but cranial nerve 7. The facial nerve is affected early because of its close proximity with the external auditory canal. Next, in the later stages, if it remains untreated, cranial nerve 8, 9, 10, 11, all these can be affected. Now coming to treatment, oral treatment, what are you going to give? Which is an oral antibiotic? You are going to give ciprofloxacin. And if it is not responding, you are going to give IV. What is the IV treatment that you give? That is cefoperazone or IV ceftazidime. This is what you are going to give to the patient when you are giving parenteral route of antibiotic. And then obviously you're going to correct immunosuppression. You're going to build an immunity of the patient so that he can fight infection. And how are you going to monitor the course of disease? You can do serial ESR. You can see how the ESR levels are falling as you give treatment. If the patient is responding to treatment, ESR levels will improve. You can also do gallium-67 scan in order to check the disease, however it is responding to your treatment, and also you can do indium-111 scans. Now coming to the next condition of the external auditory canal, can you guess what it is? Yes, we are going to look into fungal infection, which is nothing but otomycosis. So, which is a common fungus that causes infection in the external auditory canal? The number one is nothing but the Aspergillus. Which species of Aspergillus? Aspergillus niger. Aspergillus niger, and the second most common organism is nothing but Candida. What are the features? A patient is going to walk into your OPD with severe itching in the ears. He also complains of pain. There could be whitish discharge from the ear, and also he might have blocked sensation because there is a lot of fungal debris that is occupying the canal, because of which he complains of ear block. When you see all these, and the classic symptom among all this is nothing but itching. So when you see all these, and on the otoscopy, you're going to see two types of findings. Okay. In the first picture here, you can see that there is something called as wet newspaper type of appearance. This newspaper type of appearance is seen in Aspergillus. And when we talk about Candida, you can see here a cotton ball-like appearance. So when you see in the otoscope, sometimes you might even think that it is just a cotton ball and miss your finding because it looks exactly like a cotton ball. C for C, Candida, it is going to be cotton ball appearance. When you see this, you can diagnose that it is otomycosis picture that you're looking at. So what is the treatment? You're going to suction and remove all the otomycotic debris, followed by antifungal ear drops to this patient. And it is most commonly seen in those areas which are hot and which are humid, because fungus loves hot and humid climate. It is going to go and start developing in these areas. Now coming to the next condition, in this image, what are you looking at? In the first image, as you can see, the patient has facial palsy. How are you going to say that there is facial palsy in this person? As you can see in the eyes, there is drooping of the eyelid, there is deviation in the angle of mouth, because of which we are saying that the patient has facial palsy. See the second image, it is pointing at lot of vesicles in the external auditory canal. So when you see both these pictures of facial palsy and vesicles in EAC, there is a diagnosis that has to be clicking in your brain. What is it? It is nothing but Ramsay-Hunt syndrome. So this Ramsay-Hunt syndrome occurs because of the reactivation of virus. Which virus? Herpes zoster virus in the geniculate ganglion. So geniculate ganglion is the ganglion of which cranial nerve? It is the ganglion of cranial nerve 7, which is the 7th nerve, facial nerve. So whenever there is reactivation of the geniculate ganglion, it is going to cause facial nerve palsy. So what are the features? The patient comes with a lot of pain. There is going to be discharge, blocked ear, plus the most important feature, facial nerve palsy. Now, when you take an otoscope and examine, you're going to see a lot of vesicles in the EAC and various cranial nerves are affected. What are they? They are 5, cranial nerve 7, 8, 9, 10. All these nerves are going to be affected. And these patients with Ramsay-Hunt syndrome have a relatively poorer prognosis. So how are you going to treat these patients? You treat it with antivirals and steroids. Usually whenever there is any facial palsy, antivirals should usually be started within 72 hours of onset of symptom. Otherwise, a lot of studies say that they won't offer a lot of benefit if started after 72 hours. Now we have looked into the development, embryology and various conditions pertaining to the external ear. Now we'll be moving forward to the diseases, to the development and the structure of the middle ear. So firstly, coming to middle ear, we all know that it is a cuboidal cavity. It is a 6-walled cavity. Now let's see what each wall of this cavity is made up of. Now coming to the lateral wall, this lateral wall is going to be a common wall between the external ear and the middle ear. So what is a lateral wall made up of? It is made up of tympanic membrane. So this tympanic membrane is there inferiorly and above you have the scutum. So scutum is a bony projection that is going to form the superior border of the lateral wall. Next, coming to the medial wall. Medial wall is a structure which has many structures and all these structures are very important. So with the help of this image, let us see what are the different structures. So the number one structure is the promontory. So what is a promontory? This area is nothing but the promontory. It is nothing but the bulge that is seen in the medial wall, which is formed by the basal turn of cochlea. So the basal turn of cochlea forms the promontory. And in the basal turn of cochlea, which forms promontory, you can also see Jacobson's nerve. What is a Jacobson's nerve? It is a nerve of the middle ear given by the glossopharyngeal nerve, and also you can see the sympathetic plexus around this promontory. Now coming to the second structure, it is nothing but processus cochleaformis. What is processus cochleaformis? Here, if you see this image, the structure that I am marking in black color is nothing but processus cochleaformis. It is a small process at which the muscle, the tensor tympani muscle takes a lateral turn and it is going to go and attach to the handle of malleus. So what is a muscle that you have to know here? It is nothing but tensor tympani. Apart from these structures, so you have promontory, you have the processus cochleaformis, you also have two bulges. So what are the bulges? You have the number one bulge, which is nothing but the bulge of the lateral semicircular canal. This bulge is the bulge which is most commonly eroded. Eroded by what conditions? Whenever there is a cholesteatoma, it is going to hit this bulge first. The sac is going to erode the lateral semicircular canal. Also, when you do caloric test, why do you do caloric test? In order to find out the functioning of the membranous or in the bony labyrinth. Basically, the inner ear functioning is tested by caloric test. When you do this, it is also going to stimulate the lateral semicircular canal. Next, you also have a bulge of the facial nerve called as the fallopian canal. So, this facial nerve bulge is also seen at this area. Facial nerve bulge, and what is the second bulge? Lateral semicircular canal bulge. So apart from these, you also have round window and the oval window. So what is oval window? Oval window is an opening which is seen in the posterior superior aspect. So this, if you see this as middle ear, this is the anterior aspect and this is the posterior aspect. So in the posterior superior aspect, you're going to see the oval window, and this oval window is lined by the footplate of stapes. So footplate of stapes rests on the oval window and it is going to transmit impulses, the sound impulses, into the scala vestibuli. So you remember oval, no? There is a V. So it is going to transfer the information to the scala vestibuli. You also have round window which is situated posterior inferiorly. So as I told you, this side is the anterior side and you have the posterior side backwards, and in the lower aspect you are going to see the round window. So this round window, what is the significance? Whenever there are any electrodes to be implanted, for example, in surgery like cochlear implant, you are going to put all those electrodes in the round window. Through the round window, you are going to place it in the scala tympani. Also, if you have to deliver some drugs, for example, gentamicin, you are going to use the same route for drug delivery. Now coming to the next structure. So we saw medial wall, we saw lateral wall. Now we'll be looking into the posterior wall. So remember, posterior wall is a wall that is there between the middle ear and the mastoid behind. So there is a structure called as adytus in the upper part of the posterior wall which acts as a window to the mastoid antrum. So if I have to show this to you in an image, this is the medial wall. And then you have the posterior wall backside. And what are the structures that we studied in medial wall? This is the promontory. And then we studied about the oval window. Then we studied about the round window. And then we saw two canals, the facial nerve canal and the lateral semicircular canal. And what is the other structure we saw? We saw the processus cochleiformis. Now, this facial nerve is going to go from the medial wall to the posterior wall and in the vertical course. This is how the facial nerve is going to go down. At the same place, it is going to give a branch called as chorda tympani. So this is the structure what you can see. And on top, you can also see a small adytus. It is a window to the mastoid antrum. Got it? Okay. So there are some other structures that is also very important here. They are the pyramid. What is pyramid? Pyramid is a piece of bone in the shape of pyramid which gives origin to a muscle. Which is the muscle that comes from here? It is nothing but stapedius muscle. So you can see this image here. No, this is a cross-sectional image that is showing the posterior wall. So this is the pyramid, and from the pyramid you have a muscle that is coming, that is nothing but stapedius. It goes and attaches to the stapes ossicle. Now, apart from this, you also have two structures that are very important. The structures are the facial recess and the sinus tympani. So the facial recess. So facial recess is nothing but the suprapyramidal structure. What do you understand by suprapyramidal? It is above the pyramid, suprapyramidal recess. So you can see in this image, no? This is pyramid. Above that, this star that I am putting in blue is pointing to the facial recess. It is above suprapyramidal. Next, we have one more recess which is called as sinus tympani, which is infrapyramidal. It is called infrapyramidal because it is below the level of pyramid. So, below the level of pyramid, this is called as infrapyramidal recess, sinus tympani. So, the sinus tympani is also very medial, okay. So, because it is medial, whenever you do cholesteatoma clearance, some part of cholesteatoma can be left behind as a residual cholesteatoma here. That's why this is the area where commonly recurrence or residual disease could be seen. So, this sinus tympani has two walls. Okay, that is the roof and the floor. The roof of the sinus tympani is formed by ponticulus. It is a piece of bone that forms the roof of the sinus tympani. The floor is formed by a piece of bone called as subiculum. How are you going to remember? Subiculum, S, subway, low. Okay, that is how you are going to remember that the floor is formed by the subiculum. Okay, and as I told you, this is an area which is very medially located, hence residual or recurrent cholesteatoma can be seen in this area. Now coming to the anterior wall. In anterior wall, you have to remember 3-4 important structures. So what are these structures that you have to know in the anterior wall? These are nothing but, see, so this is a medial wall, this is a posterior wall, and this is the anterior wall. In the anterior wall, there are certain openings. What are these? One opening is from where a muscle enters. What is this muscle? Tensor tympani muscle. So, the entry of the tensor tympani muscle is seen in the anterior wall. Next, there is opening of the eustachian tube. You can see that there is going to be opening of the eustachian tube here. So, this is also a structure in the anterior wall. Next, You also have the internal carotid artery which lie at this level. This internal carotid artery is going to come from the floor and it is going to lie anteriorly. Then also you have a structure called as canal of Huggier, that is the chorda tympani, which is a branch of facial nerve. It is going to exit through this canal. So the exit of chorda tympani is in the anterior wall through the canal of Huggier. Now we looked into 4 walls, right? We looked into the lateral wall, we looked into the medial wall, anterior wall and the posterior wall. So what are the 2 walls remaining? We are going to look into the floor as well as roof. Okay. Now coming to floor, you need to know about certain important structures. What are these? Number 1, jugular bulb. Why do you want to know about jugular bulb? Because there is a tumor of the jugular bulb which is called as glomus jugular. Whenever there is glomus jugular, there is going to be a red mass that is seen in the tympanic membrane. What is it? Glomus jugular. Coming to the second thing that is important, it is Jacobson's nerve. So Jacobson's nerve is a branch of glossopharyngeal nerve, which is a 9th cranial nerve. Jacobson's nerve is going to form tympanic plexus on the promontory, and this tympanic plexus is going to do the sensory supply for the entire middle ear. Apart from supplying the middle ear, it also supplies the medial aspect of the tympanic membrane. So what are the nerves supplying the lateral aspect? A square, auriculotemporal and Arnold's nerve. Okay. Now coming to the other cranial nerves which are there in the floor, we have cranial nerve 9, 10 as well as 11. So these cranial nerves could be involved in various pathologies. For example, if there are any tumors, if there are any infections, these cranial nerves could be involved. There could be palsy of these nerves. Got it? Okay. Now we'll look into roof. So what is a structure that is separating the middle ear from the middle cranial fossa? It is nothing but tegmen tympani. So tegmen tympani is a part of the bone that separates the middle ear from the middle cranial fossa. If there is a breach in the tegmen tympani, what is going to happen? There is easy spread of infection. If there is any serous otitis media, chronic suppurative otitis media, there is going to be spread of these infection to the temporal lobe. There is going to be temporal lobe abscess that could occur. Okay. Next, we have a structure called as cog. So what is cog? It is a bone that is hanging from the roof of the middle ear cavity. So what is the importance of cog? It acts as a landmark for the facial nerve. Okay, and it is also a bony ridge above the processus cochleoformis. What is processus cochleoformis? It is a structure which is seen in the medial wall of the middle ear, where the tensor tympani muscle takes a lateral turn and attaches to the head of the malleus. So above that we have cog, which also acts like a landmark for the first genu of the facial nerve. Which part of facial nerve? It is the first genu. Now coming to the next structure, which is also a component of the middle ear, it is nothing but eustachian tube. This eustachian tube, where is the location? So this eustachian tube is going to open about 1 centimeter posteriorly and inferiorly to which structure? To the inferior turbinate. Okay. So this is where the opening of the eustachian tube lies. So in the nasopharynx, 1 centimeter behind and posteriorly to the inferior turbinate, we have the opening of the eustachian tube. Usually this eustachian tube is surrounded by fat. This fat that is surrounding the eustachian tube is called as Osman's pad of fat. So sometimes what happens in people who do sudden weight loss, okay, suddenly they cut down all the food, there is sudden weight loss, or under the influence of radiotherapy, the patient is getting any treatment for cancer. In such conditions, there is going to be sudden loss of fat from the body. That is when that fatty cover from the eustachian tube opening is going to be lost. The eustachian tube becomes patulous. What do you mean by patulous? That is, even at rest, this tube is going to remain open. So what is a big deal? What happens if this tube remains open? It is when it is open, the patient experiences something called as autophony. What do you mean by autophony? It is normally whenever we eat food, drink water, talk or we respire, we're not going to hear all those sounds, no? But in these people who have patulous eustachian tube, there is going to be autophony. They're going to hear their own breath, hear whenever they are swallowing, eating, chewing. So it is going to be a very troublesome situation for the patient. Now coming to the structure, like external auditory canal, this tube also has a bony part and a cartilaginous part. There we remembered which tables? 8 ones are. So here we are going to remember 12 table. Okay. So the bony part forms the lateral 1/3 and it is around 12 millimeter. Whereas the cartilaginous part is a medial 2/3 and it is around 24 millimeter in length. So the narrowest part, which is a junction of the bony and the cartilaginous part, is called as isthmus. Now coming to the length and the angle. So the angle varies between adults and children. When we talk about adults, the length is around 36 millimeter and coming to the angle, it is angulated at 45 degree. So if this is the eustachian tube and this is the nasopharynx. Okay, so this is the nasopharynx and on the top you have the middle ear and then this is a eustachian tube coming. So this angle is 45 degree in adults. Whereas if you take children, the tube is much more shorter. It is just 13 to 18 millimeter and it is wider and also it is more horizontal. Horizontal means, is it 0 degree? No, it is not 0 degree, but it is almost at 10 degree angulation with the nasopharynx from the middle ear. Now, what is a big deal if there is only 10 degree angulation? See, what happens is that there is a lot of chances of spread of infections. So, it is always advised when the pregnant woman gives birth to the child, the doctor always tells the mother to nurse the baby in sitting position. It is because whenever they nurse the baby in sleeping position, because the tube is more horizontal, milk tends to go to the ear through the eustachian tube, causing recurrent otitis media in that newborn. Got it? Now coming to the muscle function, which is the muscle that opens the eustachian tube, it is nothing but the tensor veli palatini. So this is the muscle that helps in opening of the eustachian tube. Whenever there is any dysfunction of the eustachian tube, like for example cleft palate, there is going to be poor ventilation and therefore lot of infections could occur. Okay. Now what is the clinical importance? Like I told you earlier, there could be patulous eustachian tube whenever the Osman's fat pad is lost, and when that happens, the eustachian tube is going to be open even at rest. There is going to be autophony, that is the patient hears his own voice and it could be very disturbing to the patient. Also, if there is blocked or floppy eustachian tube, it leads to recurrent attacks of serous otitis media in the child. The child always has blocked ear, painful ear, and it is because of the blocked eustachian tube. Now coming to middle ear, we've seen the different walls of the middle ear. We've also seen about the eustachian tube. So what is the other structure that is remaining now? It is nothing but the small tiny bones that are there in the middle ear, which is nothing but ossicles. So how many ossicles are there in the middle ear? We have 3 ossicles. We have malleus, incus and stapes. So which is the largest ossicle out of all 3? It is nothing but malleus. Coming to the smallest ossicle, S for S, it is nothing but stapes. So stapes is the smallest ossicle. Next, we have 2 joints between these 3 ossicles. Between the first ossicle and the second ossicle, we have the malleolo-incudor or the incudo-malleolar joint, which is nothing but a saddle type of joint. Now, between the incus and the stapes, we have the incudo-stapedial joint, which is a ball and socket type of joint. So, a lot of students usually get confused between which is saddle and which is ball and socket. So, here is a simple trick to remember. Remember that malleus is like a rider. So, this malleus, which is like a rider, it goes and sits on a incus. So, incus is like the saddle. Okay. Saddle of horse. So this rider sits on the saddle of horse, which is nothing but incus, making it a saddle joint. Okay. So the other joint is nothing but the incudo-stapedial joint. Now coming to the ossicle necrosis. Okay. So how do you get a question about this topic? Usually you're going to get a question like a person, a 60-year-old patient comes to you with a reduced hearing and ear discharge. How is the ear discharge? Blood tinged, scanty ear discharge, very foul smelling. And when you do a PTA, you get to know that hearing is about moderate to severe in intensity, bone is affected, and in the scan also it shows erosion of the bone. Okay. Now, they are not going to ask you whether it is a aticoantral disease or a tubotympanic disease. Their question would be, in such a condition, which is the ossicle that is going to be eroded? And the options are Malleus, you have lenticular process of incus, long process of incus, stapes footplate, stapes suprastructure. What is the option that you are going to choose? The right option here is the lenticular process of the incus. Why is it the lenticular process that is the answer? Because lenticular process has very little blood supply, because of which it can get eroded easily. And which is the second most common bone to be eroded? It is nothing but the long process of the incus. Okay. Now, the chorda tympani nerve runs near one of the joint. So, how many joints are there? Tell me. They are the incudomalleolar and the incudostapedial. Between the first joint, that is the incudomalleolar joint, the chorda tympani runs. Okay. Now, the footplate of stapes is most commonly involved in one of the conditions. What is that condition? The condition is nothing but otosclerosis. And whenever there is otosclerosis, there is going to be a fixation of the footplate of stapes, and there is going to be hearing loss with a lot of accompanying features, which we'll look into in the further discussion. Okay. And as I told you, this lenticular process, it is the bone that is going to be eroded first. Also, it is the bone which is eroded, because of which lot of hearing loss can also occur in these people. Okay. Now, coming to Prusac space. What is Prusac space? So, Prusac space is which is seen above the level of the tympanic membrane beneath the scutum. So, this small space that you can see here in this image is nothing but that of the Prusac space. So, Prusac space has various boundaries. Okay. So, this is the medial side. So, medially, what do you have? Medially, you have the neck of the malleus. So, this is the neck of the malleus, which is forming the medial boundary. And laterally, this is a lateral surface, and laterally what do you have? Laterally you have the pars flaccida. This area here, it is a pars flaccida, which is also called as sharpness membrane. So, two boundaries are over, right? Medial and lateral. Which is the remaining boundary? It is nothing but the inferior boundary. So, the inferior boundary is formed by the lateral process of malleus. So, in this picture, the lateral process is not seen, but somewhere which I am marking now, this is where the lateral process of the malleus is. So, this is a space which is most commonly affected by the cholesteatoma. Cholesteatoma is going to erode the scutum at this area. Now, we have seen the external ear and the middle ear, and now we are going forward into studying the inner ear. Okay. So, coming to the anatomy of the inner ear, you need to know that inner ear comprises of the three semicircular canals. So, which are the three semicircular canals? You have the lateral semicircular canal, and then you have the posterior semicircular canal, and you have the superior semicircular canal. All these are seen in the upper part of the inner ear, and then all these canals finally open into the utricle, and then there is saccule, and then there is cochlea. So, all these structures comprise the inner ear, and from the saccule and utricle, there is a sacculo-utricular duct or the utriculo-saccular duct, which comes and leads into the endolymphatic sac. And initially, as I told you, these structures are formed from the pars superior and pars inferior of the otic capsule. Now, coming to the three semicircular canals, we have the lateral semicircular canal, then we have the superior semicircular canal, and then we have the posterior semicircular canal. Okay. And then this superior and posterior semicircular canal have a common opening. So, this common opening is called as crus commune. It is between the superior and between the posterior semicircular canal, and this crus commune is going to lead into the utricle. Remember, in a lot of places in ENT, you can see that S and P are going to come together, and this is one such area, superior and posterior together. Okay. Now, there is utriculo-saccular duct which connects the utricle and saccule. This utriculo-saccular duct leads to the endolymphatic sac. So, this endolymphatic sac is having the function of absorption of the endolymph. If it fails to do its function properly, the patient develops Meniere's disease. Now coming to the lateral semicircular canal, as we discussed in the medial wall of the middle ear, it is a semicircular canal which is most commonly eroded by cholesteatoma because it is in most proximity with the medial wall of the middle ear. Also, it is the most common semicircular canal which is stimulated by the caloric test. So what is caloric test? Caloric test is a test which is going to test the function of the inner ear. You are going to put water into the inner ear. You are going to put water above body temperature and below body temperature, and you are going to see whether it can stimulate the inner ear. When you do this, which is a semicircular canal that you are testing? It is nothing but the lateral semicircular canal. Now coming to saccule. So saccule develops from pars superior or pars inferior. Where does it develop from? It develops from the pars inferior. Now, you guys have a question. Utriculosaccular duct. Where does it develop from? Superior or inferior? It develops from pars superior. Semicircular canals, pars superior. Utricle, pars superior. Utriculosaccular duct, pars superior. Got it? From pars inferior, we have only two structures, which is nothing but saccule and the cochlea. Now coming to scala media, it is a coiled tube which is going to take around 2.5 to 2 3/4 turns around the modulus. So this is how many turns it is going to take around the modulus. Now coming to the modulus and this tube, it is in a pyramidal shape. This is how it appears, okay, and there are 2 3/4 turns. And this 2 3/4 turns are there, no? So the apical part of this is more sensitive to the low frequency of the sound. It is heard in the apical region. But the lower part of this, the basal part which is bigger, is more sensitive to the high frequency of the sound that is in the base. Now, can you name any condition of the inner ear where the base is affected? We saw it initially. It is nothing but Alexander's aplasia. So, what happens in Alexander's aplasia? A for A, apex is spared. Base is gone. Base is the one which senses high frequency. Because the base is affected, high frequency hearing loss is going to be there in people with Alexander's aplasia. Okay. Now coming to the three semicircular canals, these contain one of the sense organs which detect the rotational acceleration, which is that it is nothing but crista. So these semicircular canals contain crista, and this crista is going to detect rotational acceleration. Okay, how do you remember? All these canals are round, no? Rotational acceleration. Whereas utricle and saccule have macula, and this macula is going to detect three things. What are they going to detect? One is the linear acceleration, and it is also going to detect the head tilt, and it is also going to detect the gravitational moments. So these three things, the linear acceleration, gravitational moments, and the head tilt, all these three are going to be sensed by the utricle and saccule by macula. Now, if we look into a cadaveric image of the three semicircular canals, so in this image, we can see the three semicircular canals. Now, how are you going to identify which one is superior, which one is horizontal and posterior? It is by simply knowing the fact that the semicircular canals are going to lie superiorly and anteriorly in the ear. Okay, that's why this becomes superior, this becomes inferior. And as I told you, it lies superiorly and anteriorly, right? So this becomes anterior and this becomes posterior. Now the semicircular canal which is lying posterior most becomes the posterior semicircular canal. So this becomes the posterior semicircular canal. Now the semicircular canal lying superior most becomes the superior semicircular canal. This is the superior semicircular canal. And then which is lying anterior most becomes the horizontal semicircular canal, and one more way of identifying this is that it lies more laterally, more horizontally. Okay. Now you need to know a structure called as Donaldson's line. So what is Donaldson's line? It is a line which passes through the lateral semicircular canal bisecting the posterior semicircular canal. So this line is called as Donaldson's line. So what is the significance? This line helps us to identify the endolymphatic sac. So where does the endolymphatic sac lie? It lies inferior to the Donaldson's line. Now we looked into the membranous labyrinth and the various parts that we looked into are the semicircular canals, utricle, saccule, endolymphatic sac and the cochlear duct. Now there is a bony structure which surrounds this membranous labyrinth, and as the name suggests, it's called as bony labyrinth. So this bony labyrinth has two most important components. They are nothing but vestibule and the cochlea. So the vestibule is a part which surrounds the utricle and the saccule, and cochlea surrounds the cochlear duct or the scala media. So the elliptical recess is a part of vestibule which is going to surround the utricle. Okay. And then we have the spherical recess which is going to surround the saccule. How are you going to remember this? You can remember this very easily. S for S. Spherical recess S is going to surround the saccule and the elliptical recess is going to surround the utricle. Now coming to cochlea, cochlea encloses the cochlear duct. This cochlear duct is also called as scala media. Okay. So this is enclosed by the cochlea. Cochlea is a bony part of the bony labyrinth which is going to enclose the cochlear duct. Now above we have oval window. This oval window is going to lead to which structure? It is going to lead to the scala vestibuli. So scala vestibuli, how are you going to remember this? Oval, it has a V in it, right? So it is going to lead into the vestibuli. And then we have the round window below which is going to lead into the scala tympani. So the scala tympani is an area where we are going to place electrodes during cochlear surgery, and the electrodes are placed through the round window in the scala tympani. And there is a structure called as helicotrema. So where is this helicotrema located? It is located at the apex. Apex of which structure? If you look into the image here, you can see this arrow, black arrow pointing to the apex, no? So this is where we can see the helicotrema, and this is going to connect the scala vestibuli and the scala tympani. There are two things that you have to know here. It is nothing but oval window and the round window. So as I told you, oval window is going to lead into which structure? Scala vestibuli. And oval window is surrounded by the foot plate of the stapes. And then we also have the round window, and this round window is the area through which you put electrodes in the cochlear surgery, and also it is the area through which drug delivery is done in certain conditions. For example, which drug? Gentamicin drug delivery. Now coming to the sense organ of hearing, which is the sense organ of hearing, it is nothing but organ of Corti. So this organ of Corti comprises of the outer and inner hair cells. So coming to the outer hair cells, these are the cells which are more prone for damage by ototoxic drugs. Which are ototoxic drugs like gentamicin, kanamycin, some of the anti-cancer drugs. So these drugs are going to damage the outer hair cells, and also whenever there is exposure to too much noise, there is noise-induced damage of the outer hair cells. Now coming to endolymph, where is the endolymph present? Is it in the scala media or in the vestibuli or tympani? It is present in the scala media. So this endolymph is there in the scala media of the membranous labyrinth, and it is rich in potassium. Now we have the endolymph secretion. Where does the secretion occur? Secretions happens from the stria vascularis. So this stria vascularis is present in the scala media, and it helps in the endolymph secretion. Now, as it secretes, there is also one more organ which absorbs the endolymph, which is that it is nothing but the endolymphatic sac. As the name suggests, this is the sac that is going to absorb the endolymph. Okay. Now we have one more fluid which is called as perilymph, and the perilymph is there in the upper and lower chambers. That is, it is there in the scala vestibuli and scala tympani, and this perilymph is rich in sodium. And what is this perilymph? It is nothing but an ultrafiltrate of the CSF. It is an ultrafiltrate of the CSF. Now, coming to the inner hair cells and outer hair cells, both of these have quite distinct features. Let us look into certain important ones among them. Okay. So, number of rows. Inner hair cells are less in number. There is only one row. Outer hair cells are more in number. There are around 3 to 4 rows. Number, the inner hair cells are less, whereas the outer hair cells are more in number. Coming to the shape, the inner hair cells are flask shaped. That is, they appear like a flask. This is how they are going to appear. Whereas the outer hair cells are like cylinder. When I mean that they are like cylinder, they appear like this. So this is going to be the structure of the outer hair cells. Inner hair cells are less prone to damage. Why they are less prone to damage? Because by default they are less in number, less prone to damage. Outer hair cells are more in number and they are more prone for damage. Innervation, around 95% of the innervation to inner hair cells is by afferent fibers, and when we talk about the outer hair cells, it is 80%, and that too it is only the efferents. Okay, efferent, and it is around 80%. Now coming to the function of the inner hair cells and outer hair cells, the function of the inner hair cell is to send signals to the brain. What type of signals? The auditory signals are sent to the brain. Now coming to the outer hair cell function, the main function of the outer hair cells is to amplify the sound. Also, its one more function is to modulate the function of the inner hair cells. The modulation function of the inner hair cell is done by what? It is done by the outer hair cell. Okay. Now coming to the neurotransmitter, the inner hair cell releases a neurotransmitter which is nothing but glutamate, and glutamate is an excitatory neurotransmitter which is needed for the auditory stimulus transport, whereas there is no neurotransmitters involved with the functioning of the outer hair cells. Now coming to the tectorial membrane contact, which of these is in contact with tectorial membrane? Inner hair cells? No, inner hair cells is not in contact, whereas the outer hair cells, the lips of the outer hair cells are in contact with the tectorial membrane. Okay, so if you see the image here, this image shows a single cell here, which is nothing but the inner hair cell. As I told you, inner hair cell, single row, less in number. And also, it is flask shaped. This is the shape of the cell. Now, we have many cells in this side, which are nothing but the outer hair cells, many in number, and they are cylindrical in shape. Okay, and from the picture, you can also see one more distinctive feature, that is, the inner hair cells are not in contact with the tectorial membrane. As you can see here, there is a space here, no contact with the tectorial membrane. But the outer hair cells are clearly in contact with the tectorial membrane. Now we'll look at one more important part of ENT, which is nothing but mastoid. And we'll be looking into the mastoid anatomy. So when we talk about mastoid, one important structure that comes to our mind is nothing but mastoid antrum. Why is it the most important thing? One, because it is there in the deep part of mastoid, and this is the most consistent mastoid air cell, and it is the most largest mastoid air cell. That is why this is the area at which we drill in order to clear disease from the mastoid. Okay, it is the largest and the most consistent air cell, located around 1.5 centimeter deep to the bony triangle that we drill in order to reach the mastoid. Okay, so it has two landmarks, surface landmarks. One is the bony landmark, one is the cartilaginous landmark. The bony landmark is nothing but the McEwan's triangle. This McEwan's triangle is also called as suprameatal triangle. Now coming to the different boundaries of the McEwan's triangle, the number one boundary is nothing but the temporal line. You can see here, this is nothing but the temporal line. And then we have the posterior superior segment of the external auditory canal as the next boundary. And then we have the tangent drawn joining these two lines, which is the third boundary of the McEwan's triangle. Now we take a drill, we start drilling at this area, and then we are going to approach the mastoid antrum. So where is the mastoid antrum located? Around 1.5 centimeter deep to this triangle, we are going to find the mastoid antrum. Sometimes what happens, as I told you, the superficial part of mastoid is formed from the squamous part of temporal bone and the deep part from the petrous part of temporal bone. At the area of fusion of both these bones, there is a corner septum that is there. Okay, it is going to be very superficial, around 0.5 centimeter when you drill from the McEwan's triangle, you are going to get the corner septum. Sometimes you feel like you have reached the mastoid antrum and you come back, okay. So you have not efficiently cleared the disease because the antrum is very deep to this bony corner septum. Got it? Okay. Whenever you're drilling to these triangle, you have to keep in mind that you should not go too beyond the triangle, because whenever you drill a lot, it is going to cause injury to the deep structures. What are the deep structures? Facial nerve and the sigmoid sinus. These are going to be deep to this triangle. Got it? Okay. Now coming to the cartilaginous landmark. What is a cartilaginous landmark of the mastoid antrum? It is nothing but the Simba concha. So where is the Simba concha? We studied it somewhere, right? It is there in the pinna. It is a depression in the pinna, which is a cartilaginous landmark to the mastoid antrum. Now, we have studied about the McEwen's triangle. There is also one more triangle which is important. It is nothing but Trotman's triangle. So what is Trotman's triangle? It is a triangle which gives a surgical approach to the posterior cranial fossa. The posterior cranial fossa is approached from the Trotman's triangle. So this also has various boundaries. We have the superior boundary, anterior and posterior boundary. So what is the superior boundary? This part is the superior boundary. If you look at the image, this part is formed by the superior petrosal sinus. So this sinus forms the superior boundary of the Trotman's triangle. And then posteriorly, what do we have posteriorly? We have the sigmoid sinus posteriorly. We finished superior, we finished posterior. Now coming to the third boundary, the anterior boundary, this is formed by the bony labyrinth. So the bony labyrinth is going to form the anterior boundary. So what are the two components of bony labyrinth? Vestibule and cochlea. So where does this triangle come? Superior petrosal sinus, sigmoid sinus and the bony labyrinth. Okay. Now coming to the sinodural angle. What is sinodural angle? Sinodural angle is also called as Citili's angle. So this Citili's angle or the sinodural angle is the angle between the sigmoid plate and the middle cranial fossa dural plate. So the angle between the sinus and dural plate is called as Citili's angle or the sinodural angle. Okay. So let us see in this picture. So this is the sinus plate and then we have the dural plate. So this angle here is nothing but the Citili's or the sinodural angle. Now we'll be looking into the various infections of the middle ear. The number one infection that we're looking at is nothing but serous otitis media. So serous otitis media also has certain other names. So what are the other names? It is also called as glue ear. Why is it called as glue ear? It is because of the thick sterile fluid that is there in the middle ear which resembles glue. It is also called as otitis media with effusion. Okay, so these two are the names of the serous otitis media. So it is nothing but collection of serous or sterile fluid in the middle ear without any signs of acute infection. As I told you, it is sterile, non-infected fluid which is collected in the middle ear. Now coming to what are the causes and the clinical features. In children, the number one cause is nothing but adenoid hypertrophy. Because the adenoids are hypertrophied, there is going to be disturbed in the function of the eustachian tube, because of which fluid accumulates in the middle ear. So what are the features? The child has adenoid facies. So what are the features that comprises of the adenoid facies? I'm going to tell it to you. Okay. And coming to the clinical feature, number one, the child has adenoid facies. Let us look into the various things that are seen in adenoid facies. The child has an elongated face. Okay. And along with elongated face, it is going to be very dull looking child. And along with the dull looking child, it also has mouth breathing. So these three are the classic features, and clinically you can see certain other signs as well. That is, there is crowding of the teeth, there is upturned nose. Why is there upturned nose? Or it is also called as pinched in nose because of the disuse of the ali nasi. And also there is high arched palate and hitched up upper lip. These are all going to be features of the adenoid facies. Now, these children, when they have the serous otitis media, they have certain clinical features. So what are these clinical features? There is going to be fluid filled in the middle ear, because of which they have hearing loss. What type of hearing loss we are looking at? We are looking at fluctuating hearing loss. And fluctuating painless hearing loss. Why is it fluctuating? Because whenever you treat the child with certain medications, the fluid in the inner ear is going to come down and the hearing loss improves. That is why it is called as fluctuating. And here, whatever fluid is there, it is only going to cause pressure effects. Therefore, it is painless. Bilateral, fluctuating, painless, conductive hearing loss. Why is it conductive hearing loss? Because the sound conduction is affected by the fluid that is there in the middle ear. Okay. And then we have seen the features of adenoid facies already. In adults, if we look at serous otitis media, usually it is going to be unilateral serous otitis media that we see. It is going to be a red flag because only in certain conditions like that of nasopharyngeal carcinoma, we will be looking into serous otitis media in adults. So, if we see unilateral serous otitis media, immediately do investigations pertaining to nasopharyngeal carcinoma. Okay. Now, in the otoscopy, what are you going to see? The tympanic membrane is going to look bluish because of the fluid collected. It is going to be intact, no rupture, no perforation, intact, bluish, retracted tympanic membrane is going to be seen. Apart from this, the tympanic membrane will also show air fluid levels because there is going to be air and fluid in the middle ear which is seen through tympanic membrane, or in the later stages you can also see air bubbles through the tympanic membrane. We looked into the clinical features of serous otitis media. Now we'll look into the investigations and treatment of serous otitis media. Now coming to investigation, the number one thing that we do is tuning fork test. So we do Rinne's and Weber's. So usually when we do Rinne's in a condition of serous otitis media, the bone conduction is always going to be greater than the air conduction. What is it going to signify? It signifies a conductive hearing loss. Now, when we talk about Rinne's, you need to know that there are two things that are important. One, it could be positive Rinne's when the air conduction is better than bone conduction, or it could be negative when the bone conduction is better than air conduction. So, when is it going to be positive? In a normal ear, it is going to be positive, or it is going to be positive in the case of sensory neural hearing loss. But when we take Rinne's as negative, which is the bone conduction being higher than the air conduction, it occurs in the conductive hearing loss and also in severe sensory neural hearing loss. This is something that you have to remember. Now, coming to the Weber's test, there is a very famous mnemonic that everybody uses, that is SOCS. So, what is SOCS? Whenever there is sensory neural hearing loss, S stands for sensory neural hearing loss, the hearing or the Weber's, it is lateralized to the opposite ear, that is the better ear. Whereas, whenever there is conductive hearing loss, the Weber's is lateralized to the affected or the worst ear. So, in this condition, as we saw, it is conductive hearing loss. So, where does the Weber lateralize? It lateralizes to the affected ear. Okay. Now, coming to the pure tone audiometry. Pure tone audiometry shows a conductive hearing loss picture, and as we all know, whenever there is conductive hearing loss, there is going to be an air-bone gap of more than 15 decibel. Air-bone gap is going to be present. Okay. So, these are the very simple tests that we do. Now, are we going to confirm a serous otitis media just with these investigations? No. We are going to do a confirmatory test. What is the confirmatory test? It is called as tympanometry. So, this tympanometry gives us a B-shaped curve, and whenever there is B-shaped curve, it tells us that there is going to be fluid in the middle ear. Also, it is one of the best tests or the earliest test to be done in children. Why is this the earliest test done in children and not PTA? It is because these children, they are very notorious, no? This PTA is a subjective test. You give them clicks of sound and ask them whether they can hear it or not. But children, they are not going to cooperate with you. Therefore, tympanometry becomes the earliest test that you do with children. Now, coming to management, initially you are always going to try the medical management in these children. You are going to treat them medically and you keep them in observation. How do you observe? Each month, you do a tympanometry test and see if the B type of curve is disappearing. If even after 3 months, if the B type of curve persists in tympanometry, then you have to surgically correct the situation. So what do you do surgically? You give an incision, that is, you do something called as myringotomy, and then you place a grommet. Myringotomy plus grommet insertion, and then if the child also has enlarged adenoids, you do an adenoidectomy. Now coming to myringotomy, that is nothing but a radial incision in which quadrant? In the antero-inferior quadrant. Why do you give incision in the antero-inferior quadrant? Because I told you in the initial slides that antero-inferior quadrant is a quadrant where you have eustachian tube, and you are going to do something so that the eustachian tube functioning is made better. Therefore, you are going to place grommet in the antero-inferior quadrant. Okay. So, you are also going to place short-term grommets. What do you understand by short-term grommets? The grommets which self-extrudes in less than 6 months. So, you might ask me, why are we not placing a long-term grommet? If we place a grommet for more than a year, it gives better benefit to the child, no? No, we are placing short-term grommet because the functioning of the eustachian tube usually improves after the child turns 7 years old. Because by the time the child turns 7 years, there is maturation of the eustachian tube happening and the functioning improves substantially. Therefore, a short-term grommet would suffice and do all the needy changes in the child. Okay. Now coming to the incision, it is a radial incision. Now this is the tympanic membrane that we are looking at, and this is how you have the malleus, and this is the cone of light. Okay. And coming to the quadrants, you have the anterior superior quadrant, you have the anterior inferior quadrant, posterior superior quadrant, and posterior inferior quadrant. Now, based on what I have taught you, tell me whether this is a right tympanic membrane or a left tympanic membrane. I told you that if the cone of light is pointing towards the right side, it is a right tympanic membrane. Okay. So, you are going to place grommet here in the antero-inferior quadrant. Okay. And you are going to do a radial incision as I told. How does a radial incision look like? Like a radius of a circle. It is a straight incision, and after you place a grommet, it is going to come tightly and hold the grommet in place. There is also one more type of incision that you have to know of, which is nothing but a curvilinear incision, which looks something like this. When do we do a curvilinear incision? We do it whenever there is a lot of pus or fluid collecting in the middle ear, so that when we give this incision, all the pus and fluid comes out and the pressure symptoms get relieved. And where is this incision done? It is done in the posterior inferior quadrant of the tympanic membrane. Where is a radial incision done? In the anterior inferior quadrant. Now coming to the next condition of the middle ear, we will be looking into glomus tympanicum. What is glomus tympanicum? This is a middle ear tumor which arises from the glomus cells. So, it is a middle ear tumor arising from the glomus cells. Okay. So, this glomus tympanicum shows a red reflex because of the increase in the vasculature. There is increase in the red reflex which presents to us as a rising sunshine. Some people call this rising sun even as a setting sun, because a rising sun and setting sun appear same, right? There is increase in the red reflex. So, if you look at the image here, you can see that the lower portion is pulsatile and it is reddish in color. This is nothing but the rising sun appearance, whereas the upper part of the TM looks very normal. Okay. Now, if you try to increase the pressure in the external auditory canal using a Siegel's speculum, initially this tumor is going to pulsate vigorously, and then at a point it starts blanching. This sign is named, and this sign is called as the pulsation sign, or this sign is also called as the Roundz sign. Okay. Now, what is the investigation of choice for glomus tympanicum? It is nothing but contrast enhanced CT. So, when you do this, you are going to see that there is erosion of crust of bone between the internal carotid artery and the jugular plate, and this sign is called as flap sign. So, if you look at this image of a CT here, there is a bony crest here. This bony crest is between the internal carotid artery and the jugular plate. But if you see in the other side, this crest of bone is absent. So, this is nothing but the flap sign. Now going to the various other conditions of the tympanic membrane, the number one condition is bullous meningitis. What is bullous meningitis? Mering is tympanic membrane. Itis, infection, inflammation. Inflammation of the tympanic membrane with bullous appearance is called as bullous meningitis. What is the most common cause? There are various causes. They are nothing but the Streptococcus pneumoniae. The other organisms are the Haemophilus influenzae, and we also have one more organism which is nothing but Mycoplasma pneumoniae. So these three organisms are most commonly implicated in bullous meningitis. The patient presents to you with lot of pain and ear discharge. These two are the classic signs: pain, ear discharge. And if you look at the tympanic membrane, as you can see in the image, the tympanic membrane is grossly congested, plus there are a lot of bullas that are seen on the tympanic membrane. We also have another similar condition called as acute otitis media. Here also the patient comes to you with similar features: intense pain, lot of pain. They are going to be holding their ears from pain. There is going to be discharge from the ear. And along with these two, they also give history of upper respiratory tract infection. So, in your MCQ, they are going to give you a scenario where they mention about intense pain, discharge, tympanic membrane grossly congested. So, what are the two differential diagnoses? It could be acute otitis media or bullous meningitis. Now, if it is acute otitis media, there is always a history of upper respiratory tract infection, and that is a clincher you have to look for in such questions. Okay. Here in acute otitis media, the TM is congested, as you can see here, and it also has a appearance called as cartwheel appearance. That is, there is circumferential congestion seen on the tympanic membrane. Okay. So what happens? There is a lot of pressure that is going to build up, and there could be even rupture of the tympanic membrane if it is not treated. What is the treatment of choice? You are going to give antibiotics to this patient. Also in this condition, there are two signs that you have to know of. What are the two signs? These are nothing but lighthouse sign, and also you have to know about the pulsation sign. So what is pulsation sign? Whenever there is a small rupture happens in the TM because of acute otitis media, with each heartbeat, okay, with each heartbeat, you can see a pulse of discharge coming out of tympanic membrane, which is called as pulsation sign. Also, with each pulse of these discharge, at the same time, if you try to look into the ear with an otoscope, the light is going to reflect back. One time there is discharge, light reflects. Stops reflecting, again there is discharge, light reflects. It is similar to that of a lighthouse beacon which you see near the sea. Therefore, it is called as a lighthouse sign. Okay. Now coming to the next condition, we look into tuberculous otitis media. So what is tuberculous otitis media? Nothing but tuberculous infection of the ear. Okay. So here also the patient presents to us with discharge, and the discharge is going to be serosanguinous type of discharge. And if you look into the tympanic membrane, there is going to be multiple perforations in the tympanic membrane. Usually, always when you see tympanic membrane, there is going to be a central perforation, or there can be a marginal perforation. Very rarely there could be multiple perforations, and one of the most important differentials that could come to your mind is nothing but a TB of the ear. And this discharge is going to be very foul smelling discharge, and the patient has hearing loss of more than 40 decibels. This is going to be the hearing loss in these people. Also, when you look into the tympanic membrane, it is going to look very pale and it is going to look granular in appearance. So, what is the treatment? Like any TB in the body, you are going to give the patient with anti-tubercular therapy. Now moving into two of the most important conditions of the middle ear that as UGs all of us would have done a case presentation on in your final exams. What are these? Chronic suppurative otitis media, safe and unsafe type. Firstly, we look into the safe type, which is also called as mucosal. So mucosal chronic suppurative otitis media is also called as safe type of otitis media, or it is also called as tubotympanic type of otitis media. So, in this tubotympanic type of otitis media, what is the abnormality seen in the tympanic membrane? There is usually a central perforation that is seen in the tympanic membrane. The pars tensa is involved here, whereas the annulus is going to be spared in the mucosal type of CSOM. So, what do you understand by this statement? If you look into the tympanic membrane, so this is the picture of a tympanic membrane. You have the handle of malleus. Which side of tympanic membrane is this? Is it right or left? This is nothing but right tympanic membrane. Because it is turned to the right, you have the cone of light pointing towards the right side. So, this area on top is nothing but pars flaccida. And this area in the lower part is nothing but the pars tensa. And this tympanic membrane has a perforation in one of these quadrants. Central perforation. Got it? And as I told you, there is erosion of the annulus is intact in the safe type. So, what is annulus? If I can draw a margin like this, this thickened portion of the tympanic membrane which goes and sits in the tympanic sulcus is called as annulus. In safe type, annulus is intact, whereas in the unsafe type of chronic suppurative otitis media, this annulus is distorted or this annulus is eroded. Got it? Okay. Now, coming to the type of perforation, in long-standing cases and if it is a bigger perforation, it becomes a non-healing perforation. Now, tell me what are the different layers of the tympanic membrane? It's a revision. The first layer, the outer layer, which is epithelial, the middle layer, which is fibrous, and the inner layer, which is nothing but the mucosal layer. Now, whenever there is a perforation, what happens? If it is a small perforation, the tympanic membrane usually heals. And it heals by two layers. Which are the layers? Epithelial and mucosal, and the fibrous is absent, because of which the tensile strength is not there, the tympanic membrane is weak. But if it is a larger perforation, what happens is that, for example, this is your tympanic membrane and this is your perforation. Always remember, the epithelial cell growth rate is more than the mucosal layer. So, the epithelium tries to grow and invaginates and goes and finally meets the mucosal layer. Okay. So, there is going to be close in the whatever perforation that was there because the walls approximate and meet each other. Therefore, preventing the further closure of the entire perforation. Okay. Now, what are the etiology of this perforation? There could be trauma or there could be acute suppurative otitis media which causes perforation because of lot of pressure built up, and within 3 months, if it doesn't heal, it is going to form a relatively permanent central perforation. Okay. And whenever there is repeated infection, this perforation will not heal and it will become a permanent perforation. So, how is the ear discharge? This ear discharge is going to be profuse. That is, there is going to be lot of discharge, and it could be either mucoid type of discharge that is seen, or the discharge could be mucopurulent discharge. It is a painless condition and it is non-foul smelling. Okay. Why is there profuse discharge? Because of increased secretions from the goblet cell or the mucus cells. Whenever there is infection, there is a reflux increase in the secretions because of the goblet cell and mucus cell hypertrophy in order to clear the disease. Okay, that is why there is going to be profuse secretion seen here. Now, the hearing loss could be present or absent. In later stages, when there is no treatment given at proper time because of bony erosion, there could be higher degree of hearing loss in these patients. Now, how do we manage these conditions? Initially, we can always go for a medical treatment because it is safe type of chronic otitis media. You give antibiotics to these patients. You can give both systemic and local antibiotics. Local in the form of antibiotic ear drops. Also, you can clean the ear canal. You can do oral toileting to remove any excess secretions. Then, if this is not working, you can always go for a surgical management. You can do myringoplasty, which is nothing but repair of the tympanic membrane. Also, you can do a tympanoplasty, which is repair of the tympanic membrane plus the ossicles. So, when you repair both ossicles and the tympanic membrane, it is called as tympanoplasty. And when you do this, your main objective is to make the ear dry and to restore hearing in these people. So this is about the safe type of CSOM. Now the second type of chronic suppurative otitis media that we're looking into is nothing but squamous type of chronic suppurative otitis media. This squamous type of disease also has some other names. It is called as unsafe, or it is also called as atticoantral disease, because here the attic, the antrum, everything is going to be affected. Okay, so what is the abnormality here? We are going to see a marginal perforation, or we are going to see a retraction pocket. So in the previous type of CSOM, what type of perforation were we looking at? We saw central perforation. But here the margin is eroded, because of which you have a marginal perforation. So if you look into this tympanic membrane, these are the margins of the tympanic membrane, and with this blue color I am going to point at the marginal erosion. At this place the margin is perforated. Therefore, this becomes an unsafe type of chronic suppurative otitis media. Also, if there is retraction which develops because of chronic negative middle ear pressure, it also comes under the unsafe type of chronic suppurative otitis media. Okay. Here, what is the status of annulus? The annulus is eroded. Now, coming to the abnormality, one extra thing that you have to know here is the cholesteatoma sac that is present. So, cholesteatoma is a three-dimensional structure containing the keratin debris which is there in the middle ear, which is going to replace the normal structures in the middle ear and can cause pressure effects and damage to the surrounding structures as well. Okay. Here also etiology, it is because of the chronic tubotympanic disease turning into a atticoantral disease, superadded by infections and superadded by negative pressure, or even the congenital cell rests that are there. It can also cause cholesteatoma formation. Now coming to the ear discharge is going to be scanty. Why is there scanty ear discharge? Because unlike the tubotympanic type of disease, here there is going to be lot of bony erosions or osteitis that happen. Whenever there is bony osteitis that happen, there is going to be lot of dead cells, and because of the decomposition of these cells, there is going to be little secretions that come out, which is going to be very, very scanty in amount. Okay. First of all, the secretions are scanty. Okay. And whatever cholesteatoma formation starts, this cholesteatoma collects all these secretions in the form of keratin debris and prevents them from going out, which further makes the secretions very scanty. Okay. It could be blood tinged. It is blood tinged because of the formation of the granulation tissue inside, and also it could be very foul smelling because of the bony destruction that is taking place inside the middle ear. Okay. Now coming to the hearing loss, because all the ossicles are eroded, there is often a higher degree of hearing loss compared to that of a tubotympanic disease. On examination by otoscope, what do you see? You can see lot of granulation in the external auditory canal. You can see granulation in the tympanic membrane. You can see retraction or a marginal perforation in the tympanic membrane. Sometimes these granulation appear as a red fleshy polyp, and whenever it appears as a red fleshy polyp, you should never avulse them, because these polyps could be having a higher degree of vascular supply, and when you avulse it, there could be lot of blood loss that happens in these patients. Sometimes these polyps could just be a glomus jugular, so you should never avulse these. What is the management? The management is always surgical. What type of surgery? You will always aim at restoring the tympanic membrane, restoring the ossicles, and clearance of the cholesteatoma sac. Now, we look into the complications of otitis media. Now, a patient has otitis media. He comes to you, seeks treatment initially, but later he sees to it that the ear discharge comes and goes again and again. He gets fed up of the treatment and doesn't show up. Finally, he is going to land up in your clinic after 2 to 3 years with severe headache, convulsions, nominal aphasia. He is not able to name anything, and also he says that a particular portion of his vision is blurred. What are you going to suspect in this patient? It is a complication of chronic otitis media, which is nothing but temporal lobe abscess. There are also various other complications that could happen, and we'll look into few of those. Coming to certain extracranial complications, they are the facial paralysis. Because of the close proximity of the facial nerve in front of the external auditory canal, also in the middle ear, the horizontal and the vertical segment of the facial nerve and chorda tympani are related. The horizontal in the medial wall, the vertical segment in the posterior wall, chorda tympani in the posterior wall, all these structures could be damaged because of cholesteatoma, causing extracranial facial paralysis. There could be subperiosteal abscess that could develop, mastoiditis could develop, and labyrinthitis. The infection can spread from middle ear through the inner ear, affecting the labyrinth and turning into labyrinthitis. If there is labyrinthitis, patient presents with vertigo, sensorineural hearing loss, pressure symptoms, and much more. Coming to the intracranial complications, these are the complications pertaining to the brain. There could be meningitis, infection and inflammation of the meninges, cerebral abscess, abscess in the cerebral hemisphere, lateral sinus thrombosis, and extradural abscess. These are the intracranial complications. Which is the most common site of otogenic brain abscess? What do you understand by otogenic brain abscess? That means infection is there in the ear and it is spread to the brain. Most common type is nothing but the temporal lobe abscess. Why is temporal lobe abscess most common? It is because, as I told you, the superior wall of the middle ear, the superior wall is nothing but the roof of the middle ear, is the wall which separates the middle ear from the middle cranial fossa. If there is a problem here, the infection is directly going to go to the temporal lobe. Okay, and the second most type of abscess is nothing but a cerebellar abscess. So when a patient comes to you with the above mentioned features, you are going to do a contrast enhanced CT. Okay, so when you do the contrast enhanced CT, you are going to see something like this image. You are going to see a ring enhancing lesion. So you can see here, it is a ring enhancing lesion in the temporal bone, which suggests that it is a temporal lobe abscess. Along with it, the patient also complains of, first of all, he is going to have ear discharge because the main problem is in the ear. With that, he is also going to complain of headache. He is also going to complain of vomiting, and in severe cases, because of increase in the intracranial pressure, there could also be convulsions seen in this patient. What is the treatment? It has already spread to brain. You can't do anything. You have to seek neurosurgery intervention who will do some burr hole and remove this abscess. There are also certain other features that you have to know in the temporal lobe abscess, which are like the answer clinchers in the questions that comes for your NEET PG. The number one thing is, whenever there is temporal lobe abscess, the patient will have convulsions. Number two thing is that they will have something called as nominal aphasia. That is, they are not able to say the names of things. Three things, they will have homonymous quadrant anopia. What do you mean by homonymous quadrant anopia? It is also called as pie in the sky appearance. So, if this is the visual field, it is homonymous, no? So, one side, see this side, in the right eye and left side. Homonymous means same quadrants in both the eyes. The superior quadrant is going to be affected, called as pie in the sky appearance. Homonymous supraquadrant anopia. They also have one more feature, that is nothing but contralateral motor paralysis. When all these features are seen in a patient with chronic long-standing ear discharge, always think of temporal lobe abscess. And there is also one more complication called as petrositis. Petrositis is also an extracranial complication. What happens in petrositis? There is something called as a triad. What is the name of the triad? It is called as Grad-Inigo triad. So, what are the features in Grad-Inigo triad? Number one, there is going to be retroorbital pain. That is severe pain behind the eyes because of cranial nerve 5 involvement. There is also diplopia. Why is there diplopia? It is because of the cranial nerve 6 involvement. And as you all know, what could be the third feature? It is nothing but ear discharge. Classic, because this petrositis happens because of a ear pathology. So when you have these three things in the question, retroorbital pain, diplopia, ear discharge, immediately think of petrositis. What is a triad called as? It is called as Grady-Nikos triad. Now, in your PG exam, you get a question where a 30-year-old female comes to your OPD complaining of conductive hearing loss in bilateral ears. She says that initially she had little hearing loss. Now the conductive hearing loss has progressed. She has this hearing loss in both her ears. And after pregnancy, her condition worsened. And when you do an examination, you see that there is going to be a pinkish, a flamingo pink tinge in the posterior superior quadrant of the tympanic membrane. What are you suspecting? Yes, I'm hearing it right. The condition that you're thinking of is nothing but otosclerosis. So, what is the site of origin of otosclerosis? It is nothing but fistula antifenestrum. This is the area from which the otosclerosis starts growing. Fistula antifenestrum is nothing but the enchondral layer of the otic capsule. This is the initial site where the bony remodeling starts. Okay, so the overgrowth occurs around the oval window, and the bony overgrowth around the oval window is starting to grow so much that it leads to the fixation of the stapes footplate. Okay, and when the stapes footplate is completely fixed, it becomes a full-fledged otosclerosis. Okay, what is the type of hearing loss? It is going to be bilateral conductive hearing loss. That is, it is also going to be progressive. As I told you, the lady that came to us, same thing, bilateral conductive hearing loss which progressed. What is the age group? 20 to 30 years. What is the sex predilection? The females are affected more than men because this condition has certain hormonal etiology to it. The patient can also complain of paracusis vellici. What is paracusis vellici? That is, the patient hears better in a noisy environment. Why does the patient hear better in a noisy environment? It is because a normal person obviously increases his tone in a noisy environment. That time this patient can hear it better. And this is a classic feature which is seen in otosclerosis called as paracusis vellici. What are the aggravating features in our patient? What is the aggravating feature? Nothing but pregnancy. One more most important aggravating feature that can come in your exams, measles, because of the hormonal changes that could occur in these conditions. Coming to the family history, remember otosclerosis has a very positive family history. It is an autosomal dominant condition with incomplete penetrance. What are the otoscopy findings? In around 90% of the patients, the tympanic membrane is going to look whitish, pearly white in appearance, whereas in 10% of the population, it shows a flamingo pink color. What do you understand by flamingo pink? It means that there is active phase of the disease because of increased vascularity. The posterior superior quadrants look flamingo pink. In only 10% of the population we see this, and the sign is nothing but the Schwartz sign. Okay. Every time when you see features similar to that of otosclerosis, if you put your otoscope, you're not going to see Schwartz sign because it is seen only in 10% of the population. When you get a HND, histopathology, you see something called as blue mantle of Meniere in the enchondral layer. Why do you see it? It is seen because of the abnormal bone formation in the otic capsule, because of which you see the blue mantle of Meniere in the histopathology. Now coming to one more type of otosclerosis, it is nothing but cochlear otosclerosis. What do you understand by cochlear otosclerosis? The bony overgrowth which is there around the oval window now goes inside the cochlea, extends to the cochlea, resulting in cochlear otosclerosis. So when we have this cochlear otosclerosis, there is a typical sign that we are looking at, and this sign is seen in high resolution CT scan of the temporal bone, HRCT, which is called as the halo sign, or it is also called as the double ring sign. Okay. So what is the double ring constituting? See, if you see the image here, this is a HRCT image which shows initial first ring, which is nothing but the normal bony labyrinth. This is the first ring. Now coming to the second ring, what is the second ring? It is the hypodense area, hypodense lucent area that is there around the cochlea. This otosclerotic foci forms the second ring. So this is the second ring. So therefore it is called as a double ring or a halo sign. So what are the tests that you do to find out about otosclerosis? You do a Rene's test. In Rene's test, as we all know, it is a conductive hearing loss, and in conductive hearing loss, the bone conduction is going to be better than air conduction, making Rene's negative. And it is seen in bilateral ears. Coming to Weber's, what was the mnemonic that we learned? SOCS. Sensory neural opposite, cochlear and conductive same. Here it is a conductive hearing loss, so the Weber's is going to lateralize to the same affected ear, and in some cases it could be even central. Now coming to Gell's test, it is going to be negative. What do you understand by Gell's test? So how do we do Gell's test? We are going to take a tuning fork which is vibrating and we are going to place it in the mastoid. Okay. After that, we are going to take a Seagull speculum and we are going to increase and decrease the pressure in the external auditory canal. So when we increase and decrease the pressure, whatever sound the patient was hearing through the tuning fork kept on mastoid, if it remains same, that means the test is positive. But with increase and decrease in the pressure, that is, when you increase pressure, if the patient hears less sound, and once the pressure reduces, if the patient hears more sound, it is called as negative, and this negativity is seen in otosclerosis. So Gell's test is one of the very specific tests for otosclerosis. In PTA, what do you see? You see a conductive hearing loss picture. There is going to be a Cahardt's notch, that is a notch, a dip at the 2K in the bony conduction is called as Cahardt's notch, is very much diagnostic of otosclerosis. And after you do a surgical correction, this Cahardt's notch gradually decreases. Okay. In tympanometry, what type of curve is seen? AS type of curve is seen because of the stiffening of the ossicle. Stapedial reflex is going to be absent, and the best test is nothing but impedance audiometry. Can you guess why impedance audiometry is the best test? It is because when the ossicle, the stapes, the footplate is affected, the impedance action of the middle ear is eventually going to be affected. That's why impedance audiometry, which is the sum of tympanometry and stapedial reflex, is going to give us the best possible test and the diagnosis of otosclerosis. How do we manage it? In active cases where we can see Schwartz sign, we are going to give the patient sodium fluoride so that the bone cells mature. Once the bone cells mature, we are going to do a stepidotomy and we are going to place a Teflon prosthesis. How do we know that this is giving benefit to the patient? It is because the hearing loss improves after you do a Teflon prosthesis. Now we'll look into one of the most important complications of chronic suppurative otitis media, which is nothing but mastoiditis. As the name suggests, what do you understand by mastoiditis? Infection in the mastoid is called as mastoiditis. So what are the clinical features? One, similar to that of chronic suppurative otitis media, there is going to be increased ear discharge that is seen. Along with that, there is going to be edema and there is going to be tenderness around the mastoid area. Also, there is going to be ironed out mastoid appearance. So, the patient comes to you with lot of ear discharge, and when you look at the posterior part, there is going to be swelling, edema, redness that is seen, and also any bony mark. So usually when you palpate the mastoid, you're going to feel the mastoid bone. Here you can't see any mastoid bone. You cannot palpate anything. There is going to be loss of the bony marking. It is called as ironed out mastoid. So if you look at the image here, it looks like a ironed out, neat appearance without any undulations of the bone. No, this is nothing but a picture of ironed out mastoid. On examination post-auricularly, as I said, you are going to see ironed out mastoid, which is nothing but loss of the bony landmarks. And if you look into the external auditory canal, there is going to be sagging of the posterior superior part of the external auditory canal. Because in the posterior superior aspect, you have the mastoid. It is completely filled with pus. therefore pushing the posterior superior part of the EAC forwards and downwards. That's why you are going to see sagging when you see through the otoscope. Okay. Now, there are so many abscesses that are related with mastoiditis. So, what are these abscesses? One is the post-auricular abscess, which is the most common abscess, develops in the posterior part of the ear. Next, we have Bezold's abscess. This is the abscess which is related to the sternocleidomastoid muscle. Next, we have the Citillus abscess, which is related to the posterior belly of digastric. So, the abscess related to the posterior belly of digastric is called as Citillus abscess. And this abscess, if it is related to occipital region, even then it is called as Citillus abscess. Next, we have Lux abscess, which is related to the posterior part of EAC, posterior part of external auditory canal. Then it is called as Lux abscess. Okay. There is also one more important sign that you have to know in the case of mastoiditis. It is nothing but reservoir sign. And how do you see this reservoir sign? Through the otoscopic examination. What is reservoir sign? That is, the external auditory canal is completely filled with pus and discharge. You are going to do an oral toileting, you are going to clean everything. But even then, the next second you put otoscope, you can see that the external auditory canal is completely filled. Why is this happening? Because the mastoid is acting as a reservoir from which pus gets filled into the external auditory canal. The medical management you can always try with intravenous or the parenteral antibiotics. If there is no response within 48 hours, you can always go for a surgical management. That is, you can go for a simple or a cortical mastoidectomy. What is the other name for simple or cortical mastoidectomy? It is nothing but a Schwartz surgery. Where did we see the word Schwartz? Yeah, the active phase of otosclerosis has a flamingo-pink color in the posterior superior quadrant, which is also called as Schwartz sign. So, when you do this mastoidectomy, a cortical or simple mastoidectomy, the cavity, the mastoid cavity is going to appear like this. So, this is a post-op mastoid cavity that you can see on the operation table. Okay. Now, looking at another condition, we look into another complication of chronic suppurative otitis media, which is called as sigmoid sinus or lateral sinus thrombosis. So, what do you understand by sigmoid sinus or lateral sinus thrombosis? There is a thrombus which developed as a complication of chronic suppurative otitis media, which is gone and deposited in the lateral sinus. Okay. So, when you look at the clinical features, you have all the features of otitis media. That is, you have ear discharge, you have pain, you also, this is a complication, right? So, you also have fever. In mastoiditis, do you have fever? Yes, even in mastoiditis, you have fever. Okay. And a very classic peculiar type of fever that is seen in lateral sinus thrombosis is called as picket fence fever. Picket fence fever is also called as, what is the other name? Can anybody guess? It is also called as hectic fever. So, what is the significance of this picket fence or hectic fever? There is thrombosis in the lateral sinus thrombosis. No? Each time an emboli is left into blood circulation, there is going to be spike in the fever, and then the fever comes down. A second emboli is released, fever goes up, comes down. So, this pattern, it looks like a fence, no? Therefore, it is called as a picket fence fever or a hectic fever. Remember, this will never touch the baseline. This is how the fever looks like. There is also an important sign that you have to know of. The sign is called as Gressinger's sign. So, what is Gressinger's sign? It is nothing but the edema and the redness and the swelling that is seen in the mastoid region and the tenderness seen in the mastoid region as a complication of lateral sinus thrombosis when the thrombus goes and lands in the mastoid emissary vein. It is going to go to the mastoid emissary vein. Where is the mastoid emissary vein? It is here. So, there is going to be edema and swelling. It is called as Gressinger's sign. So, you might ask me a question. There is edema, then there is swelling and tenderness in the mastoid. Even in mastoiditis, we have the same features. How do you say this is Gressinger's or lateral sinus thrombosis and that is mastoiditis? There is a simple differentiating feature. It is that, number one, let us look at mastoid features. What are the mastoid features? Tell me. It is edema, tenderness. And what is the third feature? Most important, ironed out mastoid. Okay. So these are features of mastoiditis as well as Gressinger's syndrome. But there are two extra things, that is, if the posterior superior wall of the EAC is sagging, plus there is reservoir sign. If these two signs are present, then you have to always say it is mastoiditis. If these signs are not there, that is, if these signs are negative, then it is always, what is it we are looking at? We are looking at the Gressinger's syndrome. Gressinger's syndrome is seen where? In the lateral sinus thrombosis. Got it? Okay. Now, instead of going into the mastoid emissary vein, your thrombus has dislodged and gone into the internal jugular vein. What happens? Where is the internal jugular seen? In the neck, right? So you have severe neck pain. Along with that, when you try to increase the pressure on compressing the normal internal jugular vein, there is going to be increase in the intracranial pressure. This is called as Tobey-Ayers sign, or it is also called as Quickensted's test. Okay. There is also papilledema that is seen when you press the normal internal jugular vein. This papilledema, which is seen in fundoscopy, is called as Crowe-Beck sign. This is a fundoscopy image which is showing papilledema. Okay. Now we can do CT or MRI, and when you do CT or MRI, you get a classic sign which is called as a delta sign, which is also called as a empty triangle sign. Why is it called as delta or an empty triangle sign? If you look here, this arrow, this area, no, there is a hollowness that is seen. Why there is hollowness? Because the thrombus that is lodged here won't take up the contrast, therefore giving you an empty triangle or a delta appearance. How do you manage it? You give parenteral antibiotics, nothing but IV antibiotics, and the surgery of choice is nothing but modified radical mastoidectomy. So now we have seen most of the conditions of the middle ear. We have seen the complications arising if these conditions are not treated well. Now we'll take our discussion forward into diseases of the inner ear. The first disease that we're looking at today is nothing but endolymphatic hydrops. So endolymphatic hydrops is also called as Meniere's disease. So what happens in Meniere's disease? There is either excessive production of endolymph or there is defective absorption of the endolymph. Okay. So it is most commonly seen in the age group of 20 to 50 years. This Meniere's disease is equally seen in both men and female. So it doesn't have any sex predilection and it is equally seen in both male and female. Now coming to the clinical features that the patient presents with, the number one symptom is nothing but vertigo. Now how is this vertigo in Meniere's disease? It is going to be episodic vertigo. And how long does this vertigo last? It is going to last somewhere between 20 minutes to 24 hours. And it is episodic. No? So the patient does not complain that he has vertigo every day. It is going to come in attacks and go. Next, this vertigo is also associated with aura. That is, he gets the feeling that he is going to feel dizzy and maybe fall even before he gets an attack of vertigo. And he also experiences vagal symptoms. What type of vagal symptoms are experienced by the patient? He says that he feels like he is sweating, he feels like he is nauseous, and he also feels like he pukes at times. So these are the vagal symptoms that the patient experiences. Now coming to two important named phenomena that you have to know in Meniere's disease, they are Tullius phenomena and Henneberg sign. So what is Tullius phenomena? That is the vertigo attacks that are triggered by loud sounds. That is, the patient is absolutely normal. Somewhere he gets exposed to excessive loud sound, suddenly he feels giddy. This is nothing but Tullius phenomena. Now coming to Henneberg sign. What is Henneberg sign? Here also vertigo is triggered by pressure changes. So anytime there is change in the pressure in the surrounding, he gets a triggered attack of vertigo. So these are the two name signs that you have to know. Now coming to hearing loss, what type of hearing loss are we seeing here? Is it sensory neural or conductive type of hearing loss? It is obviously sensory neural hearing loss. Why is it sensory neural hearing loss? Because the inner ear is affected here, hence it is going to be sensory neural hearing loss. And remember, this hearing loss is always going to present in one ear. It is going to be a unilateral type of hearing loss. Now, a question for all of you. Recently we saw a condition where there was bilateral hearing loss, conductive type and it was progressive. What was that condition? That condition was nothing but otosclerosis. Okay. So whenever you get a question somewhere or whenever you get a topic, you always try to, coordinate, you try to think about some related things that you studied so that it is going to be best form of revision. Okay. Now coming to the type of hearing loss, there is going to be low frequency hearing loss. Why low frequency hearing loss? Because the apex of the cochlea is going to be affected first, and apex of the cochlea is the one which is going to be receptive more for low frequency, right? So the patient has low frequency hearing loss initially, but as the disease progresses, all the frequencies is going to be affected and the audiogram is going to be a flat audiogram in the later stages. Now coming to two important signs again, they are nothing but diplaceusis and recruitment. So what do you understand by diplaceusis? It means that same pitch of sound is heard differently in both the ears. Now you might ask me, what is a big deal? He's hearing one intensity in one ear and the other intensity in another ear. What happens is that, for example, you imagine the patient is listening to one of his favorite songs. Let's keep Battamisable. What happens is that the sound becomes too harsh. He cannot tolerate the sound because the pitch that he hears is different in both the ears. Why is this happening? Because the fine tuning mechanism in the inner ear is lost. Okay. And then coming to the next thing. What is the next sign that I told about? The next sign that I told about is nothing but recruitment. What is recruitment? It is nothing but an abnormal build-up of loud sounds. This is called as recruitment. So normally what happens in these people, because they have hearing loss, the things that are spoken at a lesser intensity is not heard. Okay, but after a certain point, all the sounds, even a small increment raise in the sound becomes so bad, the sound becomes unpleasant, painful. You might have seen your grannies, no, who say that I can't hear anything, I can't hear anything. But once you raise your pitch and talk, they are like, why are you shouting? It is because of this phenomena called as recruitment. And this suggests a cochlear hearing loss. And this is not very particular in this condition of Meniere's. It is seen in almost all the conditions which affect cochlea. Okay. Now coming to what are the other symptoms, the patient also has oral fullness, that is fullness in the ear. He also has tinnitus. What type of tinnitus? It is going to be a roaring type of sound that the patient is going to hear. It is going to be a low pitched type of buzzing, roaring sound that he hears. There is something called as Tumacrine crisis that you have to know about. What do you understand by Tumacrine crisis? So these are nothing but drop attacks. So what do you understand by this term drop attacks? Here usually what happens, initially the cochlea is affected, no? So this fluid that is there in the cochlea, when it bulges so much and starts going into the next structures, which are the nearby structures, the utricle and the saccule. It is going to distort the sense organ of balance that is found here. What are the sense organ of balance that is found here? They are nothing but maculae. When these macula gets distorted, there is going to be deficient in the linear acceleration, which was mainly the functioning of the macula. So linear acceleration is affected. What is linear acceleration? You are walking straight, and which is controlled by macula. Because the macula is distorted, you cannot walk straight. The patient is normal, he tries to walk, but then he suddenly falls. There is no preceding sign that the patient gets like an aura saying that you're going to fall. He is walking, talking, just falls. But his consciousness is maintained. That is why it is not a syncope, but it is a drop attack. Now, coming to the various investigations and findings, we can do various tests. The initial test being the tuning fork test and the pure tone audiometry. As I told you, it is a sensory neural hearing loss. And in sensory neural hearing loss, what is the finding that you can see in a Rene's test? The Rene's test is going to be positive or negative. It is going to be positive. The air conduction is going to be better than bone conduction. Coming to pure tone audiometry. In pure tone audiometry, it is also going to give you a sensory neural hearing loss picture, but it also gives you a upsloping audiogram. Upsloping audiogram, especially in the earlier stages of the disease, because as I told you, there is going to be the low frequency sounds which are affected most, and as the disease progresses, the mid frequency and the higher frequency sounds are also affected. Now coming to CSI. What is SISI? SISI is nothing but short increment sensitivity index. It is going to be around 70 to 100% in these patients. So why there is going to be increase in SISI? It is because of the phenomena called as recruitment. So what is recruitment? I told you earlier, abnormal development of loud sounds. That is, after a point, even a 1 decibel increment in the sound is perceived as abnormally disturbing, loud, painful. So because of this condition called as recruitment, SISI is going to be around 70 to 100%. Now coming to electrocochleography. Electrocochleography is one of the main investigation done in Meniere's. So this electrocochleography is going to give us a ratio of more than 45% or more than 0.45. Why is it showing this value? Do you know what is a normal value? The normal value is less than 30%. Okay, and electrocochleography is nothing but a ratio of the summating potential by the action potential. So what is summating potential? It is the total activity of the inner hair cell plus the outer hair cells combined. But in a case of Meniere's, what happens is that there is going to be increased sodium around the hair cells. When there is increased sodium, all these cells undergo depolarization easily. When all these cells depolarize, there is going to be increase in the summating potential. This is one thing that you have to remember. Now coming to our denominator. What is our denominator? Action potential. What is action potential? This is nothing but the potential of the nerve. This potential of the nerve, is it going to change in Meniere's? No, it is not going to change because the nerve is not affected. Only the cochlea is affected. Therefore, coming back to the maths that we studied in our high school. If numerator increases and denominator stays same, is the ratio going to increase or decrease? It is obviously going to increase. Therefore, a ratio of more than 45%, it is nothing but suggestive of Meniere's. Got it? So, this electrocochleography is one of the most important tests that we do for Meniere's. Next, we have a test called as glycerol test, one of the basic and earliest tests developed for Meniere's. That is, whenever you give glycerol, because of its hygroscopic action, there is going to be improvement in the hearing and improvement in signs of vertigo. Therefore, the glycerol test is going to be positive in these people. Now coming to the management, how do you manage these people? Initial thing that you can ask these people to do is nothing but salt restricted diet. Whenever salt restriction is followed, there is going to be decrease in the production of endolymph. And also, you can ask the person to cut down on any type of vasoconstrictor that the patient is taking. What are the common vasoconstrictors? Can you name a few? Vasoconstrictors like nicotine, tea, coffee, chocolates, these things to be avoided so that there is going to be symptomatic improvement in the symptoms of vertigo, in the symptoms of other symptoms of Meniere's disease. Coming to other medical management that the patient can try, he can try using labyrinthine sedatives. Labyrinthine sedatives, what are the few examples of labyrinthine sedatives? You have cinerizine, chlorperazine, and some more labyrinthine sedatives can be used. The patient can also use vasodilators. Example of vasodilators, for example, beta-histine, which significantly increases blood flow to the small vasculature that are around cochlea. The patient can also use diuretics, which decreases the amount of the endolymph. He can use trans-tympanic steroids. So these are the various medical management that the patient can try. Apart from this, there is also a device that the patient can try here. What is the name of the device? It is nothing but Meniere disease. What does this Meniere device do? So basically, it is going to transmit small pulses into the ear. Okay, so basically the patient is going to take the device and keep it near his ear. It is going to transmit small vibrations which go and reach the inner ear. And in inner ear, what does it do? It causes redistribution of the endolymph. So when there is a redistribution of the endolymph, the pressure effects come down. And in a day, this patient is going to use this device 3 to 4 times. And it is very handy because it is a handheld small device. Patient can use it by himself. Therefore, the patient will always get benefit and he'll be more happy and comfortable using the device. Now, there is also Silverstein's microwick which could be placed through the round window, and through this we can give trans-tympanic steroids, we can give trans-tympanic gentamicin, which can cause chemical labyrinthectomy. Also, finally, when nothing is helping the patient, you can also plan for surgery. And in surgical management, we can do endolymphatic sac decompression. What do you understand by endolymphatic sac decompression? You are going to remove the bony ridge that is there around the sac so that the pressure equalizes. You can also do shunt operation. Shunting is that you have endolymphatic fluid in the inner ear. You are going to create channels so that this fluid goes elsewhere. So where are you going to send this fluid? Either into the mastoid cavity, or you can send this fluid, where else can you send? Into the subarachnoid space, so that there is redistribution of the fluid and the pressure symptoms come down. And also you have the final surgery. It is nothing but complete labyrinthectomy. Complete labyrinthectomy, is it suggested in patients? Usually no, because when you do complete labyrinthectomy, you are going to completely distort the hearing also. Then why is the surgery there? Is it obsolete? No, it's not obsolete. In some people who do not have any residual hearing left, you can always go for a complete labyrinthectomy. Now we'll be looking into yet another interesting topic in ENT, and this is one of the topics that is so commonly seen in your everyday practice. It is nothing but BPPV, nothing but benign paroxysmal positional vertigo. So how does a patient present to you here? The patient is going to come to you and he's going to give you a classic history. What is that classic history going to be? He says, doctor, normally when I'm sleeping, I'm normal, or when I'm walking, I'm sitting, I'm normal. But only when I turn my position, like for example, I'm sleeping, I just turn my head to get up, I suddenly get an episode of vertigo. Or I'm just walking, somebody calls me, I turn to talk to them, I get an episode of vertigo. The number one diagnosis that has to come to your brain is nothing but BPPV. So let us see what is this BPPV. Okay, this is one of the most common cause of episodic vertigo. Where else did we see episodic vertigo? We saw it in Meniere's disease. Mostly whenever there is a disease of the peripheral system, the peripheral vestibular system, there is going to be episodic vertigo. But whenever we talk about central conditions, we are always going to have a continuous type of vertigo. Okay, this vertigo lasts for few seconds and it is seen only in head position. So this is the classic history that our patient gave to us. How do we diagnose this? We diagnose this by doing something called as a maneuver, which is called as Dix-Hallpike, DH, Dix-Hallpike maneuver. Okay, and then after we do this maneuver, whenever it is positive, that is the patient says that he has giddiness, or you see evidence of oscillatory movements in the eye. What is that? Evidence of nystagmus. Then you do a corrective maneuver. That corrective maneuver is called as Epley's maneuver. This Epley's maneuver is also called as an otolith repositioning maneuver. Okay. So, what is Dix-Hallpike test and how do you do it? You ask the patient to sit normally in a bed, and then you support the head and neck of the patient and you take that patient down. So, you make them lie in the bed in such a way that their head hangs around 10 to 20 degrees. It's extended from beyond the end of the bed. Okay, and the head is turned 45 degrees. When you do this, because of the repositioning of the otolith that is there in the inner ear, it triggers an episode of vertigo. And what are you looking at? You are looking at if the patient develops nystagmus or if he complains of giddiness. Okay, so if the patient has nystagmus or giddiness, it is that the test is positive in this patient. Okay, and when you're doing this test, which canal are you testing? You're going to test the posterior semicircular canal. Okay, now the patient is positive. So what are you going to do? You're going to do something called as Epley's maneuver. So from here, you're going to continue the rest of the steps of Epley. Okay, but Epley's in general has around 6 steps. So what are they? Initially, you ask the patient to sit down. You turn the head of the patient 45 degrees and make them lie down. When you make them lie down, always make sure that you're going to give support to the head and neck of the patient. When they lie down, also make sure that the head is extended by 10 to 20 degrees. So in that 45 degree turn position, you're going to keep the patient until the vertigo attack stops. Okay, after it stops, you're going to bring the patient's head center and to the other unaffected side. So how much are you turning it by? By 90 degrees, you're going to turn the head of the patient and wait for another 20 to 30 seconds. And after the vertigo stops, you're going to ask the patient to completely turn the body to the unaffected side and sleep. Like how he sleeps on his lateral side, no? Like that the patient has to sleep. And you turn the head one more 90 degrees in such a way that the head is facing to the ground. Now, Again, you wait for the vertigo to settle in 25 to 30 seconds, and after the vertigo settles, you're going to make the patient sit down. And you have to take caution that the head is still kept in the same position, turned to the unaffected side. And when he sits, you slightly flex the head by 20 to 30 degree and keep the patient in that position for 20 to 30 seconds. So this is the complete cycle of the corrective maneuver. And what is the name of the maneuver? It is called as Epley's maneuver. Okay. Now, coming to nystagmus. What do you understand by the term nystagmus? Nystagmus is nothing but involuntary. That is, the patient does not cause nystagmus by himself. It happens by its own. Involuntary oscillating movements of the eye is called as nystagmus. By itself, the eyeball is going to beat either in the horizontal direction or in the vertical direction, or it is going to have certain turns like this, which is called as a torsional direction. The direction of nystagmus is always determined by a fast component. What do you understand by fast component? So when I told you that there is going to be nystagmus, the eye is going to beat like this. No, it is always going to beat to one side fast. If you look at my pen, it's going to beat fast and come back slowly. So whichever side it is going to beat is going to be the fast component, and that is going to determine the side of nystagmus. In horizontal nystagmus, the direction of nystagmus, or the fast component, in other words, is always away from the hypoactive side and to the hyperactive side. Okay. So remember, it is always to the hyperactive side that the nystagmus is going to point, or the fast component is going to point. The involvement of the vertical semicircular canal always leads to vertical nystagmus, and the horizontal canals lead to horizontal nystagmus. Now tell me, what are the vertical canals that we know of? They are nothing but the posterior and the superior semicircular canals. I told you earlier, right? It is always P and S that comes together in most of the cases of ENT. So remember, posterior and superior are nothing but the vertical canals, and when they are affected, you're going to have vertical nystagmus. Now coming to the next topic, we are going to see about the tympanic membrane retractions. What do you understand by tympanic membrane retraction? So usually what is tympanic membrane? It is a lateral wall between the middle ear and the external ear. Whenever the pressure in the middle ear becomes negative, it is going to pull in the tympanic membrane little inside. So this is called as retraction of the tympanic membrane. So normally, how does a tympanic membrane look like? It is having a pearly gray appearance, and it has a cone of light, it has two folds, it has the handle of malleus that is seen. This is how a normal tympanic membrane looks like. So when it is retracted, there are going to be certain general features that you can appreciate, and what are those? The cone of light is going to be distorted, or it is going to be absent. So you cannot see the cone of light. How does a tympanic membrane appear? It is going to give you a dull look. The handle of malleus is foreshortened. Because of the pull of the handle of malleus, it is not going to show its exact length. The lateral processes of the malleus is more prominent, and there are two malleolar folds, right? The anterior and the posterior malleolar folds. These become more prominent, and they give you a sickled appearance. Now, when we talk about retraction, we need to know about retraction of pars tensa and pars flaccida. So pars tensa is the maximum portion of the tympanic membrane, no? And the classification for pars tensa is nothing but Sade's classification. So pars tensa has a S in its name, no? So Sade, S for S, tensa, SA, and Sade, SA. Okay, this is how we are going to remember. Do not get confused with this. So there are 4 stages, and what are the 4 stages? The number 1, there is going to be retraction of the tympanic membrane, but it does not touch any ossicles. So it is just going to be retracted. So what are the features that you see? Those are the general features that we studied earlier. It doesn't touch any ossicles, or in general doesn't touch the incus. Coming to stage 2, what happens here? The tympanic membrane gets retracted, and it goes and touches either the incus or the incudostapedial joint. Then it becomes 2. Now there is 3rd stage. It goes further and it touches the promontory. When it touches the promontory, it causes something called as atelectasis of the middle ear. What do you understand by atelectasis? It is nothing but collapse. Where else have you heard the term atelectasis? Remember, lungs, collapse, atelectasis, correct, no? So here also the tympanic membrane is going to go and lie over promontory, causing atelectasis or collapse of the middle ear. Next, we have stage 4, when the tympanic membrane goes and gets stuck to the promontory with so much extent that there is going to be adhesion seen in the middle ear, and this condition is also called as adhesive otitis media. Okay. So let us see the images here to understand it better. In the first image, as we can see, there is going to be loss of the luster of the tympanic membrane. Can you see the cone of light there? No, cone of light is not seen. Can you see that the malleus handle is foreshortened and the folds, the malleolar folds have become very prominent. So these are the features of stage 1. Here, the tympanic membrane is not touching the incus. Coming to stage 2, here the tympanic membrane goes further inside to touch the incus or the incudostapedial joint. So if you look at the tympanic membrane, you can see that the incudostapedial joint in the posterior superior part of the tympanic membrane is appearing more prominent. Coming to the stage 3. In stage 3, what happens? The tympanic membrane is going to go and it is going to touch the promontory. So the promontory becomes seen. Okay. If you see stage 4, it is same picture like stage 3. So on otoscopy, you cannot differentiate between stage 3 and 4 because they almost look the same. So how are you going to differentiate between stage 3 and 4 then? So we do something called as Siegelization, or we do something called as pneumatic otoscopy. So what is the Siegelization? You are going to increase and decrease the pressure in the external auditory canal by using a Siegel speculum. And when you do this, you are seeing whether the tympanic membrane moves or not. If the tympanic membrane is mobile, it says that it is a stage 3. Whereas in adhesive otitis media, like glue, it is sticking on the promontory. Will it move? It is not going to move. Then the immobile tympanic membrane characterizes of that of stage 4. Now coming to the pars flaccida. So pars flaccida is an upper portion, no? Because it is an upper portion, we can remember TOS or top. So TOS classification is going to talk about the retraction seen in the pars flaccida. Okay. So in pars flaccida or the TOS classification, there are 4 stages again, and the stage 1 talks about the pars flaccida being retracted, and here it is retracted but it is not touching any ossicles. In general, it is not touching the malleus. Okay. Coming to stage 2, there is retraction, and here the pars flaccida goes and touches the malleus neck. Now you might ask me one question. In the Sardes classification, where we saw about pars tensa, we spoke so much about the incus and the incudostapedial joint. But in the pars flaccida retraction, we are talking about malleus. Won't we get confused how to remember which ossicle is involved in which retraction? There is an easier trick to remember this, and the trick is that if this is the tympanic membrane, okay, which is the ossicle that is seen in the tympanic membrane in the pars tensa, it is nothing but the handle of the malleus, right? This malleus is clearly seen in the pars tensa. So remember, the malleus is already there in pars tensa. Now, if it is retracting, it can't go touch malleus because it already has malleus. It has to go and touch one more ossicle. Therefore, it is going and touching incus. This is what you have to remember here. Now, coming to pars flaccida. Does this pars flaccida have any ossicles? No, there are no ossicles here. And you know that the pars flaccida is in close relation to the which bone? Malleus. That is why it is going to touch the malleus. This way you are not going to get confused. Okay. Now coming to the stage 3, there is going to be retraction pocket formed here, and part of this retraction pocket is going to be hidden. This is what you need to know about stage 3, and there is some degree of scutum erosion that happens in this stage. Okay. Now coming to the 4th stage, it is nothing but the retraction pocket is completely hidden, plus there is going to be definitive erosion of the scutum. This is nothing but stage 4. Now let us look at images for the same. Okay. So this image here shows us the normal appearing pars flaccida. This arrow that I am pointing here, now it is showing the pars flaccida. Now this pars flaccida is going to go and get retracted. See here, you can see that it is retracted a little. But is it touching malleus? No, it's not touching malleus. So it is stage 1. Now in the stage 2, it has gone and it is touching the neck of the malleus. So it is stage 2. In the 3rd part, you can see that a part of the retraction pocket is hidden and there is erosion because that continuity in the black line is not there. So it is stage 3. In stage 4, there is complete erosion. Also, the most of the retraction pocket is hidden in this stage. Okay. Now, what is this instrument that you're looking here? This instrument is nothing but a Siegel's speculum, and this is the instrument that you use in order to bring in pressure changes in the external auditory canal. So, the use of this is mainly to assess the tympanic membrane mobility, and you can differentiate between the stages 3 and 4 of Sardis classification, because 3 was atelectasis, 4 was adhesion, and by just looking by the otoscope you cannot make out whether it is 3 or 4. That is why you bring in pressure changes in the external auditory canal, and if the tympanic membrane is mobile, it says that it is stage 3, whereas if the tympanic membrane is fixed, immobile, it says that it is stage 4. The next topic that we're looking into is nothing but the function of middle ear. So what is the main function of middle ear is nothing but it acts as a mechanical transformer. What do you understand by mechanical transformer? It is having its action in order to effectively transfer the sound energy from that of the outer ear. In outer ear, we have the medium as air, no? Into the inner ear, where the medium is nothing but fluid. Usually what happens when the sound travels from one medium to another medium, there is going to be significant loss in the sound energy that is transmitted. So this middle ear has ossicles which act as a mechanical transformer in order to match the impedance between the outer and the inner ear. Now coming to how it matches the impedance between the outer and the inner ear, it is by a transformer action. And this entire series is called as impedance matching. So there are 3 things that you have to know here. The number 1 is nothing but aerial or hydraulic ratio. As the word suggests, it's aerial, no? Area. It is going to do something with area. So what you have to understand here is that the vibratory area of the tympanic membrane is around 55 millimeters square. What is the total area of tympanic membrane? It is 90 meters square, but only 55 meters square area in this entire 90 meters square is going to effectively vibrate. Now, from the tympanic membrane, so if you see, this is going to be the tympanic membrane. From this tympanic membrane, how does the sound travel? There is the ossicle. Which is the ossicle first? It is nothing but the malleus. From malleus, the sound is going to go to the, which is the next joint here, incubomalleolar joint. So this is the incus, and from the incus, the sound is further going to go to the stapes. So we have the incus here, and then the sound goes to the stapes. So we have the cruras of stapes resting on the foot plate. So this is the entire structure, the ossicles that are seen in the middle ear. Now the effective vibratory area of this tympanic membrane is 55 millimeters square, and of stapes is just 3.2 millimeters square. So what happens to the ratio? The ratio comes around 17:1. So this is the ratio, and when the sound energy is transferring from the larger surface area to smaller surface area of that of foot plate of stapes, it is going to focus the energy and thus increasing the pressure. Okay. Now, the second action is nothing but liver ratio. So, how much is going to be the liver ratio? It is around 1.3:1. So, what do you understand by this liver ratio? Liver ratio is the ratio of the 2 ossicles, the length of the 2 ossicles, okay? So, in this image, we can see that the length of the malleus is around 1.3 times more than the length of the long process of the incus, which is just 1 time. So, the complete transformer action comes out to be the multiplicative product of 17 into 1.3, which is nothing but around 22. This is going to be the complete or the total transformer gain. There is also one more effect called as curved membrane effect, and this is also called as the catenary effect. So what is the catenary effect? It is nothing but, see, your normal tympanic membrane is like this, right? So when the sound comes and hits this tympanic membrane, the peripheral tympanic membrane is going to move more compared to that of a central tympanic membrane. This is how the sound, when it hits, the center moves by a very small distance, just D1, whereas the periphery moves by a larger distance shown by D2. Now, what happens when this happens? Because of the increased mobility outside and decreased mobility inside, there is going to be amplification of the sound and increase in the energy. So, peripheral TM, is it moving more or less? It moves more, whereas a central TM moves lesser, because of which there is going to be effective transfer of the sound energy. So these are the three things that you have to know of. Also, there is something called as phase difference that you have to know of. What is phase difference and where is it seen? It is seen between the round window and the oval window. A quick question to you. Round window is covered by secondary tympanic membrane. Oval window is covered by footplate of stapes. Where does the oval window lead to? Where does it lead to? Scala vestibuli. Where does the round window lead to? It leads to the scala tympani. Okay. Now coming to the function of the phase difference. Normally, as we saw, this is the tympanic membrane, and after tympanic membrane you have the ossicle malleus, then you have the incus, the second ossicle, which will further lead to the stapes. This is a normal structure, right? Then you have the stapes footplate. This stapes footplate is resting on which window? It rests on the oval window. Under that you have the one more window, which is round window. This entire structure is a structure of the middle ear. Now, from this oval window, it leads to scala vestibuli. This is how the scala vestibuli is there. And then from the round window, it leads to scala tympani. This is how it leads to scala tympani. Okay. Usually, there is always a wave of compression that travels through the oval window into scala vestibuli, and the reflected waves come back through the round window. So one window is always in the state of compression and the other window is in the state of rarefaction. And this is important for the effective conduction of sound energy. Now what happens sometimes if there is a large perforation in the TM? So remember, there is a very big hole, a perforation in this TM, and because of this perforation, both the round window and oval window are exposed to the outside at the same time. What happens? The sound is going to reach round and oval window at the same time, cancelling the effect of each other. And when the effect is cancelled, this effective phase difference, whatever is there, this phase difference is going to be cancelled. And where is it seen? Whenever there is a large perforation. So phase difference is cancelled, matlab there is going to be a reduction in the effective transfer of sound. Now, you need to also know about how to localize whether a pathology is there in the inner ear or middle ear and outer ear, and which type of conduction is affected. Firstly, we will see the conductive pathway. From where does the conductive pathway start? From the external ear. Pinna collects the sound, it transmits the sound into the tympanic membrane, it goes through the ossicles, and finally it is going to rest on the footplate of stapes. This entire structure is that of the conductive pathway. Okay, if any structure here is affected, it causes conductive hearing loss. Now coming to sensory neural pathway, it starts in the inner ear from the organ of corti. From the organ of corti until the sound finally goes and reaches the auditory cortex. This is nothing but the pathway of the sensory neural system. Now auditory cortex, where is it located? It is located in the superior temporal gyrus. This superior temporal gyrus also has one more name. What is it? It is also called as Hesch's gyrus. And the area of the auditory cortex, the primary auditory cortex, is area 41-42, whereas area of the secondary auditory cortex is area 22. Now, if the cochlea is affected, there is going to be sensory hearing loss, whereas if the nerve, the auditory nerve is affected, there is going to be retrocochlear hearing loss. That is, there is pathology behind the cochlea, retrocochlear hearing loss, which is also the neural hearing loss. Now coming to the investigations of the ear, firstly we will be looking into the tuning fork test. So the most commonly used tuning fork for all the ENT examination is nothing but 5 to 12 Hz, because the tone decay is less, it comes in the normal Fritz frequency. Okay. Now coming to the tuning fork test, we have two main tests. They are Rinne's and Weber's. Also, before that, you need to know about something. Okay, if you vibrate a tuning fork and try to bring it in front of the patient's ear and try to bring the vibrations in the mastoid, if the patient can't hear 256 Hz, that means he has around 15 decibel hearing loss. If he cannot hear 512 Hz, that means he has around 30 decibel hearing loss. Now, if he cannot hear 1024 Hz, that means that he has around 45 decibel hearing loss. Now, previously we have seen 6 tables, we have seen 8 tables. Now, this is the third table that you have to know. 15 decibel hearing loss, that means the patient cannot hear 256 Hz. If it is 30, 512 Hz. If it is 45, 1024 Hz. 15 ones are, 2s are and 3s are. Okay. Now coming to Rinne's test. So Rinne's, as I gave you a mnemonic earlier, you have two type of results, positive and negative. When you say it is positive, it means that the air conduction is better than bone conduction, and it is seen in two conditions. It is seen normally in the normal ear and whenever there is sensory neural hearing loss. Rinne's is going to be positive because the air conduction is heard better. Coming to negative Rinne's, it means that the bone conduction is better than air conduction. When does it happen? It happens whenever there is a conductive hearing loss. The air is not getting conducted properly, the sounds are not getting conducted properly, hence the bone conduction is perceived better. There is also something called as false negative Rinne. So what do you understand by this? Whenever there is severe sensory neural hearing loss, what happens is that the sound, whenever you try to vibrate the tuning fork and keep it on the mastoid, the sound energy is going to transfer transcranially along the skull to the opposite ear, and in the opposite ear the patient is going to perceive as better. But in general, you're testing the affected ear, no? But the better perceivement of the sound is from the other normal ear. Hence, it is called as falsely negative Rinne. Okay. Now, there is also one more test called as ABC. What is ABC? It means absolute bone conduction. What do you understand by absolute bone conduction? How do you do it? So, you are going to vibrate a tuning fork and you are going to keep it on the mastoid of a patient. And at the same time, with another finger, the examiner is going to obstruct the external auditory canal. And then the tuning fork is kept on the mastoid. When the patient stops hearing the vibration, you are going to take the tuning fork and keep in the examiner's mastoid. If the examiner can still hear the vibration, can still hear the sound, it means that the patient has sensory neural hearing loss. So this is a test to detect sensory neural hearing loss. There is also a similar test which is called as Schwabach test. You do the same test but with the external auditory canal open this time. Then it is called as a Schwabach test. It is also a test for the sensory neural hearing loss. You have one more test called as Gellis test. It is a test for otosclerosis. So we already saw how are we going to do a Gellis test, no? You're trying to change the pressure in the external auditory canal, and at the same time you're going to place a tuning fork on the mastoid. With change in the pressure, like if you increase pressure, if the sound heard is less, and when you reduce the pressure, if the sound heard is more, it means the test is negative and it is a diagnostic test for otosclerosis. But whereas when you increase and decrease the pressure, if the sound heard is normal, it means that the patient's hearing is absolutely normal and it is a positive Gells test. Now, this pure tone audiometry, you remember that it is just a subjective test for hearing. So, each time you give the patient a pulse, the patient has to raise his hand and tell you whether he can hear that frequency or not. So, if you take a 5-year-old child and do a PTA, is the results going to be consistent and true? No, because the child is going to be very notorious. It is not going to properly respond to you whatever you say. Therefore, tympanometry becomes a better investigation in children. Now, when we talk about pure tone audiometry, there are certain signs that you have to know of. Okay, so what are those certain signs? Can you see this image here? Okay, so the first one is the right side. Whenever you're testing air conduction, you're going to test two things. Okay, unmasked ear and masked ear. Remember, in your exam, you're always going to get unmasked ear. So, if you remember that one symbol, it is enough. But if you know both the symbols, well and good. I'm just going to give you certain tricks as to how we are going to remember these shapes. Number one, air conduction. Right side, round. So, R for R, right is going to be round. Okay. Right is right, no. So, the left is going to be wrong. So, the mark here is into. It is going to be wrong mark for the left side. Now, coming to masked. Okay. In the left side, as you can see, in this cross mark, there are 4 lines. If you rearrange these 4 lines, it is going to become a box. So, box is for left ear. So, what is the remaining shape that is left? Triangle. It comes for the right ear. Got it? This is how you have to remember air conduction. Now, coming to bone conduction, you are going to see where the bracket opens. Firstly, you have to remember that for bone conduction, it is brackets. No. How are you going to remember it? Remember it for, again, with the same words. B for B, bone conduction. B for bracket B. Okay. That is how you are going to remember this. Now, in the right ear, as you can see, the arrows or the brackets are going to open to the right. Whichever side it opens, it is of that ear. Whereas, if you see the left ear, the brackets are going to open to the left. So, it is of left ear. If there is no response, these are the images that will be given to you in your exams. Okay. Now, apart from this, what is this picture showing you? This picture is depicting a Schwabach test, and we just saw how we are going to do a Schwabach test. Now, you tell me, in Schwabach, is the external auditory canal open or closed? Yes, right. It is going to be open. In which test the external auditory canal is going to be closed? It is going to be closed in the absolute bone conduction test. Now, next question. Who is going to close the external auditory canal, patient or the examiner? It is the examiner who closes the external auditory canal opening. Now, how are you going to do Rinne's test? You are going to take a tuning fork, you are going to hit it on the bony prominence, mostly the elbow. It starts vibrating and you are going to place it behind the mastoid. And when the patient stops hearing the sound, you are going to bring it in front of the external auditory canal. If you can still hear sound, it means that the air conduction is better than bone conduction. If not, the opposite way. Now, how are you going to do a Weber's test? You're taking a tuning fork, you're hitting it on the bony prominence. Once the vibration starts, you're going to keep it in any central bony prominence. For example, on the forehead, or for example, on the chin. Now, we are going to see where is the sound lateralizing to. Normally, it does not lateralize or lateralizes equally in both the ears. But if there is a perforation or any pathology based on the lateralization, you're going to say whether it is a conductive pathology or a sensory neural pathology. And as I told you, there is always a mnemonic to remember. No? It is SOCS. If it is sensory neural, it is going to lateralize to the better ear. If it is conductive, it is going to lateralize to the same ear. For example, if there is a perforation in the ear, conductive pathway is affected, the sound is lateralized to the same ear with perforation. Now, we have seen the various symbols that are there in PTA. Now, we will see few of the graphs and see if we can apply this knowledge here. So, before we see graphs, I'm going to ask you some questions. If it is a round, is it going to tell you about right ear or left ear? It is right. R for R, it is going to talk about right ear. If there is a cross symbol, into mark, what is it? Wrong. Right for right, so wrong is going to be left ear. If there is a box, right or left, it's going to be left ear because cross has 4 limbs. If you join all the 4 limbs, you're going to get a box and that is for left ear. So, what is the other shape left? Triangle. Triangle is for which side? It is for the right side. Okay. So, with this, we're going to start with these graphs. So, the first picture here. So, initially, you're seeing certain brackets. And where are the brackets opening? All these brackets are opening to the right side. So, we are talking about the right ear. And is it the bone conduction you're talking about or the air conduction? Brackets. B for bone conduction. So, we are talking about bone conduction. This is how we are going to approach each of these graphs. If you do not use some tricks to remember these symbols, this can get very confusing in the last moment and you can simply lose marks in such an easy and important question. Okay. Now, coming to the second line that you're showing, there are so many circles. Round. For which ear? Right ear. Okay. So, the round, it is not a bracket, right? So, the round stands for air conduction. So, this is showing the right ear air conduction. And as you can see here, there is more than 15 decibel gap between the bone conduction and air conduction. So, whenever there is this air-bone gap or a AB gap of more than how many decibels? 15 decibels. It says that it is a picture of a conductive hearing loss. In which side of the ear? In the right side. So, this is a picture of a right ear conductive hearing loss. Now, let's see the second image. Okay. In the second image, there are so many brackets and these brackets are opening to the right side. So, it is bone conduction of the right ear. Okay. Now, we also have so many circles. Circles meaning round. Round is for which ear? It is right ear. So, again, air conduction of the right ear. So, you have seen the bone conduction line. You have seen the air conduction line. Is there any gap between bone conduction and air conduction? No. Both the lines go hand in hand. Because there is no airborne gap, they say that this is the graph of a sensory neural hearing loss. Always remember, it is the airborne gap which is going to tell you about whether it is sensory neural or bone conduction. Okay. Now, coming to the third graph, what picture are we looking here? We can see that all these brackets are opening to the left side. So, we are learning about the left ear here and brackets of bone conduction in the left ear. Okay, so you can see that this is the normal hearing of a person, no? Minus 10 to 25 decibel. It is below that. That means the bone conduction is abnormal. Okay, let's see the second line. It is depicted by crosses. So what does crosses indicate? It is of left ear, and cross indicates air conduction. Here also it is below your 25 decibel mark. That means it says that the air conduction is also abnormal. Bone conduction affected, air conduction is affected. There is also AB gap. So what are we looking at? Are we looking at conductive? Okay, it could be conductive because there is air-bone gap. Okay. Is it also sensory neural? Yes, it is also sensory neural because the bone conduction is affected. So where it is a picture showing both the hearing loss, therefore it is called as mixed hearing loss. Got it? Okay. Now coming to the next graph, you can see that always remember that the initial frequencies below 1000 are all the low frequencies that we're talking about, and the later frequencies beyond 1000 are the high frequencies that we are talking about. So if you see this graph here, you can see that the low frequencies are all normal. It is within that 20 decibel hearing. But when we come to the high frequency, there is a characteristic dip that is seen in the bone conduction and the air conduction. So this dip is nothing but the acoustic dip, which is seen specifically at 4 kHz. And this depicts a high frequency hearing loss. Coming to the next graph. So let us try interpreting this graph. Let's see the orange color line initially. So in this orange line, we can see that the brackets are opening to the right side and we have round symbols. So the orange line is depicting which ear? It is depicting right ear. Coming to the blue color line, brackets are opening to left and there is a cross into mark. So which is it depicting? It is depicting the left ear. Is there any gap between both the lines? Are we going to consider that here? You have to consider it separately for each ear. In right ear, both the lines go hand in hand, no air-bone gap. In the left also, both the lines are going hand in hand, there is no air-bone gap. Okay. Now, you can see that at 4 kHz, there is a characteristic fall both in the right ear and the left ear, and the fall is seen both in air conduction and bone conduction. This is nothing but acoustic dip. Always remember, acoustic dip is always seen both in air conduction and bone conduction, and it is classically seen in noise-induced hearing loss. Whenever there is noise-induced hearing loss, is it one ear that is affected or both ears? It is obviously both the ears because both the ears are exposed to that noise, no? So it becomes a bilateral hearing loss. Both right and left are affected and you see acoustic dip. Now there is also one more dip that we see in PTA, which is called as Cahardt's notch. So what do you understand by Cahardt's notch? It is a characteristic dip that is seen in only bone conduction. You can see here the brackets are opening to left. So which side? It is nothing but the left ear. So when you're talking about left ear, in the bone conduction brackets, there is a characteristic dip only at 2 kHz. So this is going to characteristically talk about otosclerosis. This dip is called as Cahardt's notch. So when you do surgery for otosclerosis, when you do stepidotomy and place a prosthesis, this PTA, whenever you're going to do, it is going to give you a disappearance at this notch, and that tells you the success of the surgery. Now let's look into the last graph. So this is the last graph. Okay. So where is the bracket opening? The bracket is opening to the left side. So this is talking about a left ear. It also has cross mark which says that it is left ear. Okay. Now, coming to the brown color arrow, where is the bracket opening? Bracket is opening to the right side. Okay, so top one was the left ear. This is the right ear that we are talking about. In the right ear, what you can see is, you can see that in all the frequencies, 250, 500, 1K, 4K, 8K, in all the frequencies, there is affected conduction of sound that is seen. So, all the frequencies are affected, then it becomes a severe hearing loss picture that we are looking at. Is it sensory neural hearing loss or conductive hearing loss? Do we see air-bone gap between both the lines which are shown in brown color? No, there is no air-bone gap. That is why we are looking at a sensory neural hearing loss picture, and this says that it is severe sensory neural hearing loss because all the frequencies are affected. Okay, and in all the frequencies you can see that the hearing loss is around 80, 90, 100. This much decibel hearing loss is there in each frequency, which substantiates that it is severe hearing loss that we are looking at. Now we'll do a thorough revision of certain conditions. Okay. Now, the first graph. So, the graph looks like this. So, which is the frequency that is affected? It is the lower frequencies that is affected. Hence, which picture that we are looking at? We are looking at Meniere's disease. Coming to the second graph. Your graph looks like this. Now, we are talking about which frequency it is there in the end. That is, the higher frequencies are affected. You have a down-sloping audiogram. Meniere's was what type of audiogram? It was the up-sloping audiogram. Okay, so when the higher frequencies are affected, it could be one of the three conditions, either a noise-induced hearing loss, either presbycusis or ototoxic hearing loss. Got it? Okay. Now, we have one more graph where there is a characteristic dip at 2K Hertz. But remember, this dip is seen only in bone conduction. What condition are we looking at? We are looking at otosclerosis. Now, there is one more graph. It is a similar graph. There is a big fall at 4K Hertz. But remember, at 4K, both are affected. Air conduction is affected. Bone conduction is affected. What are we looking at? We are looking at a picture of an acoustic notch, which is seen at what frequency? 4K. Where is it seen? It is seen in noise-induced hearing loss. Okay. Dip in 2K, what is it called as? Cahardt's notch. Where is it seen? Otosclerosis. Now, coming to the last graph that I have to show, a graph in the shape of U. This graph is also called as cookie bite graph. Here you can see that all the mid frequencies are affected. Where is it seen? It is seen in sensory neural hearing loss of congenital type. Got it? So this was a quick revision of all the different types of named graphs that you get in PTA. Now, looking at the hearing loss, there are two classifications of hearing loss that you have to know about. One is nothing but the WHO classification and another one is ASHA classification. So, WHO classification classifies the hearing loss into 4 categories. Okay. What is a normal hearing? Between -10 to 25 decibels. Now, about 25 decibels, if the hearing loss is between 26 and 40 decibels, then it becomes what type of hearing loss? It becomes a mild hearing loss. Now, if it is 41 to 60, now once you reach 40, you're going to add plus 20 to each type of hearing loss, okay? Now, from 40, plus 20 is 40 to 60 decibel. It becomes a moderate type of hearing loss. Now, let's see third one. 40 plus 20, it is 61 to 40 plus 20 was which one? Moderate. Now, for 60, you're going to add 20. 60 to 80. What is it? It is nothing but severe. Now, 80 and above, it is going to become profound hearing loss. So, we have 4 types of hearing loss in WHO: mild, moderate, severe, profound. Now, coming to the ASHA classification, here this is a little extensive classification. We have some more in this. So, as I told you, -10 to 25 is nothing but the normal hearing of a person. Now, like WHO, the first one is going to be same. 25 to 40, it is nothing but mild hearing loss. After which, in ASHA, we are going to bring in 15 decibel increments. Okay. So, 40 to 55 becomes moderate. 56 to 70 becomes moderately severe. 71 to 90 here becomes severe. Now, if we have a hearing loss of more than 90 decibel, it becomes profound hearing loss. And whenever there is profound hearing loss, these patients become candidates for cochlear implant. So, you can plan cochlear implant whenever you have a proven diagnosis stating that the hearing loss is about 90 decibel. Now, we'll be looking into the WHO grading of disability. So, based on how much hearing loss a person comes to you with, you are going to grade the disability. Okay. So, coming to grade 0, that means there is no disability. When do you say it is grade 0? When the hearing is at normal threshold. Normal threshold as in the hearing is between -10 to 25 decibels. That time there is no disability. That means even whispers the patient is able to hear. Now, coming to grade 1 disability, it means that there is going to be slight disability in this patient. That means he has mild hearing loss. The hearing loss is between 26 to 40 decibels. Okay. And when the hearing loss is between 26 to 40 decibels, the patient is able to hear normal volume at a distance of 1 meter. Okay. Now, coming to grade 2, it says that there is moderate impairment. What do you understand by moderate impairment? There is going to be a moderate hearing loss between 41 to 60 decibel hearing loss. When there is moderate hearing loss at a distance of 1 meter, the patient can hear raised volume. He can hear the raised volume or raised voice at a distance of 1 meter. Now, when we talk about grade 3 disability, it is severe disability that we are talking about. There is going to be severe hearing loss. That is, the hearing loss is between 61 to 80 decibel, and now at 1 meter, the patient can hear only when the words are shouted. The patient is able to hear shouted words at a distance of 1 meter. Now, we are going to see the last type of impairment, which is profound impairment. That is, the hearing loss is more than or equal to 80 or 81 decibels, and when it is profound impairment that we're talking about, the patient is unable to hear shouted words also. So this is nothing but profound impairment. Okay. Now, let us see some conditions of the tympanic membrane and let us see how much is the hearing loss that the patient presents to us with. Okay. Now, whenever there is complete obstruction of the external auditory canal, what do you understand? You put a cotton ball or you put a cotton plug or you put a earphone into the external auditory canal so that it is completely blocked. The patient comes to you with around 40 decibel hearing loss whenever you have any ear plugs or ear masks that are there. Now, coming to tympanic membrane perforation. So, based on the size of a perforation, if it is small, medium or large, the patient can have anywhere between 10 to 40 decibel of hearing loss. If it is small perforation, maybe around 10 decibel. If it is a large perforation, maybe the hearing loss goes up to 40 decibels. Now, coming to TM perforation, or the tympanic membrane perforation with ossicular discontinuity. Here, what are we looking at? There is a hole in the tympanic membrane plus all the bones. There is going to be discontinuity. They are not in alignment. There is around 40 decibel hearing loss even here. Now, coming to another condition. Here, there is discontinuity in the bones. There is ossicular discontinuity, but the tympanic membrane is intact. Now, there is a question for you. The previous one, what did we see? We saw that there was perforation in tympanic membrane plus ossicular discontinuity. Is there going to be more hearing loss there, or is there going to be more hearing loss in a condition where the tympanic membrane is intact but the ossicles are distorted? What is the answer? If you are thinking that the hearing loss would be worse when there is tympanic membrane perforation plus discontinuity, you are wrong. There is going to be more hearing loss in this condition where there is ossicular discontinuity but intact tympanic membrane. Why is it so? It is because the tympanic membrane is intact, but whatever sound is reaching the tympanic membrane is not getting effectively transferred to the stapes footplate because all the ossicles are distorted. There is going to be a lot of hearing loss. Whereas in the above condition, there was hole in the tympanic membrane. No, because of that hole, all the sounds would directly go and hit the oval window, because of which the hearing there would have been a little more better. Okay. Coming to one more condition, wherever there is complete fixation of the stapes footplate. What condition are we looking at? We are looking at otosclerosis. When there is otosclerosis, the hearing loss is about 60 decibel. Okay. Now, coming to the various audiogram graphs that we saw, downsloping means the higher frequencies are affected. Where is higher frequency affected? Whenever there is a noise-induced hearing loss, whenever there is age-related hearing loss, the presbycusis, or whenever there is ototoxicity-induced hearing loss. Now, coming to the upslope or the ascending type of audiogram, when do you see this? You see this in the early stages of Meniere's disease. In early stages of Meniere's disease, remember, only the apex is affected. When only apex is affected, only the low frequency sounds are affected. Therefore, you have an ascending graph. But as Meniere's progresses, all the frequencies are affected and you get a flat audiogram, and in the later stages, even a downsloping audiogram could be seen. Coming to the next one, U-shaped graph or a cookie bite graph or a trough graph. Where is it seen? It is seen in congenital sensory neural hearing loss. What does it signify? It signifies that all the central mid frequencies are affected. It is also seen in cochlear otosclerosis. Okay. Now, a characteristic dip which is seen in air conduction and bone conduction. Whenever you see a dip and you see both air and bone conduction, one thing has to flash into your brain immediately. What is that? We are looking at a 4K dip seen in, which is a condition that has 4K dip. It is nothing but noise-induced hearing loss, and this dip is also called as an acoustic dip. What is the name of the dip? Acoustic dip. Now, a characteristic dip which is seen at 2K frequency, that is at 2000 Hz only in the bone conduction. What is the name of it? It is nothing but Cahardt's notch. And where is it seen? It is seen in otosclerosis. So this is a revision of the different graphs that come in PTA. Now we have looked into pure tone audiometry. Now we are going forward into second type of investigation. We are going to look at tympanogram. Okay. So whenever we talk about tympanogram, we have to keep in mind about two things. One is the mobility of the tympanic membrane, which is nothing but compliance aspect, and the pressure in the middle ear. So let us see a normal graph of tympanogram. Okay. So this arrow in the y-axis, it is going to talk about the compliance in the tympanic membrane. And down the x-axis is going to talk about the pressure in the middle ear. That is, it starts from minus 200, goes to 0 until plus 200. If it is a normal graph with normal compliance of tympanic membrane and normal middle ear pressure, the graph is going to look like this. Okay, this is what you have to know. Now, keeping this in mind, let us see the various conditions and how the graph is going to look like. Now, coming to the first condition, it is nothing but type A curve. When do you get type A curve? You are going to get it when there is no pathology, no disease. That is, the tympanic membrane is compliant. The middle ear pressure is normal. Okay. Now, coming to the second graph, it is nothing but AD type of graph. If you see the graph, it is going to be very steep. When do we get AD type of graph? We are going to get it whenever there is ossicular discontinuity. How are you going to remember it? D for D. AD for discontinuity, ossicular discontinuity. When the bones are discontinued, they're not in continuity with each other, they are not going to hold the tympanic membrane properly. There is going to be increased mobility of the tympanic membrane. That is, the compliance is increased. That is why the y-axis goes up. Number one. Now, if the tympanic membrane is very thin, even then it is able to freely move. It's more compliant. Even then, we can see that we get an AD type of curve. Coming to the third type of curve, it is nothing but AS type of curve. S for sclerosis. So we see this type of graph in otosclerosis or even tympanosclerosis to some extent. What happens here? There is going to be reduced compliance. Why reduced compliance? Because the tympanic membrane is not effectively moving. Even if the tympanic membrane is very thick, even then it does not move effectively. Compliance reduces. Therefore, we see a AS type of curve. Okay, you can see here, no, it is a very small lengthwise. Now, coming to the next type of curve, it is nothing but a type B type of curve. So, what do you understand by type B type of curve? It means that there is no barrier for pressure or fluid in the ear. So, what happens whenever the middle ear is filled with fluid? For example, sterile fluid like that of serous otitis media or a pus fluid like that of chronic suppurative otitis media, there is not much pressure changes that is happening and the tympanic membrane is also not moving, because of which you get a relatively flatter curve, which is nothing but a type B type of curve. Even when there is wax in the tympanic membrane, even when there is perforation, you can see such type of curve. Now, coming to the last type of curve, it is called as type C. What do you understand by type C curve? That is, there is negative pressure in the middle ear. Normally, if you can see this black arrow that I am pointing at, the curve had to be like this. At a zero pressure, you were supposed to get a tented curve. But you are getting a tented curve here in the negative pressure itself, because the middle ear pressure here is negative. Because the tympanic membrane is retracted, compliance is also reduced. So, this is the curve that you get, and this curve is nothing but type C curve. Okay. Now, coming to the next investigation, we will be looking into otoacoustic emission test. When we talk about otoacoustic emission test, always remember that it is formed by the outer hair cells. Okay, you can see the image here. Now, this is how the otoacoustic emission test is going to be done. So, what do? You can see this instrument here. Now, this is a probe. You take a probe and pass sound energy into the ear. The sound energy, how does it travel? It is go to the, where does it go? First, from the pinna, it goes to tympanic membrane. It goes into the ossicles. It goes into the footplate of stapes. After it goes into the footplate of stapes, it is going to go into which window? Round or oval? Oval window. From oval window, scala vestibuli. From scala vestibuli, scala tympani. From scala tympani, it is going to stimulate the basilar membrane. From the basilar membrane, where does it go? It goes into the outer hair cells, stimulate the outer hair cells, and there are sounds, echoes that are produced. these echoes are picked up again by the probe, and this is going to give us the entire otoacoustic emission, and this is how we do the test. Now remember that this test not only checks the functioning of the inner ear but also checks the functioning of the middle ear. So if a otoacoustic emission test is negative, it doesn't say that just the outer hair cells are not working, there is a pathology in the inner ear. There could also be some pathology in the middle ear. Got it? Now you have to remember that there are two types of otoacoustic emission. What are the two types? One is spontaneous otoacoustic emission, which means that no stimulus is required. Spontaneously it is going to give us a graph. Okay, and then you have evoked. In evoked, you have something called as transient evoked. So this transient evoked otoacoustic emission is used for screening test in neonates. Which type of neonates? The non-ICU babies. If the child is in ICU, by default, there is reduced maturity in the child. So there could be problem in the inner hair cells, there could be problem in the nerve conduction, and this test may not be apt here. There is also one more type which is also called as DP. What is DP? Deepika Padukone? No. Distortion product. So when we talk about distortion product, we are going to test individual frequencies here. So it is specific to frequencies, or in other words, frequency specific. Okay. So how is it going to help us? We know that when there are some conditions like noise-induced hearing loss, or if there is ototoxicity, we know that only certain frequencies, like the higher frequencies, are affected. So to specifically test those frequencies, we are going to use this. So in your NEET exam, if you get a question where they say that a person has come to you, he's been taking aminoglycosides from a long time, he has hearing loss. What are you going to suspect? You might suspect that there is ototoxicity because of increased use of aminoglycosides, and these are vestibular and cochleotoxic. What is the initial investigation that you have to think of? You have to always think about distortion product. Why are you going to think about distortion product? Because it tells that higher frequency is affected. It is frequency specific. Got it? Okay. Now, how are we going to interpret the results? If OAE, or the otoacoustic emission, is present, it means that the outer hair cells, the cochlea and the middle ear, all these structures are normal. If the otoacoustic emission is absent, it says that there is hearing loss seen in this individual, and you have to refer the child further to tympanometry and BERA. Now you might ask me, Mom, there is hearing loss. It says that the patient's hearing is affected. Why do we have to do tympanometry and BERA? It is because this test, otoacoustic emission, is just a screening test. Just with screening test, you can't say that the person's hearing is affected. You always want a confirmatory test. That is one reason. Which of these is going to confirm? BERA is going to confirm the diagnosis. Also remember, if otoacoustic emission is absent, there could be pathology either in the inner ear or in the middle ear. So tympanometry is going to test middle ear, no? So when you do tympanometry and you find out that the middle ear is normal, it says that the pathology is where? In the inner ear. So to differentiate between whether the affected part of the ear is inner or middle, you do tympanometry. Now, there are certain significances of these tests. What is the significance? In adults, it helps us to differentiate between whether the hearing loss is cochlear type or a retrocochlear type. Okay, because this is going to test the function of cochlea. So if this is normal, that means you're going to say that it is a retrocochlear hearing loss. Now, distortion product otoacoustic emission is going to detect ototoxicity, or it is also going to detect noise-induced hearing loss. Why? Because it is going to specifically test individual frequencies. High frequencies affected means ototoxicity or noise-induced hearing loss. In neonates, for screening, we are going to use what? We are going to use transient evoked otoacoustic emission. And when we do this, if there is a problem, we can further send the child for tympanometry or BERA. Okay. Also remember that this screening is done in neonates. Which type of neonates? Only in the non-ICU neonates. If you have to test for an infant or a neonate in ICU, what are you going to do? You have to always do BERA because it is a more specific and a confirmatory test. Okay. So tell me the answer. Which is the best screening test in neonates? Is it otoacoustic emission or BERA? In non-ICU babies, it is going to be otoacoustic emission. In ICU babies, it is going to be BERA. Now, looking into the next investigation, we are going to see the investigations which test the auditory pathway. Okay. So when we talk about auditory pathway, it goes step by step. And there is a very classic mnemonic. And what is that mnemonic that your DINGRA gives you? It is nothing but ecolema. That is E-C-O, ecolema. What is E. coli? It is a bacteria, right? But now it's going to help us learn ENT, okay? So what is E? E stands for 8th cranial nerve. That is nothing but vestibular cochlear nerve, cranial nerve 8. What does C stands for? C stands for the cochlear nucleus, okay? O stands for superior olivary complex. L stands for lateral lemniscus. I stands for inferior colliculus. M stands for medial geniculate body, and the last A stands for the auditory cortex. So how many auditory cortex do we have? We have 2, primary and secondary. Which is primary? Area number 41, 42. Where is it located? Superior temporal gyrus. What is it also called as? Hesh's gyrus. Secondary auditory cortex, area number 22. Okay. So the auditory cortex is the last step. So ecolema. You should always remember that it is not necessary that you form mnemonics for each and every page and each and every topic. But there should be certain mnemonics that is going to keep you confusion free. For example, this auditory pathway is something everybody gets confused. They get confused between, does the lateral lemniscus come first, or the olivary complex comes first, or the inferior colliculus comes first. All sound similar. No, in such places where each and every student tends to get confused, it is always wise to keep a mnemonic. One more area which is very confusing. What is that area? Can you guess? PTA. The different symbols in PTA. If you do not keep some mnemonic to remember that, or if you do not coordinate that, coincide and learn that, you are not going to remember it. And in the last moment when you have 19 subjects to finally answer, no, these should not be the confusing things for you. Okay. Having said that, it is not necessary to keep mnemonic for each and everything. Okay. Then you'll have to put extra efforts in remembering that mnemonic only. Forget the concepts. Okay. Now coming to a condition called as auditory neuropathy. What do you understand by auditory neuropathy? It is nothing but auditory dyssynchrony. It is one of the newly updated concept in your textbooks, okay? So auditory dyssynchrony, it means that it is a condition which affects the neural processing of the auditory stimuli. So you have to remember that the outer hair cells is all normal here, but the neural processing of the sound input is going to be distorted here. All the following must be present in the neonate in order to diagnose auditory neuropathy. So what has to be present? There are 3 things that has to be present. That is, there should be abnormal BERA results or abnormal ABR reflexes or absent ABR reflexes even when you give maximum stimuli. That is how much stimuli? Even when you give around 100 decibel stimuli, there is going to be abnormal ABR reflexes. Also, the outer hair cell functioning is absolutely normal as determined by which test? Otoacoustic emission. So in newborn, which type of otoacoustic emission do you do? Transient evoked or distortion product? Transient evoked. So the otoacoustic emission is going to say that the outer hair cells are absolutely normal. What is the third thing? Third thing is nothing but absent or increased threshold for the stapedial reflex. When all these 3 things are present, then we say that the patient might have some problem in the neural processing of the auditory stimuli, and then we say that the child has auditory neuropathy. Okay. Now coming to the next test. What is the next test? It is nothing but BERA. What is BERA? Brainstem evoked response audiometry. So why do we use this BERA? In order to test the auditory pathway. What is the mnemonic for auditory pathway? Ecolema. Okay. And it is a subjective test or an objective test. It is nothing but an objective test. That is, you are not going to give a signal and say that, can you hear it? Yes, no. You're not going to ask a patient that. You can objectively, by default, see the same results. Okay. Now, there are different graphs, the waves in the graph here. So, the wave 1 and 2, these 2 graph waves, they arise from where? They arise from the 8th cranial nerve. Wave 3, it arises from the cranial nerve nuclei. 4 arises from the superior olivary complex. 5 arises from lateral lemniscus. And wave 6 and 7 arises from the inferior colliculus. This is one important thing that you have to know. How to remember this? Just remember that there is something called as SLI. These three things constitute the last three things, and the first three waves are just from the nucleus and the nerves. So initially from nerve it is going to the nuclei, the signal. Therefore remember that initially you get the nerve, first, second wave, nuclei, that is the third wave, SLI, fourth, fifth, sixth wave. Okay. Now coming to adults, which is the best test in adults for any hearing loss, the best test is BERA. Why BERA is the best test? Because it can confirm you the diagnosis. You can even detect whether it is a cochlear pathology, retrocochlear pathology, and so much more. So it can detect a retrocochlear pathology. Can you name of any retrocochlear condition? For example, acoustic neuroma. It is a neuroma of the acoustic nerve, the 8th cranial nerve. It differentiates between cochlear and the retrocochlear hearing loss. Also, it can detect malingering. What do you understand by malingering? Malingering means that the patient is absolutely normal, his hearing is normal. But he comes to you saying that, doctor, my hearing is affected. Why does he do so? For any monetary benefits. For example, if he is working in a company or if he is working in a factory which says that it is going to compensate so and so amount if the hearing is lost because of the loud noises around him. In order to get that money, he is going to say that his hearing is affected by the loud noise of the machines. But in reality, when you do this test, BERA, it is going to say that whether he is actually lost his hearing or is he just acting. When he is acting, it is called as malingering, falsely projecting that his hearing is gone. Now, which is the best test for acoustic neuroma? We saw that BERA can be a test in acoustic neuroma, but is it a best test? No, it's not the best test. The best test is gadolinium enhanced MRI. This is the best test. Okay. Now, in neonates, when you do otoacoustic emission plus and minus BERA, it is going to confirm the hearing loss in these neonates. It can also screen the NICU babies because, as I told you, in a non-ICU baby, you can always do otoacoustic emission. But the moment you get to know that the neonate is in ICU, always the test becomes BERA. Okay. It can also determine the hearing threshold. To determine the hearing threshold, we should always take help of BERA. Now we look into one more test. This test is nothing but electrocochleography. So as the name suggests, cochleography. So it is going to test what? It is going to test the electrical activity of cochlea. Okay. And it is one of the best tests to tell us about the cochlear activity, especially in the disease called Meniere's disease, which mostly affects the cochlea. This is going to be the best diagnostic test. Okay. So in this, we need to know about three waves. The number one wave is nothing but cochlear microphonic. So what is cochlear microphonic? It tells us about the movement of the outer hair cell. The next wave is nothing but the summating potential. What do you understand by summating potential? It means that the combined activity of both the inner hair cells and the outer hair cells. Summation, sum, addition, right? So both inner hair cell and the outer hair cell functions together. Next, you have action potential. What is action potential? It is nothing but the nerve potential. It is going to tell us about the activity of the auditory nerve, which is the auditory nerve, cranial nerve 8. This is after the neurotransmitter release. After the release of the neurotransmitter, this is going to tell us about the activity of the 8th cranial nerve. Now, normally you have to remember that the action, this SP by AP ratio, that is summation potential by action potential, is always less than 30%, or in other words, less than 0.30. But what happens is that in Meniere's disease, this is going to become more than 30%. If it is more than 30%, it says that it could be probable Meniere's. And if it becomes more than 45%, it says that it is confirmatory for Meniere's. Okay. So you have to remember something. As I told you, SP, summating potential, is the sum of the activity of the inner and outer hair cells. No? So what happens whenever there is Meniere's disease? Because of excess of the sodium, the activity of the inner and outer hair cells substantially increases. So what happens? SP, that is the combined activity of the inner hair cells and outer hair cells, is going to increase. So the numerator increases, whereas the action potential remains same. Action potential measures the functioning of the nerve. In Meniere's, nerve is completely fine, so action potential remains the same. Basic mathematics, we know that whenever the numerator increases and denominator remains same, the ratio is going to increase. Therefore, in Meniere, the ratio is going to increase to more than 0.45%. So, when the ratio becomes this, it is confirmatory of which condition? It becomes confirmatory of Meniere's condition. Now, we are going to look at the protocol for neonatal hearing screening. Okay. Now, there is a simple exercise for all of you. Take your pens out. Do not be lazy. And then you're going to mark all these along with me. So, firstly, whenever there is a neonate, you're going to do first screening test, right? What is that screening test? Nothing but otoacoustic emission. So, when do you do this otoacoustic emission? Ideally, within 2 days after birth. It comes to how many hours? So, within 48 hours, you're going to do this otoacoustic emission. By chance, you have not done otoacoustic emission within 48 hours. So, what is the maximum time up to which this has to be done? That is less than 1 month. Okay. So, the screening test has to be done within 1 month at any cost. Now, which type of otoacoustic emission do you do? Transient evoked or distortion product? You're going to do a transient evoked type of otoacoustic emission. Now, after you do a otoacoustic emission, there could be two results. That is, the otoacoustic emission can be present or the emission could be absent. If it is present, that means the child has passed the test. Now, if the child does not have any risk factors, absolutely normal, healthy child, then what do? You do not do any further screening. You can say that the child is completely fit hearing-wise. Now, if the child has any risk factors, then you suggest to the parents that regular screening and follow-ups are needed. So, this is one side of the story. Now, otoacoustic emission is not present. So, the child has failed the otoacoustic emission test. What do? Do you say that the child is not hearing? He has hearing loss? No, you can't do that. You have to always clean the external auditory canal first. Because during the process of birth, when the child is in womb, there could be meconium or any other fluids that is there in the external auditory canal, because of which you do not get proper result in the test. Therefore, always clean the external auditory canal, and then you have to repeat the test in around a week. In 7 to 10 days, you repeat the test, and now you see whether it is present or absent. If the test is present, then you say that the child has passed the otoacoustic emission. You don't have to do anything further. Now, test is absent. That means the child has failed the otoacoustic emission test. Do you say the child has hearing loss? No. Here also you can't tell the child has hearing loss, because otoacoustic emission is just a screening test. Now you have to refer the child for confirmatory tests. So, what is a confirmatory test that you refer to? It is nothing but tympanometry. So, tympanometry is going to check for the middle ear status. So, 1. If there is a defect in the middle ear, what happens? You have to see whether that defect is a correctable defect or a not correctable defect. If it is a correctable defect, you do something and correct the defect. Problem is solved. Now, you get to know that the defect in the middle ear is not correctable. Then what do? You give hearing aid to the child. Okay, this is one side of the story again. Now, you are checking tympanometry. There is no defect in the middle ear. The middle ear is absolutely normal. So, what does it indicate? It indicates that there is no problem in the middle ear. Where is the problem? Problem is in the inner ear. So, you have to do BERA now. So, when you do BERA, as we all know, BERA is a confirmatory test, right? So, BERA, what is the time by which maximally you can wait and do BERA? It is just 3 months, okay? Within 3 months, you have to finish BERA. And in BERA, if you get to know that it is a cochlear defect, that is, the defect is there in the inner ear, in the organ of Corti, then you have to do hearing aid trial to the baby. At the earliest, by 6 months, you have to give hearing aid trial. If there is no benefit with hearing aid, then by 1 year of age, you plan for a cochlear implant. Now, in the inner ear, you see that everything is normal. There is some problem in the auditory nerve. That is a retrocochlear defect is seen in the child. What do? You can't give a cochlear implant because cochlea is normal. No, nerve is affected. So, you plan for a auditory brainstem implant. It directly stimulates the cochlear nuclei, and you can do the surgery when the child is around 1.5 to 2 years. Now, we should also know one important formula. Okay, More than formula, I can call it a rule. What is that? It is nothing but a 1-3-6 rule. That is, all the hearing screening test has to be done before the child reaches 1 month of age. All the referral tests should be over by the time the child reaches 3 months, like for example, tympanogram or BERA. And by the time child reaches 6 months, all the rehabilitation by hearing aid has to be started. This is the 1-3-6 rule. Now we have seen various tests, we have seen various reflexes. Now we'll finally study about nystagmus. Okay. So what is nystagmus? Nystagmus is nothing but involuntary oscillatory movements of the eye is called as nystagmus, either in the horizontal direction or vertical direction or in torsion, that is the circling movements. So these are going to be the involuntary oscillatory movements of the eyeball. This is nothing but nystagmus. So there are two types of nystagmus that you have to know about. One is peripheral nystagmus, one is central nystagmus. Peripheral nystagmus is seen in conditions of the peripheral system. For example, here, whenever there is any defect in the vestibular system, it comes under the peripheral system. Whereas, if there is any defect in the central systems, the brain, then it is the central nystagmus that you're talking about. Now, there are certain features of differences between both, and we'll look into all of these. So, when we talk about latency, that is, at what period nystagmus appears, there is going to be few seconds of latency, that is around 2 to 20 seconds of latency if it is a peripheral nystagmus, whereas in central nystagmus, there is no latency period. That is, as and when it requires, there is a nystagmus attack. Okay. Now, the duration in peripheral, the duration is limited. That is, it is going to fade away in few seconds. Whereas in central, the duration is not limited. The nystagmus is going to be there for long minutes. Okay. Now, fatigability, that is, whenever you try to elicit nystagmus again and again, that is on repetition, it becomes fatigable. Whereas in a central condition, it is non-fatigable. How many ever times you try to elicit nystagmus, it is going to be present always. It is non-fatigable with repetition. So, the peripheral nystagmus is present in certain head positions only. Now, for example, a person is sleeping, he turns to his right and gets up, he feels that his eye is moving, nystagmus. So, only in certain head positions, we get nystagmus in a peripheral condition. Whereas, in case of central conditions, it is present in multiple positions. Got it? Now, coming to the direction is always going to be fixed. For example, in a peripheral condition, direction always to the right. Whereas, in a central condition, the direction is going to be changing. Different head positions bring in nystagmus in different directions. Got it? Now, coming to vertigo. In a peripheral condition, peripheral meaning which system are we looking at? Vestibular system. Will there be vertigo? Obviously, right? If the vestibular function is disrupted, there is going to be vertigo. So, vertigo is always present and the vertigo is going to be severe. Whereas, in a central condition, occasionally vertigo may be present, and if it is present also, it is just going to be mild vertigo that we are talking about. Now, coming to incidence, around 85% of the vertigo and of the nystagmus that we see are nothing but peripheral, whereas just 10 to 15% of the nystagmus that we see come under central nystagmus. Now, there are two terms that you have to know about. So, what are these terms? So, one is optic fixation. So, what is optic fixation and why are we talking about it here? So, we use a glass called as Fresnel glass in order to bring in optic fixation. So, what is the function of this Fresnel glass? This Fresnel glass has very high power and very high illumination. So, when you make this patient wear this Fresnel glass, because of such high power, the vision becomes blur. So, because his vision is blur, he is not able to fixate his eyes on any target. And that's why the peripheral nystagmus becomes much more prominent and evident. So, it is fixing the eyes so that you can see the peripheral nystagmus better. There is also one more nystagmus that you have to know about. This is nothing but optokinetic nystagmus. And we use Catford drum in order to elicit this optokinetic nystagmus. So what is cat4 drum? It is a drum which has stripes in white and black color, and this drum is continuously rotating. So you ask the patient to sit and look at this drum. So his eyes is going to move along a moving stripe, and as soon as that goes out of his vision, his eyes is going to jerk back to the next moving object. And that time the nystagmus that is elicited is called as optokinetic nystagmus, and this nystagmus localizes the lesion in the parietal lobe. There's also one more thing that you have to know. This is nothing but bithermal caloric test. What do you understand by caloric test? You're going to put in water in the external auditory canal and you're going to see if a nystagmus is elicited or not. You're going to see the direction of the nystagmus, okay? And it's called bithermal because you're going to test with hot water and cold water. Water in two different temperatures are used, hence it is called as bithermal caloric test. So it is going to test which semicircular canal? It is going to test the horizontal or the lateral semicircular canal. Now, quick question. Which is the semicircular canal easily eroded by cholesteatoma? Yes, it is the horizontal semicircular canal. Which is the semicircular canal bulge seen in the medial wall of middle ear? Horizontal semicircular canal. Okay. Now, there is something called as cold air caloric test. So initially we saw that we are using bithermal water to test for nystagmus. Now instead of water we are using air. Why we are using air? In case there is a perforated eardrum. That time we are going to use a tube which is called as Dundas Grant tube in order to transfer cold air into the inner ear, and we are going to see whether there is nystagmus or not. Because if there is perforation in the tympanic membrane, if you put water, it is going to cause infection in the middle ear. Therefore, you are going to use cold air. Okay. Now, the results of this test can be remembered by a mnemonic called as COWS. C-O-W-S. So, how to remember this? So, C, that means if you are using cold water, C for cold, you are using cold water, the nystagmus is towards the opposite side. Okay. Now, you are using warm water. Whenever you are using warm water, the nystagmus is towards the same side. So, how to remember this again? There's an easier way. So, remember warm water is hot water. No, it is for the same side. You see a hot person, you are attracted to the same person. So, this is the mnemonic that will help you remember that whenever hot water is used, the nystagmus is to the same side. And the one more is just opposite to this. Got it? Now we will move our discussion further into learning about fistula test. So when we talk about fistula test, we should know that there is something called as true positive fistula test, false positive fistula test. Also, we have a false negative fistula test. So what is a true positive fistula test? There is a fistula. What is fistula? Nothing but opening. There is a fistula because of which the test is positive. This is called as true positive. Okay, and it is seen whenever there is a fistula on the lateral semicircular canal. Fistula, or you can call it dehiscence. So when there is fistula in the lateral semicircular canal, how does it develop? In conditions of chronic suppurative otitis media, when there is cholesteatoma, it is going to erode the wall of the lateral semicircular canal. There is going to be a labyrinthine fistula that develops. Okay. This labyrinthine fistula is there where? In the lateral semicircular canal. It is also positive in fenestration surgery. What do you understand by fenestration surgery? That is, the footplate of stay-piece is fixed. Whenever the footplate of stay-piece is fixed, you try to create a small fenestra or opening in the lateral semicircular canal for the effective transmission of sound. Even then, because of a hole that is there in the labyrinth, this test becomes positive. Third one, post-stapedectomy surgery or post-stepidotomy. You are creating a fistula. There can be a complications which causes perilymph fistula. Whenever there is perilymph fistula, there is an opening because of which the fistula test becomes positive. Okay. Now we are talking so much about fistula test, no? What do you understand by fistula test? It is nothing but whenever there is fistula. Okay. Whenever you try to change the pressure in the external auditory canal, that is, you increase and decrease the pressure in the external auditory canal using what? Either a Siegel's speculum, or you can also do this by simply pressing the tragus inside and outside. When you do this, you are going to see whether nystagmus develops in the patient or not. What is nystagmus? Involuntary oscillatory movements of the eyeball. If nystagmus develops, it states that there is fistula in the inner ear and the test is positive. Okay. Now, we saw about the true positive fistula test. Now, we'll look into the false positive fistula test. When can there be a fistula test without fistula? That is, it is falsely positive. Understand, no fistula, but the test is positive. It is also called as henna bird sign. What is henna bird sign? That is, we saw it somewhere, right? Where did we see? We saw it in the condition called as Meniere's disease. It was a named sign that we saw in Meniere's disease. Henna bird sign means that with increase in the pressure, there develops vertigo in a patient. Now, what is Tullio's phenomena? With increased noises or increased loud sound, if there is vertigo, it is called as Tullio's phenomena. What is drop attack? Drop attack means when the linear acceleration is affected because of the bulging of the utricle and saccule. Macula is gone, the patient suddenly falls. There is drop attack without loss of consciousness. All these are seen in Meniere's disease. Okay. So, false positive fistula test, it is seen in Meniere's disease. It is seen in superior semicircular canal dehiscence. It is also seen in hypermobile foot plate. Okay. So, these are the three conditions where you see a false positive fistula test. Now, coming to the false negative fistula test, where do you see it? False negative. What do you understand by falsely negative? That is, there is a fistula, but that fistula is covered by something because of which the fistula test is coming to be negative. For example, if there is a large cholesteatoma that is blocking the fistula, or if it is a dead labyrinth or the dead inner ear, whenever you try to change the pressure in the external auditory canal, the vibrations are not transferred into the labyrinth because it is dead, because of which fistula test comes out to be negative. Now we will move our discussion further into VEMP. What is VEMP? Vestibular evoked myogenic potential. What do you understand by this term? It means that because of an action in the vestibule, where is vestibule? In the inner ear, there is going to be myogenic muscle potential that is developed. And which is the muscle that we are testing here? It is nothing but the sternocleidomastoid muscle. So what is the normal reflex pathway that we are looking here? Whenever there is loud sound, it is going to stimulate the saccule, which is there in the inner ear. After stimulating the saccule, the inferior vestibular nerve gets stimulated. It relies in the vestibular nuclei. After relieving in the vestibular nuclei, it further goes and acts on the sternocleidomastoid muscle. How do you know that a myogenic potential is created? Because the sternocleidomastoid muscle relaxes on receiving the input from the inferior vestibular nerve. So, it's going to affect on the same side or in the opposite side. Ipsilateral side of the sternocleidomastoid is going to show us action. Okay. Now, there is one more thing that you have to understand. I always told you that whenever there is nystagmus that you're talking about, it has fast component and slow component. And the fast component is the one that is going to guide you in identifying the side of nystagmus. If the fast component is to the right, you say that it is a right-sided nystagmus. And if the fast component is to the left side, you're going to say that it is a left-sided nystagmus. Now, to understand this, you need to know that the fast component always moves or is towards the hyperactive side. So, how do you know which is hyperactive and which is hypoactive? So, there are a list of conditions that come under hyper and hypoactive, and you have to mug it up. Okay. So, hyperactive conditions are: 1. If there is a fistula in the inner ear, labyrinthine fistula. If there is a superior semicircular canal dehiscence. If there is Meniere's or hypermobile foot plate. So, these 4 conditions are the ones which usually come in your entrance exams, and whenever this is there, you always remember that these are the hyperactive lesions of the labyrinth. Now, coming to hypoactive lesions, hypoactive. One clue to remember here is whenever they talk about hypoactive, always remember that it is a nerve pathology that is in focus. Okay. So, can you name any nerve pathologies? Yes. Infection of nerve, infection of 8th nerve. What is it? Vestibular neuritis. One more condition, acoustic neuroma. These 2 are the hypoactive lesions. These 2 are hypoactive, right? So, which is the direction of nystagmus? It is going to be away from the affected ear. For example, if there is a vestibular neuritis of the left ear, okay, which side is the nystagmus? It is to the right side, because the right side, the normal side, becomes the better side. Okay, it is as simple as saying that imagine there is a normal side, less active side, and there is a more active side. Okay, there are two interpretations that you have to know here. See, if there is less active, which is a better side, the less active is better or normal is better? Normal is better, no? So the nystagmus is towards normal. When we are comparing normal and more active side, which is the best active side, that is a more active side. So the nystagmus is towards the more active side. Okay. Now, there is a condition called as superior semicircular canal dehiscence. What do you understand by this situation? It says that the superior canal, there is dehiscence of the bony wall around it. Now, we remember that this is a one condition in the inner ear where there is conductive hearing loss. Now, superior semicircular canal is in the inner ear. So, if a question comes pertaining to this, you are destined to think that they are talking about neural hearing loss, the sensory neural hearing loss, no? But remember, this is the only exception. You can put star marks here. This is an exception because you have conductive hearing loss. Why conductive hearing loss? Because of the leakage of the sound energy from this dehiscence or opening. Therefore, it is also called as third window syndrome or third window effect. Because of the opening around the semicircular canal, superior semicircular canal, sound escapes. Therefore, it's called third window. Which are the first and second windows? Oval window, round window. Got it? Now, we'll be moving forward and seeing the next topic. In this topic, we'll look at the types of tympanoplasty. So, based on where you keep your graft, tympanoplasty is divided into around 6 types and the classification is called as Woolstein's classification. Okay. So, coming to the type 1 in the Woolstein's classification, this is nothing but meringoplasty. As simple as the word suggests, repair of the tympanic membrane, you keep the graft over the malleus. Okay. Now, coming to type 2, it is also called as meringo-incudopexy. That is, as you can see in the image, the graft is placed over the incus here. Therefore, it is called as meringo-incudopexy. Now, coming to the type 3, it is called as meringostepidopexy. As the word suggests, stepidopexy, right? So, the graft is placed over the stapes. So, this is also called as columella surgery. Okay, this could be a potential question for you in your exam. Meringostepidopexy or columella surgery is type 3 tympanoplasty. Now, moving forward to type 4 tympanoplasty, it is also called as cavum minor. So, what do you understand? If you see the image clearly, you can see that the open window area is completely closed here and we are keeping the round window area open. So, the sound is going through the round window and coming out into one more structure. What is the structure into which the sound is coming? It is like the cave-like structure here. Okay, we are obstructing a path and making it look like a cave where the sound reflects back from the inner ear, and this is called as cavum minor or type 4 tympanoplasty. Now, we have type 5 tympanoplasty. What is type 5 tympanoplasty? It is done whenever the footplate of the staypiece is fixed. You can see here that the footplate of staypiece is fixed, because of which it can't effectively transfer sound. Therefore, you are going to do what? You are going to create an opening or fenestra in a lateral semicircular canal. Because you are creating a fenestration or opening, it is also called as fenestration surgery. But remember, this is obsolete now. We don't do it because whenever you create a fenestra, it becomes an opening. No, it becomes a reason for why the patient will have vertigo. They come to you with lot of vertigo. They cannot tolerate it because of this type of surgery is not done now. You have a final type which is also the most advanced one, which is called as sono inversion, also type 6 tympanoplasty. So normally what happens, sound travels to the oval window and comes to the round window. This is how the normal cycle of sound travels and comes back, no? But here what happens, you are creating an alternate path for the sound. When you create an alternate path for the sound wave to travel, from where does it travel? It comes out through the round window niche. Okay. Therefore, it is called as sono inversion. You are inverting the normal pathway. So, these are the 6 types that you had to know about. Now, coming to mastoidectomy, mastoidectomy is a surgery of the mastoid. You are going to remove the disease, clear out the disease from the mastoid. Okay. So, there is simple cortical mastoidectomy and also radical mastoidectomy. We'll look into depth of it henceforth. Okay. Now, coming to where do we do a simple cortical mastoidectomy? Firstly, tell me what are the other names of simple mastoidectomy? Cortical mastoidectomy. What is the other word? Schwartz mastoidectomy. Where did you also see Schwartz sign? 10% of the people, flamingo pink, where was it seen? It was seen in otosclerosis. This is something that you have to remember. Okay. Now, whenever there is acute otitis media with the reservoir sign, this is an indication for simple cortical mastoidectomy. Reservoir sign means even when you clean the secretions from the external auditory canal and you put an otoscope again, the minute you put it, you can see that the external auditory canal is filled again because this mastoid acts as a storehouse of secretion and it pours out secretions continuously into the ear. Okay. As an initial step to perform endolymphatic sac surgery or whenever you have to do facial nerve decompression, these are the two areas where you do simple cortical mastoidectomy as an initial step and follow it with specific steps of these surgeries. And also, whenever there is acute coalescent or masked mastoiditis, even then you do a simple mastoidectomy. Okay. Now, what are the indications for radical mastoidectomy? Radical mastoidectomy is done when the disease is a little more extensive. When do you do it? Whenever there is a residual cholesteatoma or if there is a glomus tumor or if there is any carcinoma of the middle ear. These are the conditions when you do radical mastoidectomy. Radical, as the name suggests, you're going to remove most of the parts of the middle ear as well as the mastoid in these conditions. Now, there is also a term called as meatoplasty. What do you understand by meatoplasty? You are going to alter the shape of the external auditory canal and the meatus. Why do you do it? Now, when you do a surgery in which you are increasing the size of the mastoid, all the secretions or the products that are there has to drain out through a proper opening. No, there are a lot of secretions, so it needs a bigger channel to drain out. Hence, you are doing something called as meatoplasty. You are going to widen the external auditory canal and the external auditory meatus for proper drainage. And how do you widen the external auditory meatus? It is by removing some part of the conchal cartilage. Conchal cartilage is a elastic cartilage in the ear which gives a lot of support and keeps the opening of external auditory canal to a certain extent. So when you remove it, you are going to widen the external auditory canal opening. And it is mandatory for all the canal wall down surgeries, because in all the canal wall down surgeries, the mastoid is going to be big. So it requires a bigger channel for effective drainage. Also, it is performed in combination with all the canal wall down procedures, like which are the two canal wall down surgeries you know of? Radical as well as modified radical mastoidectomy. So these two mastoidectomies come under which one? They come under canal wall down mastoidectomies. Got it? Now we'll be looking at certain devices which are helping in rehabilitation of hearing. And the number one device that we'll be looking into is nothing but BAHA, bone anchored hearing aid. Firstly, you have to understand why do we use a hearing aid? Why do we fix a hearing aid to the bone? You can directly put it into the ear canal like a microphone and use, no? But instead, why are we using it in the brain? It is in the bone. It is because there is some defect in the development of pinna or the external auditory canal, because of which you cannot place the device in the external auditory canal. This is the number one concept that you have to understand. Okay. Wherever there is microtia, small ear, small canal, wherever there is anotia, that is absent ear, or whenever there is atresia, that is there is a small external auditory canal opening, whenever these conditions are there, or if there is a big ear cavity post-op, that is you do a canal wall down surgery, for example a radical mastoidectomy or a modified radical mastoidectomy, after which for effective drainage you do meatoplasty and you widen the external auditory meatus. Now it is so big. Now if you place a earphone, it is going to fall off, no? Therefore you cannot put a hearing aid in these people. Also, if the ears are discharging, what is the problem here? This ear discharge is going to spoil the hearing aid, as simple as it, because of continuous moisture. Therefore, you can't use hearing aid. If there is a single deaf ear, even then BAHA becomes the treatment of choice. Okay, if there is both the ears are deaf and you get to know that there is a problem in inner ear cochlea, what do? You do cochlear implant. Okay, so this image that you see here is nothing but the image of Baha. So it has 3 parts. The part that you can see here, the black colored thing, is nothing but a speech processor. Now this speech processor is connected by one instrument. The central instrument is called as abutment. Through an abutment, this speech processor is connected to the bone. Okay. The piece that you connect to the bone is called as a fixture. So whenever you connect this instrument to the bone, there develops a process called as osteointegration. That is, the entire machine gets integrated with the osseous system of the bone. That is when it stays there permanently. So this is a question that can come in your exam. What is a process that makes this device stay in your bone? It is the osteointegration that happens. Okay. So whenever there is 8th cranial nerve injury, that is when you use Baha. And Baha, whenever you use, where is the position of Baha? You are going to place it in the lateral recess of the 4th ventricle. Okay. Where do you place it? Lateral recess of the 4th ventricle. So it is going to do what? It is going to replace the auditory nerve. If cochlea was damaged, what you would do? Cochlear implant. Now the nerve is damaged, that's why you are going to use the brainstem implant so that the signals go and stimulate the brainstem directly. Okay. So you also remember that whenever you do this, this is going to stimulate what structure? It is going to stimulate the cochlear nuclei directly. Okay. This is what you have to know. Now coming to the second instrument, it is nothing but cochlear implant. When you talk about cochlear implant, you need to know about the indication. That is the first and foremost thing. Whenever there is severe hearing loss, severe more than 70 decibel hearing loss, to profound. Profound means how much is a hearing loss? That is more than 90 decibel hearing loss. When this is the hearing loss and it is sensory neural type of hearing loss, you use cochlear implant. Some of the examples where you have such a degree of hearing loss: congenital hearing loss, aminoglycoside induced profound hearing loss. Okay. Now the electrode of the implant is placed where? It is placed in the scalar tympani. So you need to know one thing here, that is, there is something called as facial recess. Okay. This is your facial nerve. This is your chorda tympani. Chorda tympani is a branch of facial nerve. And above you have the fossa incudus. Where is the structure located? Can you guess? We saw the anatomy, right? This is seen in the posterior wall of the middle ear cavity. So this triangular area that is there between these 3 structures is nothing but, what is the structure? It is nothing but the facial recess. So through this facial recess, you are going to drill and enter and go reach the round window. So through the round window, you are going to place the electrodes in the scalar tympani, because the round window is going to lead to the scalar tympani. And whatever electrodes that you place here, the signals that are generated is directly going to stimulate the cochlear nerve. Okay, because the nerve is normal here. Whereas in Baha, where did it go and stimulate? It stimulated the cochlear nuclei directly. Now, revise with me. Auditory pathway. E. Colema. 8th nerve. C. Cochlear nuclei. O. Superior olivary complex. L. Lateral lemniscus. I. Inferior colliculus. M. Medial geniculate body. A. Auditory cortex. Okay. You should never forget this. Now, is there an X-ray that will help us to detect the position? Yes, there is an X-ray and it is called as Stenver's view. In Stenver's view, we are going to see the various components of the cochlear implant through the round window. This is what you're supposed to know. Now, when we see the structure of the cochlear implant, there are various components that we have to know about. There are 2 components mainly. First one is the external component. And then we have the internal component. In the external component, we have 3 parts. What are they? Number 1, microphone. So microphone is nothing but a earphone-like device that you put in the external auditory canal. So this microphone is going to receive the sound impulses and it is going to transfer it to the next structure called as a speech processor. That is the second structure in the external component. This speech processor is going to process the sound and convert the sound into digital impulses. And finally, it is going to go to the transmitter, which is the third part, and it is going to finally transmit all these information into the internal component. Okay, so this external component is connected through an external magnet to the internal magnet. So there are two magnets which hold the external and the internal component together. This entire information goes to the internal component. It goes to where? It goes to the receiving antenna, and then it goes to the receiver stimulator. This receiver stimulator converts the digital information into electrical stimuli. This electrical stimuli is going to go and stimulate the cochlear nerve. This is how the cochlear implant device works. Now, we can also see an X-ray here. Now, this is the X-ray showing which view? Stenverse view. So, how do you identify this? You can just see here through the round window, you are seeing the cochlear implant structures. And whenever you see cochlear implant structures, you say that it is Stenverse view. Now, we'll be looking into yet another most important topic in ENT, nothing but cholesteatoma. This is one of the extensive surgeries for any of the ENT surgeon. Okay. Now, let us look into various theories of cholesteatoma development. Firstly, we'll look into the congenital cholesteatoma. Congenital means by birth the patient has cholesteatoma. This is given by which criteria? It is given by Levin's criteria. It is given by Levin's criteria, and what happens here is that there are certain cell rests congenitally present in the middle ear. So, this cell rest starts growing suddenly, and that is why a cholesteatoma forms in the middle ear. So, whenever it is congenital cholesteatoma, it is mostly seen in the anterosuperior quadrant of the tympanic membrane. Okay. Now, coming to the primary acquired in the sense, there is something happening as a primary pathology which leads to the formation of cholesteatoma. It is given by Whitmark's invagination theory. So, what happens is that because of the constant negative pressure that is there in the middle ear, there is retraction of the tympanic membrane. There is formation of the retraction pocket which gives rise to the primary acquired type of cholesteatoma. And where is the retraction pocket commonly seen? It is seen in pars flaccida, or it is seen in the space. Which space? Prusac space. Okay. There is a thing, okay, some people get confused between Haberman's theory and Whitmark's theory. You remember a simple story for it, okay. Now, you take a balloon and remember that the wall of the balloon is nothing but tympanic membrane. So, with matchstick, okay, remember, Mac for matchstick, you take a matchstick and slightly push that tympanic membrane or the balloon wall. What happens? Does a balloon burst? It doesn't burst. It is slightly going to move inside. It is slightly going to retract inside. No? Therefore, Whitmark's theory is for primary retraction pocket, primary cholesteatoma. Got it? Okay. Now, secondary theory. It is called as Haberman's theory, which explains about the secondary cholesteatoma formation. Here what happens? We have a marginal perforation that develops. Marginal perforation meaning that the annulus, the thickened part of the tympanic membrane which rests in the tympanic sulcus, gets eroded. How come it gets eroded? Mostly because of secondary infections. Because of secondary infections, the margin gets eroded, and through the margin, the epithelial cells which are there in the external auditory canal go inside the middle ear and cause development of cholesteatoma. And the most common cause for this is infective, as I told you. The infection is acute necrotizing otitis media, which causes necrosis of the margin of the tympanic membrane. Can you guess the organism? It is nothing but group A beta hemolytic streptococci. This is the major culprit. Okay. How are you going to remember this? Marginal perforation, Haberman's theory. There is a man who is called as Haberman. He is going to create a burrow in the margin and he is going to go through it inside the middle ear. This is how we are going to remember the Haberman's theory. It is for secondary cholesteatoma development. Post-infective etiology. Infection by beta hemolytic streptococci. Where is the marginal perforation seen? Most commonly, it is seen in the posterior superior quadrant of the pars tensa. This is what you have to remember. Now, coming to whenever you do a surgery in the mastoid, surgery involving the middle ear, what is your primary goal? Your primary goal is to give the patient a dry ear, a non-discharging ear, and a hearing ear. So, these becomes the primary goals or the principles of the surgery of clearing disease from the middle ear and the mastoid. Okay. So before you do surgery, you have to do two major investigations. The number one being PTA, or the pure tone audiometry. You do this in order to find out what is the degree of hearing loss, and also it becomes a proof for you, preoperative proof to document hearing loss. And even post surgery, you can see how much improvement is there after the surgery in the hearing of the patient by comparing it with the pre-operative pure tone audiogram. Now, you can also do a high resolution CT of the temporal bone. HRCT can be done, and whenever you do HRCT, it is going to tell you about the extent of the cholesteatoma or extent of the disease, as well as if there is any bony erosions because of cholesteatoma. Now, coming to the types of mastoid surgery, there are two major types of mastoid surgery, okay? The number one is called as intact canal wall surgery, and the number two is called as canal wall down surgery. What do you understand by intact canal wall? It means that the canal wall is not broken. The canal wall is intact. We're talking about which canal wall? You're talking about the posterior wall. Posterior wall of which part of the ear? Middle ear cavity. So as we discussed earlier, middle ear has 6 walls. No? In the 6 walls, the posterior wall is a common wall between the middle ear in the front and mastoid in the back. If you have to reach the middle ear from behind the ear, you're going to drill in the mastoid, break the posterior wall, and then go to the middle ear. So this is the normal pathway. Now, if you're not breaking the entire posterior wall, but creating only a small opening here, then it is called as an intact canal wall surgery. You can do a small opening in the posterior wall, calling it as a posterior tympanotomy, or you can call this as combined approach tympanotomy. So these are the different names for intact canal wall surgery. There is also canal wall down surgery. This means that you are breaking the entire posterior wall so that you can directly access the disease in the middle ear. So there are two types of canal wall down surgery, which are nothing but radical mastoidectomy, and you have one more type which is nothing but modified radical mastoidectomy. Okay. Now coming to the broad classification again in a little more depth. Intact canal wall down. Okay. So intact canal wall, in the sense you're just making a small opening in the posterior canal. Now when do you do that? You do that when the disease extent is very little. When you have minimal disease, you can just make a small opening, go to the middle ear and clear the disease from there. Canal wall is completely broken, canal wall down, when there is extensive disease. Whenever you do intact canal wall surgery, because the opening is very small, intra-op visualization is going to be very less. Whereas in canal wall down, because you have broken the canal wall completely, you have very good intra-op visualization. Now coming to the surgical approach, in the intact canal wall, you are going to approach it by an area called as facial recess. Now, go back and tell me, what is the facial recess area? So it is a triangular area which is bounded by 3 structures. Okay. So you have the facial nerve as a medial landmark. You have a branch of facial nerve called as chorda tympani as a lateral landmark, and you have the fossa incudis, which is the superior landmark. Fossa incudis is formed by the short process of incus. This triangular area surrounded by these 3 structures is nothing but the facial recess area, and through this area you are going and creating a posterior tympanotomy incision. Did we also study facial recess somewhere else? Where was it? It is when you do cochlear implant. Through the facial recess, you are approaching the round window and placing the electrodes in the scalar tympani so that it can stimulate the cochlear nerve. So this way you have to correlate topics in study so that you can remember them for longer amount of days. Okay. Now coming to the surgical approach in canal wall down, you are directly going to break open the entire posterior wall. Coming to chorda tympani, in the intact canal wall, this is going to be preserved, whereas in the canal wall down, this is sacrificed. Coming to healing, in intact canal wall, it is going to be faster, water tolerance is going to be better, cavity problems are less, cleaning requirement is less, and the hearing aid trial is better tolerated, and the recurrence is more. Why is recurrence more? Because you create a very small opening and you go inside the middle ear, no? So, if there is any disease that is there in the scalar tympani, the scalar tympani is what area? It is the hidden area. So if there is disease that is remaining here, it causes recurrence in the cholesteatoma. So these are the features that you have to know in the intact canal wall. Now coming to canal wall down. So as we saw that here the chorda tympani is sacrificed. Hearing, the healing, is it faster or slow? It's going to be slow because the surgery is a little extensive surgery. Water tolerance is going to be very poor. Why is water tolerance poor? Because after you do a canal wall down surgery, for example, a radical or a modified radical surgery, there is a big cavity. And to drain the big cavity, you're going to do meatoplasty and widen the opening of the external auditory meatus. So if this patient, if they go swimming and all, lot of water can enter the cavity and create secondary infections. Therefore, swimming is absolutely contraindicated after canal wall down surgery. Okay. Cavity problems are frequent because lot of wax and lot of debris starts getting collected in the canal wall. Cleaning requirement is very frequent cleaning requirement because of the collection. Somebody has to clear these connections. So they have to frequently on a regular basis visit their ENT. Hearing aid use is poorly tolerated. Why? Same funda again. There is wider external auditory canal and when you place the hearing aid, it just falls off. Okay. And the recurrence rate is less. Why is recurrence less? Because you have removed the entire canal wall and removed lot of disease from the middle ear, because of which it is not going to have any left out cholesteatoma, because of which recurrence is less. Now coming to the two types of canal wall down surgery, we have radical mastoidectomy and we have modified radical mastoidectomy. Now, in both radical and modified radical mastoidectomy, you remember that the mastoid air cells are removed. A quick question, which is the most biggest and the consistent mastoid air cell? Mastoid antrum. And it is at the distance of how many centimeter from the McEwen's triangle? 1.5 centimeter. Okay. Posterior bony wall is removed in both the surgeries. Okay. This is the first common points between both surgery. Now let's look into the differences. Extent of the middle ear structures removed in radical mastoidectomy. We are going to remove very little. Whichever is involved, we are going to remove only that. Okay. Whereas coming to the modified radical mastoidectomy, we are going to remove the damaged ossicles. We are going to remove the damaged mucosa. And we are going to also remove the damaged tympanic membrane. So we are going to remove all these structures here. Okay. In a radical, we are going to remove almost everything. Okay. Nothing is preserved here. Coming to the eustachian tube, the eustachian tube is closed in the radical mastoidectomy, whereas in modified radical, it is kept open. Coming to the middle ear reconstruction, it is not done in case of radical mastoidectomy, whereas in modified radical mastoidectomy, we do middle ear reconstruction. Now coming to indication of radical mastoidectomy, always remember that radical mastoidectomy is a very extensive surgery, okay? So whenever there is any residual infection, the residual cholesteatoma, this is when you do a radical surgery. Also, if there is any cancer of the middle ear, even then you do a radical mastoidectomy. Also, if there is glomus tumor, you do a radical mastoidectomy. Now coming to the modified radical mastoidectomy, you do it in cases of chronic suppurative otitis media with or without complications. Okay. Now coming to meatoplasty. What is meatoplasty? That is nothing but widening of the external auditory canal. In both radical and modified radical mastoidectomy, you are going to do the meatoplasty, so that it gives a proper drainage channel for all the wax and debris that is connected in the big mastoid cavity. Now we'll be looking into two more tests, the head impulse test and the caloric test. Okay. So how do you do a head impulse test and what are you looking at in a head impulse test? It says that some small head movements are done in order to check for the functioning of the vestibular system. Okay. What are you assessing in the head impulse test? You are assessing the vestibulo-ocular reflex. It detects if there is any pathology in the peripheral vestibular system. So, what constitutes the peripheral vestibular system? Either a labyrinthine defect or a vestibular nerve defect of the same side. Okay. So if there are corrective saccades that are developing, these corrective catch-up saccades say that the test is positive. It indicates there is a defective vestibular ocular reflex. Okay. Suggests abnormality in the labryinth or suggests a abnormality in the vestibular nerve. So what do you understand by an abnormal vestibular ocular reflex? Normally what happens is that now as a doctor, you ask the patient to fixate his gaze on your index finger. Now you are going to hold the head of the patient and try to move the head fast to the right and left, asking the patient to fixate his vision on your nose, okay, or on the index finger, anything. Now, you're going to ask the patient, you're going to hold the head of the patient and turn to one side. When you turn this, normally what happens, his eyes are always fixated on your nose or the index finger. But in case the vestibular ocular reflex is defective, that means if there is a pathology in the labryinth or the vestibular nerve, what happens is that the eyes will move along with the head. The eye has moved away from the target and it does small corrective saccades to come back to your stimulus. They come back to your finger or the nose of the examiner. These corrective catch-up saccades say that there is a defective vestibular ocular reflex which comes as positive test, positive head impulse test. Okay. So the head moves with the head moves to the side, the eye also moves with the head, and after the eye moves with the head, it is going to bring in small saccades to come back to the target. This is what you have to know. Now, what is the significance? This is a very simple test. It is an office procedure. You can do it very easily. The stimulus, what is the stimulus? Normal physiological head movements is nothing but the stimulus for this test. And one more benefit is that each semicircular canal can be tested individually. So these are the benefits of this test. It is a very, very simple test. Now coming to some benign tumors of the external auditory canal, you have to know about exostosis and osteoma. And both of these can be very confusing in the image that they give in your exam because they look very similar, right? So this is an image which is showing multiple bony outgrowths. You can see 1, 2. There are multiple outgrowths, no? And as you can see, these outgrowths are very close to the tympanic membrane. This is nothing but a picture of exostosis. And remember, exostosis is also called as surfer's ear. We also saw about a similar condition, right, called as swimmer's ear. Where did we see that? Swimmer's ear. It was in diffuse otitis externa. What was the other name? Tropical ear. What is surfer's ear? It is exostosis. You should not get confused between the two, okay? So, surfer's ear is caused because of repeated exposure to cold water. How are you going to remember that it is surfer's ear? The person goes surfing, lot of cold water enters the ear. So, bilaterally in both the ears, there is going to be small, multiple, sessile, bony outgrowths that are seen. Cold water exposure, no? So the tympanic membrane has to be protected. So in the deep part of the tympanic membrane, deep part of the external auditory meatus, it is where you see these outgrowths. Okay. Coming to osteoma. What is osteoma? This is nothing but a bony outgrowth seen especially in the lateral part of the external auditory canal. Also, this is nothing but a single outgrowth that we are talking about. Single bony outgrowth. If they are multiple, that is mostly the exostosis, and exostosis is there in the deep bony part, whereas osteoma is there in the outer cartilaginous or the outer lateral part of the external auditory canal. So if you can see the image here, this is an image of osteoma. As you can see only a single bony outgrowth that is seen here. This single outgrowth that is seen in the lateral part of the external auditory canal consists of an osteoma. Now we'll be looking into yet another most important topic of ENT, and this is one area where you could expect a potential question in this year's NEET. So what is the topic that we are looking at? We are looking at acoustic neuroma, which is also called as vestibular schwannoma. So this is a tumor of the vestibular nerve, and this is also the most common benign or malignant? Benign CP angle tumor or the benign cerebellopontine angle tumor. So it originates from the nerve, right? Which nerve? As the name suggests, it originates from the vestibular nerve at the internal acoustic meatus. Now let's see how an internal acoustic meatus appears. Okay. So this is the structure of the internal acoustic meatus. So this is the anterior side and this is the posterior side of the internal acoustic meatus. So we have a horizontal line dividing it into upper and lower portion, and in the upper portion we also have another bony prominence which is called as Bill's bar. Now in the anterior part of the Bill's bar we have the facial nerve. Posteriorly we have the superior vestibular nerve. Inferiorly we have the inferior vestibular nerve. And in the down portion anteriorly we also have the cochlear nerve which gives nerve supply to the cochlea. Now one potential question that can come from here. There is a nerve supplying the posterior semicircular canal. Which is that nerve? That is nothing but the cingular nerve. Where does it supply? The posterior semicircular canal. Now the question can be, cingular nerve is a branch of which of the nerves in the internal acoustic meatus? The cingular nerve arises from the inferior vestibular nerve. Now, this acoustic neuroma is a very slow growing tumor which is locally invasive and it is also non-encapsulated in nature. Now coming to the clinical features of acoustic neuroma, number one, there is going to be unilateral. It is always, mostly 90% of cases, it is a unilateral tumor. There is progressive sensory neural hearing loss. So sensory neural hearing loss which is progressive in 1 year. This is one of the earliest presentation of this condition. Then the patient can also have tinnitus. Why tinnitus? Because of the cochlear nerve involvement, because it is there in the internal acoustic meatus. Now we saw that there is facial nerve there, cochlear nerve, vestibular nerve. So when the tumor in the vestibular nerve grows, it can compress the surrounding nerves causing these features. Okay. So vestibular nerve is affected. Do we have vertigo? No, we do not have vertigo because of the slow compensatory mechanism, because of which we do not have vertigo even though vestibular nerve is affected. Now coming to facial numbness and weakness, it occurs because of either involvement of the trigeminal nerve or involvement of the facial nerve. There is also one named sign that you have to know, which is nothing but Hitzelberger's sign. What is Hitzelberger's sign? We already saw this. This is nothing but numbness over the posterior superior part of the external auditory canal. So facial nerve gives supply to the external auditory canal in the posterior superior aspect. There is numbness here because of the involvement of the facial nerve, and the sign is characteristically called as Hitzelberger's sign. Okay. Now coming to the external auditory canal and the pinna nerve supply. We had a mnemonic for it. Now what is a mnemonic? GOBA with 2 extra A's, GOAAA. Now can you name all these nerves which supply the external ear? G for greater auricular, O for lesser occipital, A for auricular temporal, another A, Arnold's. Arnold's is branch of vagus. The another nerve, auricular branch of facial. Okay. Now in young patients, if at all there is bilateral vestibular neuroma, we know that in 90% of the cases it is unilateral. In case there is bilateral vestibular schwannoma, then you have to always suspect the patient could have neurofibromatosis type 2, which is the gene that is associated with neurofibromatosis type 2. It is nothing but Merlin gene mutation, and this is located in chromosome number 22. Now coming to the various investigations. Firstly, let's look into the tuning fork test. So we know that there is sensory neural hearing loss that is seen in these people, and sensory neural hearing loss progressive, one of the earliest presenting feature. Okay. In sensory neural hearing loss, whenever you do a PTA, do you have AB gap, air-bone gap? No, it is there only in conductor. Okay. And in patients who have acoustic neuroma, there are 2 named signs that you have to know about. That is, their speech discrimination score is going to be poor. What do you understand by this? That is, there are certain rhyming words, no? Like for example, pin, tin, rin, sin. Such words cannot be clearly discriminated by these people and they hear all these sounds similarly because their speech discrimination is affected. That is one thing that you have to know because it is a nerve pathology, retrocochlear pathology. Okay. Next, there is something called as rollover phenomena. This rollover phenomena also says that it is a retrocochlear pathology. What do you understand by rollover? So, if you see this graph here, this is the speech intensity, okay, in the x-axis. In the y-axis, we have the speech discrimination score. So, as you increase the sound, initially the patient is going to hear better. But after reaching a level, there is going to be rollover or fall. That is, the patient is no more able to understand things better. This is seen in retrocochlear pathology because of the nerve fatigue that happens. Okay, this is the picture of a rollover phenomena. Then you can do BERA. What is BERA? Brainstem Evoked Response Audiometry. So this is one of the best audiometric tests for acoustic neuroma. Here there is going to be increase in the interpeak latency between wave 1 and 2. Okay, there are two findings of BERA which are most important for acoustic neuroma. One, increased interpeak latency between wave 1 and wave 2. The second, more than 0.2 millisecond latency difference in wave 5 between the ears. So, there is a latency of more than 0.2 millisecond between right and the left ear of the wave 5. Okay. Now, there is also one more test which is a gold standard test. Which is this test? It is nothing but MRI with gadolinium, which is a gold standard test. It is going to show an appearance called as ice cream cone appearance. There is going to be increased enhancement that is seen at the CP angle in the form of ice cream cone. So, ice cream cone indicates that the tumor is there in the CP angle plus the internal acoustic meatus. So, we can see this image here, no? This area that I am marking with orange is nothing but CP angle. This is of one side which is unaffected and this is the affected side. How does the tumor look like? It is looking like a cone with an ice cream, right? Ice cream cone appearance of the which tumor? Acoustic neuroma. Now, when you do a biopsy and send the sample for histopathology, you have two characteristic areas that you get. They are called as Antony A areas and Antony B areas. So, Antony A area means that there is going to be hypercellular area that is seen. So, these areas which has lot of cells which have compact nature of cell arrangement is hypercellular, and there is also Verroque bodies that are seen. What do you understand by Verroque bodies? If you see this image here, I can show you that there are a lot of aligned nuclei. You can see, so many aligned nuclei. So, these aligned nuclei are surrounded by an area of acellular area. So, this is called as Verroque body. There are also Antony B areas which are relatively acellular areas. So, where do you see these areas? In the biopsy. In the histopathology, you are going to see these. Now, the same nerves that we studied initially, we are going to look at into it, okay? Now, if the cochlear nerve is involved, cochlear nerve is which nerve? Cranial nerve 8. So, what features are seen? You see features of tinnitus plus you're going to see sensory neural hearing loss picture, okay? So, sensory neural hearing loss is one of the initial presentation that the patient comes to you with. Vestibular nerve involvement, do you get vertigo? No, you do not get vertigo because of the slow compensation that happens. It's a very slow growing tumor that you're looking at. Seventh nerve is involved. What happens? There is going to be hypoesthesia of the posterior superior part of the EAC, which is called as what sign? Hitzel-Berger sign. Trigeminal nerve is affected. That's the fifth cranial nerve. This is the earliest intracranial nerve to be involved, and when this happens, the corneal reflex becomes distorted or sluggish or even absent in later cases. Abducens nerve, sixth nerve. See, basically this fifth nerve and sixth nerve are at the upper part of the CP angle, okay? And when they get distorted, abducens nerve, there is going to be diplopia that the patient comes to you with. These nerves, where are they located? In the upper pole. Now, 9th, 10th, 11th nerves are there in the lower pole, and these are going to be later involved in cases of acoustic neuroma. Now, whenever there is cerebellar compression as the tumor grows, what happens? There are some features of imbalance, because cerebellum is a structure that maintains balance in a person, no? So it is compressed, causing imbalance. There could be vertigo in these patients, and if the tumor is very big, there could be even coma seen in these people. Now we have seen all the investigations, all the features. How are we going to manage the tumor? If the tumor is less than 1.5 centimeter, that is, it is a very small tumor, or if the patient is an elderly patient with so many other comorbidities, because the tumor is slow growing, you can just wait and watch. You can serially monitor with gadolinium enhanced MRI. If it is between 1.5 to 3 centimeter, what do? You can do a stereotactic radiosurgery, or you can use a gamma knife to debulk the tumor. If it is more than 3 centimeter and it is cystic in nature, then surgical excision becomes the treatment or surgery of choice. Now, in post-op management, because the vestibular nerve that is gone, hearing is gone. So what do you do in post-op? You can do a auditory brainstem implant. So in neurofibromatosis 2 or cochlear nerve loss, auditory brainstem implant becomes one of the major things that you do in order to restore hearing in these people. So where do you place the auditory brainstem implant? It is placed in the lateral recess of the fourth ventricle. Okay, quick question for you. When you place the auditory brainstem implant, what is it going to stimulate? Nerve is gone here, so it stimulates the nuclei. Correct, no? Next, when there is cochlear implant that you place, what is a cochlear implant going to stimulate? Try to remember, it's going to stimulate the nerve because cochlea is damaged but nerve is present. Okay. Now we'll be discussing about yet another topic, which is nothing but glomus tumor. So this glomus tumor is also called as paraganglioma. So this is the most common tumor of the middle ear, and this tumor, you have to remember, it is a non-chromaffin type of tumor, and around 10% of these tumors could be multicentric. And also remember that these tumors are capsulated. Okay. Now coming to the origin, where do these tumors originate from? They originate from the paraganglionic cells. These paraganglionic cells are nothing but the neural crest cells. So there are mainly two types. Those tumors which arise from the jugular bulb from cranial nerve 9 and 10 is called as glomus jugulare. And the tumor which arises from the tympanic plexus, mainly from cranial nerve 9, is called as glomus tympanicum. And you have to remember that glomus tympanicum, which is seen in the middle ear, is the most common type of glomus tumor. Okay, and whenever there is glomus tumor, there are going to be clinical features of tinnitus. What is the type of tinnitus that we see? It is nothing but pulsatile tinnitus. So there is going to be squishing sound which comes in the form of tinnitus. Okay, and then there is going to be conductive hearing loss, because the mass that is there in the middle ear acts as an obstruction for the conduction of sound. Hence the patient complains of conductive hearing loss. There is also something called as Aquino sign, which is very classical of glomus tumor. This is nothing but on compression of the carotid artery, this tinnitus is going to stop. It is nothing but Aquino sign. This Aquino sign is specifically seen in glomus jugulare. We also have another sign which is called as the Brown sign or pulsation sign. What happens here is that on seagulization, that is, whenever you use the Seagull speculum and increase the pressure of the external auditory canal, there is going to be continuous beating in the ear, and then there is going to be blanching that is seen in the area of the tumor. This is nothing but Brown sign or pulsation sign. Initially, there is going to be a lot of pulsation seen. Ultimately, blanching is going to be seen. Coming to the cranial nerve palsies, multiple cranial nerves could be involved. 9, 10, 11, 12 cranial nerves could be involved. Now, on examination with otoscope, you can see a red polypoidal mass in the EAC. So, you can see the image here. No? This is an otoscopic image that is seen. In the lower part, you can see a reddish area here. No? This area is nothing but the area through which we can see the polyp. This sign is called as a rising sign, rising sun, red reflex, or a setting sun shine. Okay. It is because of the increase in the vascularity, and this sign is seen. Now coming to the investigations that we do, we can do PTA. PTA is going to show us a conductive hearing loss because the sound conduction is affected. And you need to know two important things about glomus tympanicum and glomus jugular. One important thing about glomus tympanicum is that near the promontory, whereas promontory in the medial wall of middle ear, you can see a reddish mass that is there adhering to the promontory. And in glomus jugular, whenever you do CT, you are going to see that there is something called as flap sign. That is, there is going to be erosion of the bony wall between the carotid canal and the jugular bulb area. This sign is called as flap sign, and flap sign is very characteristic of glomus jugular. You're not going to see flap sign in glomus tympanicum. Whenever there is a ear polyp, always note that you should never avulse the ear polyp. Okay, if you avulse the ear polyp, it is going to cause torrential hemorrhage. Hence, the ear polyp should never be avulsed. Now, coming to the staging is called as fish staging, and this is a CECT based staging system. So, there are different types. Okay, you're going to stage it as type A, B, C, and D. Type A, it is spread only in the middle ear. Type B, it also extends to the mastoid. Type C, it goes to the inner ear. It is called as either labyrinthine and infralabyrinthine extension. Here, this type C is further divided into C1, C2 and C3. So, C1 and C2 are the vertical extension. If it is limited vertical extension, it becomes C1. If it is extensive vertical extension, it becomes C2. And it is C3 if the horizontal carotid canal is involved, then it becomes C3. Type D is when there is intracranial extension. If the extension is less than 2 cm, it becomes D1. If it is more than 2 cm, it becomes D2. Now, coming to the management of the tumor, initially before we do the surgery, we have to get a preoperative investigation done. That is, we are going to check the level of urinary vanillin mandelic acid. This is a very important investigation, and you have to always remember this whenever a question about glomus is asked. And as I told you, it is a very slowly growing tumor, locally invasive tumor, and it is, if the tumor is seen in an elderly who also has a lot of comorbidities, you can always wait and watch because the tumor is extremely slow growing. Now, who is fit for surgery? If the tumor is less than 3 cm, then you're going to do a stereotactic radiosurgery, or you're going to use gamma knife for the surgery. If the tumor is more than 3 cm, then a surgical excision, complete surgical excision can be done after pre-operative embolization. Okay? Yes. Now we'll be looking into yet another favorite topic of all the examiners, and can you guess the topic? Nothing but facial nerve. In facial nerve, the anatomical course of facial nerve is one of the very important topics that you have to know, and we will look into depth of this topic. Okay. Initially, you have to remember that the facial nuclei is there in pons. Okay. So, the nuclear part of the facial nerve starts in pons. The facial nerve motor nuclei is going to take a turn around the cranial nerve 6 nuclei. Which one? Abducens nerve. And then the rest of the course is nothing but the infranuclear course of the facial nerve. So, the facial nerve goes and enters the internal acoustic meatus. This is where it is called as the meatal part of the facial nerve, or the meatal segment of the facial nerve. So, in the internal acoustic meatus, facial nerve lies along with one more nerve, which is that 8th nerve, okay, vestibular cochlear nerve. So, from the meatal segment, it is going to go into giving the second segment, which is nothing but the labyrinthine or the geniculate part. It is called as geniculate part because this is where we can find the geniculate ganglion of the facial nerve. And this is also the part where we get the first bend of the facial nerve, or the first genu of the facial nerve. And from this part, that is from the labyrinthine segment, we also get one of the branches, the most important branch of the facial nerve, which is that it is nothing but the greater petrosal nerve. So, greater petrosal nerve supplies the lacrimal gland, it supplies the palate, and also it supplies the nasal glands. Okay, so whenever there is any problem with the greater petrosal nerve, there is going to be reduction in the secretions of lacrimal gland, palate as well as nasal secretions. Okay, and there is also a test to detect how much secretions is happening from the lacrimal gland. What is the test? The test is called a Schirmer's test. You're going to take a Schirmer's strip, fold the end and place it in the lower palpebral fissure, and then you're going to wait for 5 minutes, keep the eyes closed and then measure the wetting that happens. So whenever there is dry eye, there is going to be reduction in the wetting. Okay. Next, coming to the third segment, it is nothing but the tympanic or the horizontal segment. This is where we have the second bend of the facial nerve, the second genu. Okay. And this is also the area where the facial nerve is in the medial wall of the middle ear under the lateral semicircular canal bulge. So from here, we get another branch of facial nerve, nothing but nerve to stapes. Whenever there is any problem at this level, the stapedial reflex is going to be absent. So if stapedial reflex is absent, the patient can hear abnormal sounds while chewing. His own sounds are going to be exaggerated and heard louder if the stapes is not doing its function well. Okay, the stapedial muscle. Now, coming to the next segment, it is nothing but the mastoid or the vertical segment. This is a segment which can be most commonly injured during surgeries of the mastoid, and this is a segment where chorda tympani nerve is given off. So in the middle ear, where can you find the segment? In the posterior wall, you can find this segment. Okay. So the chorda tympani brings taste sensation from the anterior two-thirds of the tongue, and also it gives secretomotor fibers to the two salivary glands. Which salivary glands? Submandibular and sublingual salivary glands. Next, after this, it goes through the stylomastoid foramen, and the course of the facial nerve after this is nothing but the extracranial course of the facial nerve. It goes out of the cranium through the stylomastoid foramen. Now, here it gives certain branches. One is the posterior auricular branch. It goes behind the ear, posterior auricular branch. Next, you have the branch to the digastric muscle. Then you also have branch to the stylohyoid muscle. After which, it gives terminal branches in the face, and these branches supply the facial muscles. So what are the 5 terminal branches? They are called as pes anserinus because they look like the geese feet. So the 5 branches are the temporal branch, zygomatic branch, buccal branch, marginal mandibular branch, and last is the cervical branch. So this is what you had to know about the facial nerve. Okay, there are 2-3 important things that you have to know here. That is, in case there is any lesion in the facial nerve above the first genu. Okay, so you know that all the important branches, for example, the greater petrosal nerve, nerve to stapedius, all these are given after the first genu, right? So if there is a lesion in the first genu, all these nerves are affected. So in the question, they're not going to tell you that these nerves are affected, but instead they're going to tell you the patient comes with dry eye, and patient can hear excessive noise while chewing, while talking. It gives a clue saying that both the nerves are gone. Now, there is another question which says that the patient comes to you, his tearing is all normal, nasal secretions normal, palatal secretions normal, but he hears excessive sound when he eats. So where is the level of injury? It is at the level of second genu and beyond, because the first nerve, that is the greater petrosal nerve, is spared here. So looking at the clinical features that the examiner has given you, you should be able to locate where is the injury in the facial nerve course. Okay. Now coming to the segments, what are the different segments that I told you about? The first segment is a meatal segment. Next we have the labyrinthine segment, which is the narrowest segment. It is also the shortest segment, and it is also the segment which is most commonly affected by the viral infections. Next, we have the third segment, which is the tympanic or the horizontal segment, and this is a segment which is commonly involved in dehiscence. Okay. Next, we have the fourth segment, which is mastoid or vertical, most commonly damaged during mastoid surgeries. So this is what you had to know about the different segments of facial nerve. Now we'll be looking at one more important topic. You can say that every alternate year a definite question comes from this topic, and the topic is nothing but Bell's palsy. Bell's palsy is nothing but a facial nerve palsy. Okay, it is an acute onset lower motor neuron type of facial palsy, and the nerve affected is nothing but cranial nerve 7 or the facial nerve. If you can look at the image here, you can see that there is going to be one-sided, that is contralateral lower half of the face is most commonly affected, which is a classical feature of lower motor neuron palsy. There is going to be deviation in the angle of mouth, there is going to be epiphora, and there is going to be absent wrinkling, there is going to be difficulty in the closing of the eyelids. So all these features are going to be seen, okay? And it is mostly idiopathic. We do not know the exact cause of a facial nerve palsy, but most commonly it is the viral etiology that we look for. And which virus are we talking about? It is nothing but herpes simplex virus type 1. Okay, so what are the clinical features? As I told you, the wrinkling on the face is going to be lost. There is going to be wide palpebral fissures, and there is going to be epiphora, increase in the watering from the eyes, absence in the nasolabial fold. This fold is going to be absent. There is also going to be drooping of the angle of mouth. So what is the treatment? If the patient presents to you in less than 72 hours, you can always give antivirals. Antivirals in the form of acyclovir can be given to the patient. Okay. You can also treat the patient with high dose of steroids. By high dose, how much steroids are we giving? 1 milligram per kg body weight of person can be given. If there is a response, then you can give steroids for 5 days and then you are going to taper it in another 5 days. But in case there is no response, you have to give steroids for 10 days and then taper in another 5 days. Okay. Now, there is also one more condition that you can see in the image here, which is called as Melkersson-Rosenthal syndrome. So, how are you going to get a question in your exam? They say to you that a person has come to you with facial nerve palsy features like that of deviation in angle of mouth, epiphora, loss of wrinkles, absence in nasolabial fold with swelling of the lips. Okay, you can see in the first image, no? You can see swelling of the lips, and also in the second image it is showing fissuring of the tongue. And then the question would be, what type of lesion or what is a condition that you are looking at? You all might think it is facial nerve palsy. That is right. But because they've given these two additional features, which are nothing but very characteristic of a condition called as Melkersson-Rosenthal syndrome, your answer becomes Melkersson-Rosenthal syndrome. Okay. Now, sometimes what happens whenever there is damage to facial nerve, whenever it starts to regenerate its fibers, it is going to cause aberrant regeneration. That is when a condition called as crocodile tears happen. So, crocodile tears, also called as synkinesis, it develops because of the aberrant regeneration of the facial nerve. So, crocodile tears, as you all know, false tears. So, what happens here? There is something called as gustatory lacrimation that happens whenever the patient is eating. Now, for example, the person named XYZ has gone to a restaurant with his friend. He is trying to eat, but then he is crying. His friend thinks that the biryani is so tasty that the person is crying. But in actual, it is not the biryani that is making him cry, but it is this condition of aberrant regeneration of facial nerve that is making him cry. Okay. We also have one more condition called as gustatory sweating. Gustatory sweating is also called as Fraze syndrome. So, this happens post parotid surgery because of damage to the auriculotemporal nerve. This is also one important question for you guys. So, what happens whenever there is parotid surgery? There is damage to the auriculotemporal nerve, and then when it tries to regenerate, it is going to join with certain sympathetic nerves which supply the sweat glands of the parotid. And when this happens, whenever the patient is trying to eat food, gustation, there is going to be sweating in the parotid region. It is such an embarrassing moment for the patient because he is just trying to eat his food peacefully, but he is not able to eat peacefully because the entire face is sweating and red. Okay, this is nothing but Fraze syndrome. Now we saw about the course of the facial nerve, right? We need to know that whenever there is damage anywhere in the course of the facial nerve, it could be either a upper motor neuron type of disease or it could be a lower motor neuron type of disease. So, what is the difference among both the diseases? We'll be looking at it, okay? Now, whenever we talk about the UMN lesion or the upper motor neuron type of lesion, where is the lesion located? It could be either in the motor cortex or it could be anywhere between the connection from the motor cortex to the facial nucleus. Where is the facial nucleus located? Which part of the brainstem? It is located in pons. Okay. Now, when we talk about the lower motor neuron type of disease, here the disease is somewhere in the facial nucleus or anywhere along the course of the cranial nerve 7 itself. Now, coming to the affected side, whenever there is upper motor neuron disease, always the contralateral face is affected. Also, what are the muscles involved? Only the lower muscles of facial expression is involved here. But when we talk about the lower motor neuron disease, it is the ipsilateral side of face that is affected. And remember, both the upper and the lower muscles of facial expression is involved here. Now, you might ask me, in upper motor type of lesion, why only the contralateral lower part is affected? Why forehead is not affected or upper part is not affected? It is because of the bilateral innervation that is seen. Therefore, the forehead is spared. Whereas in lower motor neuron type of disease, the forehead is affected. There can be features like loss of wrinkling that is seen in the forehead. Now, coming to the other symptoms, what are the other symptoms? In the upper motor neuron type of disease, the symptoms could be variable and it depends on the size of the lesion. Whereas in the lower motor type of lesion, I said both upper and lower face is affected. No? So, there could be incomplete eye closure because the eye muscles are affected, because eye is not getting closed and it is constantly exposed outside. The patient experiences dry eyes and corneal ulceration. The patient can also have hyperacusis, that is, I said along the course of facial nerve, anywhere there could be damage, no? So, if the damage is around the area of second genu where the nerve of stapedius is affected, the patient can hear his own sounds extremely loud, which is called as hyperacusis, because the main function of stapes is to reduce the sound. And also there can be loss of taste sensation to the anterior tongue whenever the chorda tympani is affected. This can be seen. Now, coming to the different signs in ENT which are named with G. So, this is one of the confusing aspect, okay. So, many students get confused whether Gressinger or Gradinigo or Grisel or Guerin, what are these? So, here we have combined all these four so that you do not get confused in your exams, okay. Now, Gressinger. Gressinger means there is going to be edema plus tenderness in the posterior aspect of the mastoid. So, you can see the picture here, no? There is edema and tenderness. Now, if this reddish thing is fully there around the mastoid, then it is called as battle sign. If there is battle sign, it indicates that there is a fracture of the middle cranial fossa. Okay. Now, there is one more sign called as Gradinigo sign. Gradinigo sign is seen in petrositis. So, petrositis is an extracranial complication of CSOM, chronic suppurative otitis media, and when we have petrositis, it is a triad of three things. One, there is going to be deep retroorbital pain. Behind the eyes, these patients have pain because of cranial nerve 5 involvement. There is going to be diplopia or the double vision. Why there is diplopia? Because of cranial nerve 6 involvement. There is also ear discharge, classic of CSOM. Now, coming to the next syndrome, which is nothing but Grisel syndrome. That is nothing but the atlantoaxial subluxation that happens. That is the C1, C2 vertebra is going to be affected. And when are we going to see this? We are going to see this whenever there is any surgery in the Rose's position. Rose's position, can you think of any surgery? What are the surgeries? Yes, right. You're thinking it right. You do the adenoid surgery in this position, tonsil surgery in this position. So, when you do the surgery, what happens is that whenever you're trying to cure the adenoid, if there is increase in the extension at the level of C1, C2, because of hyperextension, there could be atlantoaxial joint subluxation, because of which the patient can have Grisel syndrome. Next, there is also a sign called as Guerin sign. What is Guerin sign? Because of the damage to the greater palatine artery. Where is the greater palatine artery? It is there in your palate. Whenever this artery, it is one of the major supply to the palate, and whenever this artery gets damaged, for example, in a Lefort type of facial fracture. So there are 3 types of Lefort fractures. We'll be studying more about it later. So whenever this artery, greater palatal artery, is damaged, there could be large hematoma seen in palate, which is called as Guerin sign. Now a quick question to you. I told that Gressinger sign there is going to be edema and tenderness in the mastoid area, no? In Gressinger sign, which is the artery that is going to be affected? Can you name it? Yes, it is the mastoid emissary artery or vein. Yes, vein is going to be affected here. There is thrombus formation in the mastoid emissary vein.